Actually, you mean to say first trimester the TSH was more than 25?
Say 25 and you started.
And you have started the dose and you have adjusted the dose over the first 3 to around 20 weeks. Correct. Then after, when you discharge, you have the liberty to reduce the dose by 25%.
If I can have the permission to take one more question. So just that, we are talking about trimester specific here, but all this starts off, as we know, the neurodevelopment starts off even much before a patient misses her periods and comes to us with a positive result. So the periconception is very important. So what would be your suggestion for during the when a person is planning for a spontaneous, natural conception, and if her TSH is more than 4, antibody negative, would you advise her?
Planning pregnancy.
Periconception. Yeah.
Negative and TSH.
Negative antibody. TSH more. She's planning for a spontaneous natural conception. TSH more than 4, antibody negative. Do we start her?
No,
periconception.
All this while I was batting for against it.
Yeah. No, again, both of you.
I agree. Yeah. But when in that context, when she conceives, you should repeat the test.
No, that is the booking visit would be done. So because much of the neuroendocrine development happens much before she misses the periods. In the 2 weeks periconception, when she comes with me, she's 3 weeks post a pregnancy. So that time most of the development of neurodevelopment has already started. So where we debate there more than 4.
If you are starting, then as per the 80 or 2000 guidelines, you are doing it on a very, very slippery base.
Recommendation. Done. Thank you, sir.
Thank you. Enjoyed your presentation. Just a thought to share. Postpartum, if it is a gestational hypothyroidism and you're discontinuing the thyroxine just after delivery, maybe we have to wait for the pregnancy changes to sort of regress, and till then they might need that dose of thyroxine, and it might adversely affect the breastfeeding, though there is no data. It is just a thought. Maybe we have to discontinue probably after 6 weeks and then recheck it after 4 to 6 weeks is one thought. The other thing is, if we started treating women between 2.5 and 4 in pregnancy, I think we would be treating 1 in 3 women in our population, because we had done an audit and it did show that if we treated between 2.5 and 4, we would be treating 1 in 3 women in pregnancy.
I just add.
Yeah.
That is exactly what my point was, madam.
Yes.
That means you are
unnecessarily treating.
Any disease which has got, you are declaring that a disease in a particular society is 33%.
Yes.
Then you have something, I think your stats are something wrong.
Absolutely.
Or your definition is wrong.
Yes. Yeah. Maybe we have
that means, that implies that you are over. If you decide to treat every Tom, Dick and Harry having TSH more than 2.5, 4, it is rest assured that you are over treating the community.
That's right.
If you over treat, I have already shown the adverse outcomes which may come.
And that needs to be highlighted.
Yeah. And maybe we will have to consider the Tamil Nadu study a bit more seriously.
Yes, yes.
I feel.
And
thank you.
Dr. Subramaniam Kannan and Sriram said, the TSH can be as high as 5 to 6. That is published in 2021. In Indian context, with the kind of lab values that we are doing, every Tom, Dick and Harry can have a lab. Nobody is going to check on what you are doing, what method you are using.
No standardization.
Whether you are drawing your standard, this one, how many times you are running the control solution, nothing. True. Actually, in Trivandrum, there are 400 labs. 3 labs have the accreditation. 3 out of 400.
So one rejoinder to her question, keeping postpartum depression in mind, don't you think we should stop the thyroid medication 2 weeks or 3 weeks after delivery?
Antithyroid or thyroxine?
I mean thyroid medication. We should wait for 2 to 3 weeks, keeping postpartum depression.
Before stopping the medication.
Yes, yes.
I think your point is well taken, even though we don't have any body of evidence to suggest that.
Yeah.
Thank you, speakers, for this wonderful session. It was really enlightening. And as you can see, the debate is on. Thank you, one and all.
Thanks to the chairperson and to the speakers for making it very lively. I request you all to collect your token of appreciation from our organizers' side. So there's a small branding wall just right here. So please collect your mementos, and we'll proceed with the inauguration. So I'll call on the dais Dr. Pushpa Lengade. Madam is the president of IMA South Bangalore. So this meeting will not be possible without collaboration with IMA South Bangalore. So they've helped us reach out to a lot of doctors, and the strength of the meeting actually comes from IMA South Bangalore. Ma'am, please take the dais. And I request Dr. Ganapati Bantwal. So he's the senior most endocrinologist in Bangalore, and and for me he's the senior most endocrinologist because he's the first endocrinologist whom I ever met. Actually, he was my consultant when I was an intern. So I worked with sir also in the past. Around a decade ago, I was working with him. So welcome, sir. And I'll call on stage Dr. KVS Harikumar also. Dr. Hari. Are we going to play the song now, or? So we'll play the song now. There is a small, Karnataka anthem. We'll play that for a minute. So, thank everyone for making this big success. So we'll have a lighting of the lamp followed by Dr. Pushpa, then Dr. Ganapati, and vote of thanks will be by Dr. KVS Harikumar. Thank you.
ಹಚ್ಚೇವು ಕನ್ನಡದ ದೀಪ, ಹಚ್ಚೇವು ಕನ್ನಡದ ದೀಪ, ಕರುನಾಡ ದೀಪ, ಸಿರಿನುಡಿಯ ದೀಪ, ಒಲವೆತ್ತಿ ತೋರುವ ದೀಪ, ಹಚ್ಚೇವು ಕನ್ನಡದ ದೀಪ, ಹಚ್ಚೇವು ಕನ್ನಡದ ದೀಪ. ಬಹುದಿನಗಳಿಂದ ಮೈಮರೆವೆಯಿಂದ ಕೂಡಿರುವ ಕೊಳೆಯ ಕೊಚ್ಚೇವು, ಎಲ್ಲೆಲ್ಲಿ ಕನ್ನಡದ ಕಂಪು ಸೂಸಲು ಅಲ್ಲಲ್ಲಿ ಕರ್ಣ ಚಾಚೇವು. ಬಹುದಿನಗಳಿಂದ ಮೈಮರೆವೆಯಿಂದ ಕೂಡಿರುವ ಕೊಳೆಯ ಕೊಚ್ಚೇವು, ಎಲ್ಲೆಲ್ಲಿ ಕನ್ನಡದ ಕಂಪು ಸೂಸಲು ಅಲ್ಲಲ್ಲಿ ಕರ್ಣ ಚಾಚೇವು. ನಡುನಾಡೇ ಇರಲಿ ಗಡಿನಾಡೇ ಇರಲಿ ಕನ್ನಡದ ಕಳೆಯ ಕೆಚ್ಚೇವು, ನಡುನಾಡೇ ಇರಲಿ ಗಡಿನಾಡೇ ಇರಲಿ ಕನ್ನಡದ ಕಳೆಯ ಕೆಚ್ಚೇವು. ಮರೆತೇವು ಮರೆವ ತೆರೆದೇವು ಮನವ, ಎಳೆದೇವು ಒಲವ ಹಿಡಿ ನೆನಪ, ನರ ನರವನೆಲ್ಲ ಹುರಿಗೊಳಿಸಿ ಹೊಸೆದು ಹಚ್ಚೇವು ಕನ್ನಡದ ದೀಪ, ಹಚ್ಚೇವು ಕನ್ನಡದ ದೀಪ, ಹಚ್ಚೇವು ಕನ್ನಡದ ದೀಪ. ಕಲ್ಪನೆಯ ಕಣ್ಣು ಹರಿವನ ಕಸಾಲು ದೀಪಗಳ ಬೆಳಕ ಬೀರೆ.
Hello. Good morning all. First of all, let me congratulate all of you, as all of you have gathered here to share your knowledge, to update about your newer advances and discuss with each other about your opinions for the betterment of humankind. In spite of online CMAs, webinar, workshops, you have gathered here, nothing like in-person meeting. And on behalf of IMA Bangalore South, I congratulate and happy to support Dr. Anantram and magnacode team for successfully conducting CMEs every time. Thank you and all the best to all.
So good morning all. It's been a pleasure to be a part of Magnacode CME update in association with the IMA. Once again, I would like to thank and congratulate Dr. Raman for doing a wonderful job. Single-handedly, I think he's done the scientific sessions. I was just going through the topic. The topics are very interesting. I mean, you saw the amount of discussion which happened in the just before the inauguration. So it's all the common garden types, what we see in day-to-day practice, how do you fine-tune it, and not only on thyroid disorders, you are actually going to see a lot on reproductive endocrinology, vitamin D, the usual one, diabetes also. The only thing which I didn't find probably was calcium disorders, though you have vitamin D, bone osteoporosis, everything is there. But then all topics will be dealt by stalwarts in the field of endocrinology. So I think you'll have a good academic feast. Today, the whole day you have on endocrinology. So with these words, I would once again thank Magnacode and team Raman for the CME. Thanks, Vanana.
Good morning, everybody, and thanks to the first the delegates, second to all the faculty, and third and most important the IMA team, and thanks to Professor Ganpati sir for chairing and coming as a chief guest. And it's a pleasure to be part of this and giving a vote of thanks. We thank each one of you who have spared their valuable time on a Sunday to look at maybe enriching the knowledge in the practice what we are looking in some of the conditions on day-to-day basis. And I thank everybody on behalf of Dr. Raman, and special thanks to the pharma colleagues who have always supported the Magnacode endeavors across the cities. And without wasting more time, we will continue the academic sessions. Thank you all. Thank you, sir.
Thanks to the dignitaries for gracing the occasion. I call Dr. Ganapati Bantwal to give the next session. We'll move without any interruption. In the chair will be Dr. Vimal and Dr. Prithvi.
Next.
I think you can start, sir. You need no introduction.
Yeah, thank you. Thank you, Raman, for the invite. Yeah. So in the next maybe 15 minutes, I'll speak on long-term cardiovascular outcomes of sitagliptin and other gliptins in patients with diabetes. This is the agenda of my talk. Review the evidence on clinical trials of cardiovascular outcomes with anti-hyperglycemic agents. Why do you require these trials after all? So what is the need for that? Review the cardiovascular safety with glucose-lowering agents. Analyze positive CV outcomes found in trials designed to prove safety and validity. Discuss the endpoints and discuss why is this important? All patients with diabetes, the most common cause of mortality is cardiovascular disease. So you can see here, at least 55% die because of heart disease, 10% cerebrovascular disease. Because of diabetes per se, it's around 13%, and then of course others are there. So now why do you want this cardiovascular trials? What is the reason? So in 2007, a publication came in the New England Journal by Steve Nissen. Till such time, you use any glucose lowering agent, we thought invariably it's going to help for bringing down cardiovascular outcomes. But then this study came from Steve Nissen, And he told no, there was a 43% increased risk of mortality when they actually used these molecules, especially rosiglitazone. So that changed the scenario. And after that, so this was the one. You can see here, they looked into the myocardial infarction outcome, small trials combined, not much significance, though a trend was there. The DREAM, ADOPT, nothing changed. But when you combined all the trials, there was a 43% increase in the risk of myocardial infarction. And if you take death from cardiovascular cause, it narrowly missed that outcome. So after this, actually a change came, and the FDA told there is a requirement for all diabetic agents. It's not necessary that you must only bring down the HbA1c. Now it's necessary also to prove cardiovascular safety. So this was the 2008 they came. So what they told was the CV risk assessment on, you do a phase 1, phase 2, phase 3 trials. So the CV risk assessment on phase 2-3 data for all marketed and pipeline anti-diabetic treatment requisites, you require to have upper bound of two-sided 95% confidence interval for estimated risk. So if it is more than 1.8, the data are inadequate to support approval and you should do a safety trial. If it is between 1.3 to 1.8, you still have a potential for harm, CV harm. So for that, what they told was an adequately powered and designed post-marketing trial is necessary, and then you must show that it is less than 1.3. And any trial which had a confidence interval less than 1.3, it said it was a safe molecule. So that's how it came. So the same thing repeated here. So then how do you identify? Because these are all very expensive trials. So what they told was you should focus on high-risk populations, including those with advanced disease, elderly, and those with renal impairment. And the duration of this should be at least 2 years of CV safety data. And the endpoint was a prospective independent adjudication of CV events in phase 2 and 3 studies must also be performed, including most important cardiovascular events. So you can see from 2008 onwards, all the trials required that. So you had the VIDT, the Origin, the Saver-TIMI, TCOS, ELIXA, all the trials which came after that. I have actually done this. So these are some of the trials which are there. So DPP4 classes, a lot of them came, the GLP-1, the SGLT2, and also insulin also they actually asked. You had for the degludec, there was a trial known as a DEVOTE, and they found that it was non-inferior. That means it was neutral. So I will just touch on the DPP4 inhibitors. So you have the 4 major ones, the sitagliptin, the Saxa, the alogliptin, linagliptin. And for sitagliptin, you have the TCOS, the saxagliptin, the Saver-TIMI, alogliptin, the Examine, and the linagliptin, the Carmelina and the Carolina trial. Now coming to TCOS, that is a trial evaluating cardiovascular outcomes with sitagliptin. So you can see here, the primary composite endpoint was neutral, you can say. Secondary endpoint, whatever you take was neutral. So it was non-inferior, of course not superior. So that means to say this drug it did not produce excess harm when compared to that of placebo. If you take individual outcomes, so if you take CV death, or if you take hospitalization for unstable angina, 10% trend was there, of course did not reach significance. Fatal or non-fatal MI, fatal or not fatal stroke, death for any cause, etc. All were neutral. So now you can say that this drug can be used. It does not produce excess cardiovascular risk. So this is the same thing, clinical outcome. Now then came another trial, the Examine trial. This was with alogliptin, clinical outcomes. So here also you can see the primary composite endpoint. That is a 3-point MACE, 0.96. So once again telling that it is neutral. But then another important finding was they found that there was a slight increase in the risk of hospitalization for heart failure, which did not reach statistical significance. But then the patient recruited were within 3 months of a cardiovascular outcome. So it was a very bold study. We were actually a part of that trial also, we could hardly recruit because the patients were not willing for using this drug actually. So if you take the mortality, the hazard ratio was 0.88, trend towards benefit was there. Of course, only thing was the hospitalization for heart failure, slight increase, but did not reach statistical significance. So Saver-Timi was for, this is for saxagliptin. So once again, you can take the clinical outcomes, primary composite endpoint, the secondary composite endpoint, death from any cause or CV death was once again neutral. The one thing you can observe here clearly is hospitalization for heart failure. There was an increase in by 27%. So among the gliptins, this drug, there was increased risk of hospitalization, and this reached actually statistical significance also. And then this was for linagliptin, the Carmelina and the Carolina trial. So once again, the same primary endpoint, CV death, non-fatal MI, non-fatal stroke, and the secondary endpoint being sustained eGFR decline by more than 40%, progression to end-stage kidney disease, or death due to kidney disease. So linagliptin, once again, the 3-point MACE, non-inferior, so telling that this can be this drug is safe, you can actually use it, it does not produce more harm. Time to secondary kidney outcomes, once again, it was neutral, you can say it did not produce any problems. Carolina, here they compared linagliptin with glimepiride in patients with type 2 diabetes. So here the linagliptin met its primary endpoint defined as a non-inferiority versus glimepiride in the time to first occurrence of CV events. CV events include death, non-fatal MI, or non-fatal stroke. So the overall safety was actually proven. The only thing they found here was there was slightly increased risk of excess risk of hypoglycemia with glimepiride compared to that of linagliptin. But otherwise, a safe drug, you can actually use this. We don't have a large clinical trial, dedicated trial for actually vildagliptin. So there was a trial known as a VIVID trial. So there, the one thing they found was some end diastolic volume was a little bit more in the arm which used vildagliptin compared to those which did not use it, the other arms. So that was one point, but otherwise it was once again telling that this was a neutral drug. So recently, this is a recent publication, and you can see here, they have found that DPP-4 inhibitors can be useful in heart failure with preserved ejection fraction. See, one of the problems with DPP-4 inhibitors, at least from the saxagliptin, was there was an increased risk of hospitalization for heart failure. Whereas a recent trial which came in JAK, and they found that in a patient with preserved ejection fraction, there was actually a 31% improvement. It was beneficial. So that's what they have actually found. So why did you find benefits, or you can say neutrality in TCOS, whereas you found harm with the in the Saver-Timi, that was with allogliptin, and this could be because of the sympathetic activation due to DPP-4 inhibition. So when you do DPP-4 inhibition, not only the GLP increases, the GIP can increase, that's fine, but it's also inhibiting the SDF, the EGF, all these things. The SDF, probably the stem cell derived factors, this could have probably caused the harm, that's what they say. Then a recent meta-analysis came, cardiovascular efficacy and safety of DPP-4, a meta-analysis from cardiovascular outcome. So non-fatal MI, non-fatal stroke, hospitalization for heart failure, everything actually was neutral, you can say, on risk of MI, hospitalization, stroke, urgent coronary revascularization, and cardiovascular death. But then what they found, an additional thing here was, there was an increased incidence of around of atrial fibrillation to the tune of 52% compared to that of placebo. So this is another thing which you have to actually keep in mind. So this observation that DPP-4 may actually increase the risk of atrial flutter is of utmost importance. So somebody having arrhythmias, you be a little bit cautious when you use a DPP-4 inhibitor. So that's the take from this. So now we had a lot of negative trials after the FDA started the thing. They were all neutral, but then recently almost all the trials have shown, majority of the trials, especially the SGLT2 trials, showed a benefit. So that's the reason what the FDA says now is, you don't have to do an extensive trial. They say before being authorized to be placed on the market, the newer anti-diabetic agents should have controlled clinical trials, including extensive studies, with at least 4,000 patient years of exposure to these drugs in phase 3 trial. Any dose, all doses are valid, with at least 1,500 patients exposed for at least 1 year, and at least 500 patients exposed for at least 2 years. And what should be the type of patients be? At least 500 with stage 3 or stage 4 CKD, at least 600 with established cardiovascular disease, that is prior MI, cardiovascular accident, or peripheral arterial disease, or documented coronary disease, and at least 600 patients over 65 years of age. At least 1,200 patients should fall under one of these 3 categories. And the third thing they told was, evaluation of cardiovascular adverse effects remain important. If an adverse effect, particularly to this newer anti-diabetic agent, is anticipated, it is advisable to contact the FDA for the design of phase 2 trials. And of course, you also look for adverse events, which should be an ongoing thing. So to summarize, after the rosiglitazone saga, the FDA told you must have a CV outcome trial. The TCOS trial showed that sitagliptin was non-inferior to placebo for MACE in patients with type 2 diabetes and established cardiovascular disease, but did not demonstrate superiority. The SAVOR-TIMI showed an increased risk of hospitalization for heart failure. The EXAMINE trial once again showed non-inferior in patients with recent acute coronary syndrome with no increase in heart failure risk. A trend was there, did not reach statistical significance. The Carmelina demonstrated non-inferiority to placebo for the composite endpoint of cardiovascular death, non-fatal MI, non-fatal stroke in population enriched for renal disease with no increase in heart failure. So while the CVOT trials have consistently showed cardiovascular safety with gliptins, only the EMPA outcome trials with EMPA, the CANVAS, the DAPA one, have shown superiority over placebo for reducing MACE in patients with type 2 diabetes and established cardiovascular disease. Yeah, thank you for patient hearing. Yeah.
Thank you for that insightful lecture, telling us what goes on behind the scene before an anti-diabetic drug, in particular gliptins, were introduced, and what monitoring we take place when the drug is there in the market. So in case of any comments or queries from the audience, the house is open. So if there are none, then thank you, sir. Thank you so much.
Thank you.
So thanks to the speakers and chairpersons for the session. So please spend a few minutes with us, accepting our token of appreciation. So then next on stage will be, Dr. Madhuri Patil and Dr. Chandrika Anand. I request Dr. Vimal to give a token of appreciation to Dr. Ganapati. So you can take a small photograph on the sidelines. So we are doing all this to save time, so that we stay on course. Welcome, ma'am. Dr. Madhuri Patil needs no introduction to a team of gynecologists and physicians. She's a pioneer of fertility practice in Bangalore city, and she's a clinical director of Dr. Patil's Fertility and Endoscopy Clinic, Bangalore. So she's the associate editor of Fertility and Sterility, an official publication of ASRM. She's a chairperson of the Aspire SIG Reproductive Endocrinology and president and founder member of the Fertility Preservation Society of India and the vice president and founder member of PCOS Society of India. I'll stop with that. I think I'll stop with that. I'll go to the next person. I think it's Then is Dr. Chandrika. Dr. Chandrika is Director PCOS Center and Saraswati Specialty Clinic, and she is Chief Consultant at Fortis Hospital, Nagar. She is one of the top 10 gynecologists South India in the Outlook India Today Peer Survey. She is a South Zone Coordinator of the Endocrine Committee of FOGSI. She is a Managing Committee member of PCOS Society of India, and she has won 8 gold medals from KMC Bangalore, and also during her MD in BMC. Her areas of interest is PCOS and high-risk pregnancy. So I've had multiple conversations with Madam. Madam is very passionate about her cases, and she maintains a large database of patients with PCOS, and she's really interested in PCOS care. So thank you, ma'am. And next, I'll call ask them to introduce the speaker and the topics.
For the session is Dr. Shanmukha Sundar. He's going to talk to us on medical management of hirsutism and hypoandrogenism, what has changed in the last 5 years. He's a consultant endocrinologist at the Magna Center for Obesity, Diabetes and Endocrinology, Chennai unit. He's been trained in MD and DM from PGI Chandigarh. He's invited speaker at many international, national and international endocrinology and diabetes conferences. He has received the Dr. MGR University Award for topping in anatomy as the best outgoing student award, and is also presented more than 800 scientific forums, and he has several publications to his credit.
Thank you, madam. Thanks for the kind introduction. So the topic given to me is the management of hirsutism and hyperandrogenism, recent update. So I have taken a few points from this recent guidelines published in collaboration with various societies. Thank to Dr. Madhuri madam for sharing this. It's a 5,800 page guidelines, so I have taken important points from that. So first, when the patient present to us, the female present to us with an hirsutism or acne or female pattern hair loss, so 3 things we have to ask. So what is the patient underlying diagnosis? It is a common garden variety of PCOS, or there is something danger thing is there which we have to rule out, like secondary causes for this PCOS or any androgen secreting tumor is there, we have to rule out. That's the first question we have to ask. Second thing is we have to note down the baseline, this one, what the patient present to us, the degree of hirsutism or acne or the hair loss. So we need to, best thing is to take a photo and follow up it, because we need to monitor whether there is improvement, whether the patient is satisfied or that. Third is assess the degree of emotional distress, because we know that even within India there is a difference between different people. In North India, and if you see Punjab and Haryana and all, they used to have mild hair growth, they don't worry about it. But if you see South Indians, even slight hair growth, they are much worried about it. So patients' distress is very, very important. So treatment decision also based on that. Some patients, they don't worry about it, so we can go with the milder treatment for like local application, no need for hormonal pills, etc. So these 3 questions are very, very important. So coming to the first question, in women with suspected PCOS, what is the most effective measure clinically to diagnose PCOS related hyperandrogenism, whether the patient may have increased testosterone level or not, what are the important things? So the 3 most common signs we need to see, which says that the patient may have hyperandrogenism are hirsutism, acne and female pattern hair loss. So hirsutism, again, it's the most recognizable clinical sign of hyperandrogenism. So more than 70% of the women with hirsutism can have elevated androgens. That is, elevated androgen means from 40 to 150 nanogram per deciliter, may not be more than 150 nanogram per deciliter. And data says that if the patient has this modified Ferriman-Galway score of 3 to 5, more than 50% of the people can have hyperandrogenism. And if the score is more than 5, then again more than 70 to 90% of the people can have hyperandrogenism. Coming to acne, there are no universally agreed scoring system for acne. Usually, generally, based on the lesion counting, global acne severity grading are subject to what the patient feel about this degree of acne, and photos and multimodal digital imaging, we grade the severity of the acne. And a number of studies has found that the acne is associated with biochemical evidence of hyperandrogenism, and also the timing of emergence of acne, whether that adolescents or in the late onset acne, correlates with hyperandrogenism. Data says that with persistent or late onset acne, that is rather than at the adolescent, if the patient develops at the acne after 20 or 30 years of age, they are more likely associated with androgen excess. So overall the data says that in patients with only with acne, if not associated with hirsutism, it has a low predictive value for the hyperandrogenism except for the late onset of acne. Female pattern hair loss, again we don't have the scoring system. There are typically two patterns of hair loss in female pattern hair loss: centrifugal expansion in mid scalp with preservation of frontal hairline is called as Ludwig pattern. Second thing is frontal attenuation or Christmas tree pattern, Olsen pattern. Again there is a various differences in different ethnicity, and again if you see only the female pattern hair loss without hirsutism, it is only the modest clinical predictor for hyperandrogenism. So the most important clinical predictor is hirsutism. Then if associated with acne or female pattern hair loss, it has a low to moderate predictor for biochemical hyperandrogenism. So this is the grading system for FG scoring. So usually before they used to have this 12 sites for grading, but now it's a 8 sites for grading. So we have to grade from 1 to 3, 4, and usually if it is more, they used to say it's significant. But again, as I said earlier, even for some people, even with they have a point score of 2 to 3, they may be having distress about this score of 2 to 3. So we have to treat them also. But it's important to grade at the start itself so that we can follow up the patient when the patient comes to after 3 months or 6 months. And another thing is the diagnosis. I was talking about the first question, whether we are we are missing something. So if the patient has severe form of androgen excess, we have to ask for some questions like temporal balding, deepening of voice, breast atrophy, increased muscle mass, and loss of female body counters, and clitoromegaly. Then if the patient has this kind of symptoms or signs, they may be harboring something dangerous, some androgen secreting tumor. So we have to go for detailed evaluation. So to summarize, many times the patient may come with they would have taken already some treatment, like they would have treated themselves. So sometimes we may not, as a doctor, we may not see the severity. So they may be having severe hirsutism or acne, they would have taken some local treatment. So we don't know the exact severity. So we need to ask them whether they have taken any photo previously. And self-assessment, what the patient feels about the 3 symptoms is very, very important rather than what we see. And only terminal years should be considered in defining hirsutism. And any new onset or severe hyperandrogenism or fast progression, we need to further evaluate. It may not be the common garden variety of PCOS. And monitor for clinical signs for hyperandrogenism. At least every 6 months we need to monitor so that we know whether they are improving with the therapy. Coming to the second question, in women with suspected PCOS, what is the most effective measure to diagnose PCOS related hyperandrogenism? So how to measure the biochemical hyperandrogenism? So testosterone, we all know, circulates in the 3 form: attached to sex hormone binding globulin, attached to albumin, and free testosterone. Free testosterone and attached to albumins are the most active form. Attached to the sex hormone binding globulin is not active. So practically we need to measure total testosterone and free testosterone by calculated method, not by the direct method, because again the assay reliability is very, very poor in India. It has to be measured by equilibrium dialysis. We don't have in many places. So it's better to measure total testosterone and calculate the free testosterone using total testosterone, albumin, and SHBG. The calculator is available online freely. If the testosterone and free testosterone is not elevated, the patient has clinically significant hyperandrogenism, then measure androstenedione and DHEAS. And if the particularly the patient doesn't have any clinical signs of hyperandrogenism, then it's biochemical hyperandrogenism is important. And if the patient is already taking combined oral contraceptive pills, again very important, testosterone value may be mistakenly it can be low. So always we should stop the combined oral contraceptive pills for at least 3 months, then remeasure the testosterone levels. And repeated androgen measurement for ongoing management in PCOS is not warranted. We don't have the data. So I think the slides are not very clear. So how to briefly how to approach to the patient. So if the patient has hyperandrogenism, if there is no drug-induced hirsutism, then measure the testosterone level. If testosterone is more than 50, then we have to see whether the patient has any CAH, non-classical CAH, or androgen secreting tumor. If the patient has testosterone less than 150, then most likely diagnosis is either PCOS or idiopathic hirsutism. Coming to the management, in women with PCOS or lifestyle, another one important thing is we have to rule out other things like hypothyroidism and hyperprolactinemia, Cushing syndrome, all those things also we should have it in the back of the mind. We should rule out those disorders also. So whether lifestyle modifications are important, again data says that lifestyle modification has some data to say that it lead to reduction in the testosterone level, increase in the SHBG level, and reduction in the FG scores. So if the patient with obese or overweight PCOS, lifestyle modification is very, very important. It leads to improvement in the various biochemical parameters and also some data on the FG scores, but we don't have very strong evidences to say that only lifestyle modification enough for the hirsutism management. Coming to the medical treatment, first thing is if the patient has other than this only hirsutism or only hyperandrogenism due to PCOS, the patient has other diagnoses like neoplasm or ovarian hypertrichosis, those has to be treated. Cushing disease, again we have to go what is the cause, whether adrenal or pituitary we need to see. Hypothyroidism and prolactinoma as per protocol we have to treat. Non-classical CH, again it's a common diagnosis, particularly in lean PCOS. So most of the times anti-androgen plus oral contraceptive may be enough. If still they are not responding, we have to add glucocorticoids. Coming to the OCPs, so this is the mainstay of treatment for hirsutism. So the meta-analysis has shown that combined oral contraceptive pills leads to minus 7.2 score decrease in the FG score. But again we don't have data how much reduction in the point is success leads is the we can classify it as success. We don't have the data, but any reduction in score is we have to see whether the patient is satisfied with it. So this 7.2 reduction is also maybe beneficial for many of the patients. So combined oral contraceptive pills data has shown that it leads to significant reduction in the hirsutism patients or hyperandrogenism patient. And how it acts, basically by inhibition gonadotropin secretion, increases the SHBG and reduction in the serum total and free testosterone concentration. Coming to the important question, because we have various OCPs, so what is the choice of OCPs? Choose the one that contains a progesterone with low or neutral androgenicity. So and also we have to remember that all these newer OCPs which has this cyproterone acetate, rosperidone, all has increased risk of venous thromboembolism. So we should be careful in elderly obese patient because it can lead to thromboembolism. It has low androgenicity but increased risk of venous thromboembolism. The older one which we routinely use for oral contraceptive, levonorgestrel containing combined contraceptives, have similar benefits on hirsutism, but it has adverse metabolic profile. So if the patient is at risk for metabolic profile, better to avoid LNG containing contraceptive pills. And again the second question, whether we have to use 20 microgram versus 30 to 35 microgram ethinyl estradiol. So various studies have shown 20 microgram versus 30 to 35 microgram as almost equal data. So the patient is at risk for venous thromboembolism, particularly the elderly female more than 40 at risk for thromboembolism, better to go with a lower dose. But if the patient has severe hirsutism, then we can start with the 30 to 35 microgram ethinyl estradiol. So always give 6 months. Again, it's very important. We need to educate the patient. Any treatment, whatever we are giving for hirsutism, it will take at least 6 months to see the response because the air cycle is 6 months. So we have to wait. In between, there can be a decrease in the speed of the air growth, the change in the texture. But the complete this one the treatment response may take at least 6 months. And try to obtain baseline FG scores and also follow up. Better is to take the photo and follow with the photograph. And routine monitoring of serum androgen is not required unless if the patient is on OCPs and there is again the fast progression in the symptoms, then we need to do the androgen levels, otherwise routine monitoring is not required. So if the patient has clinical improvement at the 6 months, then we can continue the oral contraceptive based on the patient priorities. If the patient is planning for pregnancy, we can stop. If there is a suboptimal response, then add anti-androgen. So thing is, better start with combined oral contraceptive pills. After 6 months, if still not responding, then add anti-androgens. So anti-androgen as an initial therapy is not recommended unless the patient is in very severe distress due to hirsutism or has some poor response previously to combined oral contraceptive pills, then we can start with combination. As a monotherapy is also not advisable in reproductive age group unless the patient is on some reliable contraceptive methods or the patient has some documented infertility. It's not advisable to start monotherapy because it can affect on the developing male fetus in utero. So what is the suggested drug? Again, drug of choice. So again, data says that different anti-androgen has a similar efficacy, but we have to decide upon availability, cost, side effects and potential toxicity. So mainly the side effects. So the main drug what we use is spironolactone. So we start with 25 or 50 milligram twice daily, and we can go up to 200 milligram per day also. The side effects hyperkalemia, but routinely we don't see unless the patient has some renal failure or reduced urine output, otherwise it's safe. But one important side effect is the intermenstrual spotting. So if the patient has irregular uterine bleeding, then we can reduce the dose from 200 milligram per 200 milligram. By reducing the dose, usually the intermenstrual spotting also improves us. So practice points with respect to anti-androgen therapy is, whenever pregnancy is possible, the patient is not on reliable contraception, avoid anti-androgens. And anti-androgens again can be considered to treat hirsutism if there is a poor response to oral contraceptive pills or the patient hirsutism is severe. Spironolactone is preferred drug due to lower side effects. Other all drugs has side effects. Cyproterone acetate at more than 10 milligram is not advised nowadays because the recent data says there is increased risk of meningioma. Finasteride, flutamide, bicultumide, all has the increased liver toxicity. So usually routinely we don't use all these drugs. So what about ionositol? It's again, this drug doesn't have any harm, and data says that it can reduce biochemical hyperandrogenism and lot of effects on the metabolic measures, but we have limited data for the clinical benefit with respect to hirsutism or hyperandrogenism. Topical therapy, for whom they want the rapid response to laser therapy, we can add L-carnitine cream in addition to the laser therapy. Anti-obesity medication, again for weight management, particularly the patient with overweight or obesity, we can use it, but we don't have the evidences for the improvement in the hirsutism or hyperandrogenism. Treatments not routinely recommended are metformin. Again, we don't have data that say that metformin is effective for hirsutism, and GnRH agonists or antagonists we don't advise. Topical androgens, again, one topical androgen in Western countries they are using has been approved for acne. We don't have it in India, clascoterone, and other anti-androgen has showed little or no benefit for hirsutism. So approach to the therapy, the first line of therapy, we have to see whether the patient testosterone less than 150 doesn't have other diagnosis like serious diagnosis, and the patient doesn't have any high risk for venous thromboembolism, then oral contraceptive is the first line of therapy. So evaluate after 6 months. If the patient is happy with that, continue the oral contraceptive pills unless the patient is planning for pregnancy. Otherwise, if there is a suboptimal response, add the anti-androgen therapy. And at any point of time, depends on the patient's wish, we can go for the laser treatment, for local laser treatment also. So follow-up, as I told, 6 months follow-up is better because air cycle is every 6 months. Taking photograph is the simplest and the most objective tools. And most of the patients, particularly the PCOS and idiopathic hirsutism, they respond to within 1 year of therapy. And the patient should be encouraged to continue for at least 2 years. After that, depending on the patient wish, we can continue the therapy or stop the therapy. And most of the patients require continuous treatment for suppression of the hirsutism. So again, we need to discuss with the patient plus and minus of continuing the therapy. So to summarize, so hyperandrogenism, the clinically we have to see 3 signs: hirsutism, acne, and female pattern hair loss. And the most recommended testing for hyperandrogenism is testosterone and free testosterone by the calculation, not the direct free testosterone assessment. And always rule out other causes, see clinically whether they may have other causes, and also historically whether it's the fast onset and rapid progression we have to see. And recommended treatment are lifestyle modification for weight loss, and the first line therapy for hirsutism or hyperandrogenism is the combined oral contraceptive pills, followed by anti-androgen if there is a suboptimal response. Again, anti-androgen, you have to be very careful if the patient is in reproductive age group, not having on any reliable contraception, you have to be very careful before prescribing anti-androgen therapy. And again, the preferred anti-androgen is the spironolactone. So there are medical treatment, there are plenty of options are there. So always it's better if the patient has significant hyperandrogenism, it's better to correct the hormones before referring to the cosmetic procedure, because if they are on hormonal pills, then the response to the cosmetic therapy also will be better. Thank you.
The points related to hirsutism, but one thing is there, I mean, when you are starting your hormonal therapy, many a times the patients already have taken cosmetic measures. So then your grading of your hirsutism with the FG score and the other things also will not stand good at that point of time, and whether your treatment is helping the patient.
Yeah, that's what I told. Many times when they come to us, they would have taken the self-treatment or treatment from the cosmetologist. So that will alter.
When you have started your anti-androgens, would you advise them not to undergo any cosmetic treatment or something?
Again, it depends on the patient preference. If they are significant distress and they want a faster treatment, it's always we go with a combination, the local cosmetic procedure plus the medical treatment. So, depend on the patient's willingness or what they want, we have to decide.
And if the patient doesn't respond to COCPs, then you add the anti-androgen. So then you give both the drugs together, or you just
Yes, anti-androgen as a monotherapy, it's unless the patient has some infertility where they can't become pregnant or on IUDs, so something else, we should not prescribe anti-androgen alone in the reproductive age group, always in combination with the combined oral contraceptives.
Yeah, so that was a wonderful talk, doctor. You covered everything. So as you told, the hyperandrogen symptoms of hirsutism, alopecia and acne are the most distressing symptoms, irrespective of the metabolic profiles of the patient, particularly in adolescents. So they are connected with the emotional aspect of the body image disorder, and then they are more associated with depression and anxiety. So management of hirsutism and alopecia and acne are very, very important, and you have very clearly, very lucidly given the management protocols.
Thank you, ma'am. Thank you.
Any questions from the audience?
Yes, sir. Yes, sir. It is anti-androgen action, sir. It has anti-androgen action. Yes, it's an anti-androgen action. It acts at the androgen receptor.
Hello. Yeah, so some patients who had hirsutism in their teenage or young age, we have seen it subsiding with the cosmetic therapy or whatever, and it recurs after menopause, say 10 to 15 years after menopause, and it is quite bad at that time. So anything in particular recommended, and is this related to any type of cancer? Because the patient who has this has breast cancer.
Yeah, again, postmenopausal, perimenopausal or postmenopausal hyperandrogenism, hirsutism is again well-known entity. I have not covered this because we have concentrated mainly on the PCOS or the reproductive age group and adolescent. So again, in those age group, we have to relate mainly two things: ovarian hypertrichosis and the androgen secreting tumor. So otherwise, the routine because there will be a disturbance in the balance between the testosterone and the estrogen. Postmenopausal, the ratio of testosterone estrogen varies, so some people can have the hirsutism or increased hair growth during the perimenopausal or postmenopausal. So many times we do go with the local treatment, the cosmetic treatment. We don't go for the hormonal treatment in those kind of patients. But main thing in those patients is the rapidity of onset, whether they have any virilization symptoms, and the progression of the hirsutism we have to see. And if it's there, then we have to evaluate for the androgen check. I have a couple of patients in the last 6 months where we found out the cause is due to the androgen secreting tumor from the ovary. So after removing the oophorectomy, the symptoms completely resolved. So ovarian hypertrichosis and androgen secreting tumor always at the back of the mind if the patient presented with a later age. Thank you. Thank you. Thank you, everyone. Thank you.
Yeah. Thanks, thanks, doctor, for the wonderful talk. Now we invite Dr. Prithviraj for the very interesting upcoming topic, that is anti-obesity drugs in the management of obesity and particularly obese PCOS. What are the latest guidelines? So, talking about Dr. Prithviraj, he is a consultant endocrinologist, adult and pediatrics, and associated with the Magna Center of Obesity in Hyderabad. He was previously was an assistant professor in the Department of Endocrinology in the Medical College, Mumbai. He has got 5 PubMed Index original publications, co-authored 2 textbook chapters, and he is a co-investigator in multiple diabetes-related research projects. So, over to you, doctor.
Good morning, everyone. And as Madam said, it's a very evolving topic. Before starting my topic, that is role of GLP-1 agonists in polycystic ovarian syndrome, I just want to know how many of you are currently using GLP-1 analogs. Kindly raise your hand in your clinical practice. Okay, great. Not many. How many of you are contemplating to use GLP-1 agonists for the obese PCOS? Yes, then I think this presentation might give you a little bit clarity. So before starting on to the GLP-1 agonist, one slide on the pathogenesis of PCOD. We all know the PCOD pathogenesis starts from the genetic predisposition to environmental disruptors, including the gut dysbiosis and the unhealthy diet pattern and a lifestyle pattern. All these cumulatively cause hormonal imbalance, leading to increased production of LH and decreased production of FSH, and increased production of testosterone and increased production of insulin, manifesting various clinical features like hirsutism, acne, anovulation, and metabolic features like fatty liver disease and diabetes. So what are GLP-1 agonists? GLP-1 agonists are the incretins. There are two incretins that are most extensively studied in human population. One is GLP-1 and another is GIP. Both these incretin hormones are secreted from the small gut in the small intestine and from various cells, and these incretins are going to act on the pancreas after a glucose consumption. These incretins produce excess insulin from the pancreatic beta cells and suppress glucagon secretion from the alpha cells. So this is the mechanism of action of these incretin hormones in controlling the hyperglycemia. So what is the mechanism of action of these GLP-1 agonists in reducing the weight? GLP-1 receptors are present in many systems in our body, especially in the arcuate nucleus of the hypothalamus, where appetite center is located. The GLP-1 agonists suppress the appetite by acting on this arcuate nucleus in the hypothalamus. And another important action of this GLP-1 agonist is on the stomach, where it delays the gastric emptying. By delaying the gastric emptying, even after a small meal, you feel fuller for a prolonged period of time, and making the satiety, increased satiety and decreased appetite. And the other important actions of GLP-1 agonists are at the level of liver, and there are many other actions that have been portrayed and are under studied currently. Especially recent ongoing trials also suggest neuroprotective mechanism of GLP-1 agonists against the Alzheimer's disease and Parkinson's disease. And many other inflammatory diseases also GLP-1 agonists are under studied. So what are GLP-1 agonists I just mentioned? They can be classified according to the duration of action or the skeletal backbone they had. Coming to short-acting GLP-1 receptor agonists, exenatide, lixanatide are the short-acting GLP-1 agonists. The long-acting GLP-1 agonists that are currently in use are dulaglutide, semaglutide, liraglutide, and exenatide. How many of you know that GLP-1 agonists are segregated from the venom of the Gila lizard monster, which lives in a desert? And this lizard monster survives many days without eating, in a fasting state, in a hibernating state, in a desert. Maybe this is because of the GLP-1 action or not, we are not sure. And these are all the various pens that are currently available in market, GLP-1 agonists, dulaglutide, liraglutide, which we are very commonly using, and oral semaglutide also we are very commonly using in the diabetes practice. Coming to PCOS, the beneficial efficacy of incretin-based therapies in the management of type 2 diabetes, together with their glucose-dependent mechanism of action, indicates their potential benefits in the management of polycystic ovarian syndrome and its related metabolic consequences. GLP agonists have shown significant efficacy in weight reduction, extending from 5 to 25% in the clinical trials over a duration of 3 to 6 months, and improving the parameters of insulin resistance, together with potential improvement in beta cell mass and function in various preclinical and clinical studies. So before offering this new drug for PCOS, GLP-1 agonist for PCOS, several critical questions needs to be answered. So what is the efficacy of this GLP-1 agonist in improving PCOS symptoms such as insulin resistance, hyperandrogenism, and menstrual irregularities compared to the current existing treatment? And what is the short-term and long-term safety profile of this GLP-1 agonist in women with reproductive age group suffering with PCOD? And will the combination therapy of already existing therapy plus GLP-1 agonist therapy is going to offer any additional benefit on top of the current available treatments? The most extensively studied GLP-1 agonists in PCOS are liraglutide and exenatide, and all the GLP-1 agonists showed promising results for obese PCOS patients by improving their metabolic parameters and fertility potential. Here, patient selection is the key. If the patient is having obesity, overweight, even in the treatment of PCOD also, we advise patients to lose at least 5 to 10% weight in the initial 3 to 6 months. For that, we offer either lifestyle medication or as a support, we can offer this GLP-1 agonist. But it has no role in the patients who have a normal BMI or lean patients suffering with PCOS. So what is the efficacy of liraglutide? Liraglutide has been studied in comparison to metformin at various doses, especially at 1.2 mg, 1.8 mg and 3 mg, and it has been studied for 3 months, 6 months and 32 weeks is the largest trial that I have known. So in the short term data, that is the studies done on 12 weeks of period at the dosage of 1.2 mg of liraglutide or 1.8 mg of liraglutide, the liraglutide is found to be very much beneficial in the metabolic component, in decreasing the metabolic dysregularities of the polycystic ovarian syndrome patients. It is improving the insulin sensitivity and helping the patients. But to have a menstrual regularization, they need a prolonged treatment for at least 6 months, and they may require a higher dose of liraglutide. In this study, which is a randomized placebo-controlled phase 3 study, they recruited 88 patients and they segregated into 2:1 ratio, and out of 55 patients are subjected to receiving liraglutide. They started with a 0.6 mg and increased the dose up to 3 mg, and they have kept them on a 3 mg for 32 weeks, and they have observed their free androgen index, and they have observed their menstrual regularities. And on the placebo study, around 25 patients were observed for 32 weeks, and they compared the results which was shown here. In the liraglutide 3 mg group, you can see after the completion of 32 weeks, the free androgen index is significantly decreased with a p-value of 0.006, whereas in the placebo control group, the free androgen index is increased. Similarly, in the number of menses per year, that is menstrual regularity, at the end of 32 weeks of liraglutide, in the liraglutide arm, the menses regularization happened at a very significantly with a p-value of less than 0.001, whereas in the placebo, there is no improvement. So this is all the studies which I have quoted. Liraglutide has studied in PCOD in comparison to metformin. All the studies at the low dose are equally efficacious to metformin or more effective than metformin in weight loss and insulin sensitive parameters. Even for usage of 2 to 3 months also, these metabolic consequences can be observed. But to attain a menstrual regularity or to observe the difference in the menstrual rhythm, we need to use them for a prolonged period of time, preferably at least 6 months. Again, combination therapy of metformin and GLP-1 agonist, is it going to offer any additional benefit? This is one study that has done on a 40 obese patients, PCOD, in whom lifestyle medication did not result in less than 5% of medical weight loss. So they are subjected to 3 groups. In one group, they have given metformin 1000 mg twice daily. In the another group, they have given liraglutide 1.2 mg once daily. And in another group, both metformin and liraglutide was given. As you can see here, in the metformin group, there is only mean weight loss of 1.2 kgs at the end of 3 months. Whereas in liraglutide group, the weight loss is around 3.8 kgs. And where metformin is complemented with liraglutide, the weight loss is even more, that is 6.5 kgs, which is very much significant in comparison to the other arms. So the combination therapy can definitely help the patients if they can afford and tolerate these medications. So liraglutide is more effective for weight loss and has significant metabolic and hormonal benefits, making it a strong option for managing polycystic ovarian syndrome, especially in obese patients. Metformin remains a cornerstone for managing insulin resistance and hyperinsulinemia in PCOS with a favorable safety profile. Combination therapy can offer superior benefits and may be considered for patients who need more comprehensive management of PCOS symptoms. These are all the studies done on exenatide. As I said, only liraglutide and exenatide are extensively studied. Again, exenatide also shows favorable outcome in PCOD patients. Exenatide alone or in combination with metformin has been found to improve pregnancy rates, increased sex hormone binding globulin, and increased FSH levels more effectively than metformin alone. It also significantly reduced total testosterone levels. So the combination therapy of GLP-1 agonist and metformin is superficial. What are the advantages? As is shown, the additional combination leads to more significant weight loss and more improved androgen profile, but it comes with the disadvantages of, as both the agents have some gastric intolerance, some patients may suffer with more severe GI side effects. So where does this GLP-1 agonist liraglutide come in the management of metabolical part of PCOD, management of PCOD? Metabolically, even now, metformin has the most safety data, and GLP-1 receptor agonist has some data till now. And coming to intervention for hyperandrogenism, GLP-1 receptor agonist, whatever studies they have done, the long-term studies have shown a decrease in free androgen index, as I mentioned, but still the available treatment options like estrogen pills, anti-androgens are far superior, and they may really provide immediate relief. Coming to discuss the safety profile of the GLP-1 agonists that are currently available, as I said, there is around 15 to 20% dropout rate who are taking this GLP-1 agonist. They cannot tolerate the severe nausea, bloating, flatulence, constipation, diarrhea. These are the common GI problems which we encounter when we start the patient on GLP-1 agonist. But luckily, these are all the symptoms are usually very transient and usually occur in the first 1 to 2 or 3 weeks of the after initiation of the agents. And usually, if the patient can pass that phase or tolerate that phase, we can see the actual results. Benefits of the GLP-1 agonist. And some patients may get injection site reactions. As a mechanism of action, appetite is very much decreased, and there is some theoretical risk of pancreatitis, and in diabetic patients, risk of hyperglycemia if you're concurrently used with sulfonylureas or insulins. And in rodents, it was shown to have a medullary thyroid hyperplasia. There is no cancer was reported either in rats or in the humans, but they're shown that medullary cells are little bit hyperplastic who are taken on the rats who has given GLP-1 agonist. So as a safety profile, FDA endorses not to use GLP-1 agonist for patients who are suffering with medullary thyroid carcinoma or having a family history of multiple endocrine neoplasia 2A. And pancreatitis, as I said, there have been concerns about increased risk of pancreatitis with high dosage and long-term use, even though the evidence is not conclusive. And reproductive health, there is limited data on the long-term effects of GLP-1 agonists on reproductive health. However, studies have shown no significant increase in risk of congenital malformations when used during early pregnancy. As PCOS is a majority of patients are reproductive age group, if the patient is taking this drug and she conceives, what to do, how to proceed, and all these things I am going to discuss now. So we cannot do randomized controlled trials in a reproductive age group female for these molecules. So whatever the data that has accumulated from the teratology information services, they have done an observational prospect cohort study on 168 patients who inadvertently received GLP-1 agonists during the first month or first 3 months of pregnancy, and their outcomes have been published in this journal, which is published in this year only. Around 168 pregnancies were inadvertently received GLP-1 agonists in their first trimester, out of which 99 patients have received liraglutide, and 51 patients have received semaglutide, and 9 patients have received dulaglutide, and few patients have received exenatide. And in this study, it shows that inadvertent exposure to GLP-1 agonist during the first trimester of pregnancy did not lead to increased incidence of congenital anomalies or fetal growth restriction or preterm births or any other complications. This is the data. In the GLP-1 receptor group, around 168 pregnancies, live-born infants of 113, and they are compared with the same age and BMI matched diabetes population who took oral hypoglycemic drugs inadvertently during the first trimester, non-GLP-1 oral hypoglycemic drugs, and they compared it with the similar weight obese normal patients also, and they found that there is no increased prevalence of any of these congenital spontaneous abortions or preterm delivery or small for gestational age or large for gestational age. All were comparable in comparison to the other groups. What does FDA say about this usage of liraglutide and semaglutide? In the FDA label, liraglutide, it mentions as Liraglutide should be used during pregnancy only if the potential benefit justify the potential risk to the fetus. Because in studies it was shown that liraglutide, exenatide does not cross the placenta and are much more safer. But we do not have that data for the semaglutide. That's why FDA cautious mentions that do not use Rybelsus if the patient is planning pregnancy, and you have to withdraw Rybelsus or semaglutide at least 2 months prior to planning a pregnancy. So till the data available, it is advisable not to use in a patients who are planning to conceive this GLP-1 agonist. So FDA clearly mentions that avoid semaglutide if you are trying to conceive. It's unclear if semaglutide can be harmful in pregnancy, as some studies have shown increased skeletal anomalies in the babies that are born, in the rats especially, but there is no human actual data. That's why the Therapeutic Goods Administration recommends women of childbearing potential use contraception when taking semaglutide. Guidelines recommend stopping semaglutide at least 2 months before planning pregnancy. For women who use semaglutide to manage diabetes, it is important to seek advice and other options to control blood glucose level when trying for pregnancy. So to conclude my talk, consider GLP-1 agonist in a PCOD patient who is not planning to conceive with a BMI of more than 30 kg per meter square or 27 kg per meter square, who are not responding to lifestyle modification, and use contraception while on semaglutide, and it needs to be withheld for at least 2 months before conception. Despite the available evidence of GLP-1 agonists, more clinical trials are required before they can be recommended routinely for PCOS patients to promote sustainable weight reduction and to improve the parameters of insulin resistance in PCOD. Thank you. Questions?
It was a very interesting talk. So what I would like to add on few things is that in PCOS, according to the international guidelines, orlistat is the only recommended use in PCOS obesity. Okay, and then they say that liraglutide could be tried as a second line. And this liraglutide, semaglutide, or the anti-obesity drugs where you endocrinologists routinely use becomes in between the metformin and the bariatric surgery. Most often we give metformin, so much of metformin, and for so long, and along with the lifestyle modifications, the weight loss becomes, they go for a dead end. They can't lose more than 5 kgs or 6 kgs in spite of all the lifestyle interventions. So I think then the only choice available all the while was bariatric surgery. So anti-obesity drugs will come in between. It is giving a more weight loss of more than 10%, whereas as you rightly told, metformin can give 5%, and in majority 5% of weight loss is going to bring in a lot of metabolic and reproductive outcome improvement. But then after metformin, what next? That is when the anti-obesity drugs come, and as you rightly told, we need to select the patients, and we need to see the contraindications, and we need to monitor for the weight and the side effects. So I think all the gynecologists here, we should be aware that there is something beyond metformin and before bariatric surgery in management of obese PCOS patients.
So would you test for insulin resistance before you would start these in PCOS? Because I don't think all patients of PCOS have insulin resistance. There are some who don't have. So would you test for insulin resistance before you start the GLP-1 agonist?
So currently it is not approved for obesity or PCOD in India, madam. So we do not endorse using these GLP-1 agonists. It is only approved for diabetes in Indian setting currently, and some off-label usage is being happened. And insulin resistance is more of a clinical sign instead of a lab HOMA-IR we take. It is if the waist circumference is more, if there is acanthosis, and these are the clinical signs of insulin resistance. We look at it, and BMI is one parameter, waist circumference, acanthosis, all these parameters are taken in consideration, and HOMA-IR is not required if you...
No, HOMA-IR is normally not done only, but any other test would you like to do? Because I don't think it's...
Ideally, glycemic clamp study is the gold standard for the insulin resistance or insulin sensitivity, but that is very cumbersome, and we do not require that much cumbersome test to simply identify the clinical insulin resistance.
And what about, just for obesity, what is, I mean, though it's not still used, I mean, indicated in India, it's not been approved. Have you used, and what is your
See,
experience
obesity,
on that?
liraglutide is used, madam, on a daily basis. For obesity in India, liraglutide is available and can be used. And the dose we have available is only 1.8 mg. For obesity, we may require up to 3 mg actually to achieve it. With liraglutide, the weight, again, weight loss can be in the range of 5 to 8%. Semaglutide is more efficacious molecule in that aspect. It can go up to 20% also, semaglutide. So before getting to use it on a routine basis, we need more and more Indian data also.
Yeah, because most of the data is from outside. Any questions from the audience?
Liraglutide is approved, that's what I am saying. There are no questions, thank you.
Yeah. Thank you for an excellent overview of the topic, so that at least people have become aware that there's something like GLP-1 agonist that's available and which can be used. And once it's approved for its use in India, I mean, we can also probably use it. Though now it's used off-label, but it can be used. Thank you very much. And thank you for giving us this opportunity.
I request Dr. Shanmu Sundar, Dr. Varun to give a token of appreciation to both the chairpersons and the speakers. Yeah. Yeah. And I'll call up onto the stage the next chairpersons for the next session. Dr. Rupa Varnekar. I think Dr. Rupa Varnekar has not. Yeah, Dr. Rupa Varnekar is there. I can see madam at the back. Yeah, ma'am. Dr. Rupa Varnekar is a. We'll wait for ma'am to come. She's a fertility consultant at. She's a fertility consultant at Kushi Fertility and IVF Center. Madam has done a fellowship in cosmetic gynecology from RGUHS. She's a guest speaker in Bellary and Bijapur Society of Obstetric and Gynecology. She has a presentation in South Kisar 2024 and 23. She's a speaker in Gulbarga Society of Obstetric and Gynecology. Welcome, ma'am. Over to you to introduce the speakers in the session.
Yeah, thank you for giving me the opportunity on this class. Today, introducing Dr. Vijay Bhaskar Reddy. He is a senior consultant and endocrinologist and managing director, Vijay Diabetes, Thyroid and Endocrine Clinic, Puducherry. He caters about more than 60,000 diabetes and endocrine patients. He has awarded one of the inspiring endocrinologists of India for the year 2020 by the Economic Times India. The present affiliation, he is a Secretary Endocrine Society of Tamil Nadu and Puducherry, and President Puducherry Diabetes Research Forum, Faculty Public Health Foundation of India Diabetes and GDM courses, and he has more than 20 publications in peer-reviewed endocrine journals and 4 book chapters. His area of research interest is type 2 diabetes mellitus and vitamin D. Endocrine conference is what he organizes, Trendo 2024, PET 2022 and Trendo 2022. Over to you, sir. Yeah.
Thank you, madam. Thanks for the introduction. I thank the organizing team of Magna Update for having invited me to give this important topic today. So I'll be talking about endocrinologist role in women with panhypopituitarism undergoing fertility treatment. I think patients with women with infertility numbers have gone up due to various reasons, and this is one of the important causes of infertility where the women will come to seeking for fertility treatment. although it's not very common, but we need to recognize this and see how we can manage this. Slide is not moving. Oh, it's here. Okay, I'll start off with a case scenario. A 26-year-old lady, past history of pituitary adenoma, non-functioning adenoma. Patient had undergone transphenoid surgery at the age of 23 years. Post-op, she was confirmed to have a biochemically confirmed panhypopituitarism, and she was on estrogen progesterone replacement, and she stopped 3 months before. Now she has come to discuss the possibility of pregnancy. Current hormonal replacement, because she was confirmed biochemically to have panhypopituitarism. She was on hydrocortisone 20 mg per day in 2 divided doses, levothyroxine and desmopressin and somatotropin, that is growth hormone. So this type of case when we get, so I'll just discuss about panhypopituitarism and how it is associated with fertility and what is the endocrinologist role. So panhypopituitarism, as the name suggests, so there is a deficiency of anterior or posterior pituitary hormones. It can be partial or complete. So to call it pan, I think the terminology says pan means it's complete pituitary hormone deficiency, but for definition we can take 3 or more pituitary hormone deficiencies. So the pituitary gland, we know that it has got 2 lobes. We have anterior lobe and the posterior lobe. Anterior lobe secretes various hormones. So they are called the trophic hormones. So we have ACTH, and then we have prolactin, then LH, FSH, which are the gonadotropins, thyroid stimulating hormone and growth hormone coming from the anterior pituitary. So in turn, these trophic hormones are acting on the adrenal gland, producing cortisol and androgens, prolactin on the mammary gland causing lactation, and then we have FSH, LH acting on the gonads, estradiol, progesterone, and in males testosterone. Thyroid, we have thyroxine and T3, and growth hormone effect on the liver, IGF-1 in the peripheral tissues. So posterior pituitary gland secretes arginine, vasopressin and oxytocin, mainly in water reabsorption and for contractions of the uterus and breast. So if there is going to be deficiency of the hormones, the corresponding gland will be failing. So you can have secondary adrenal insufficiency, you can have secondary hypothyroidism, hypogonadotrophic hypogonadism. So all this can be there. So looking at the etiology of hypopituitarism, so we can have a pituitary gland problem. So there can be an expanding mass. We can have a cellular or the supracellular tumors. There can be iatrogenic hypopituitarism because of prior surgery for pituitary tumor, like in our case, or radiotherapy in the pituitary area, which can lead on to panhypopituitarism. Traumatic brain injury affecting the pituitary gland is known to be associated with hypopituitarism. Infections, congenital or genetic causes, developmental. And in the Indian scenario, we also have vascular causes, Sheehan syndrome, postpartum pituitary necrosis, and snake bite also in some areas. There can be problem in the pituitary gland, in the hypothalamus area. So there can be infiltrative hypophysitis, lymphocytic hypophysitis, so and functional, vascular. So many causes can be there. We need to identify the cause to manage the case correctly. So this is a clinical spectrum of hypopituitarism in India, a single center experience. This is from the Army Referral Hospital. It's published around 10-12 years back. So they found around 100 cases of hypopituitarism. Most common was pituitary macroadenoma and other supracellular and cellular tumors, accounting for nearly 80% of the hypopituitarism cases. Sheehan syndrome was the second, and then the other causes, including snake bite, were identified. Manifestation wise, you can see that hypogonadism is the most common manifestation. So this is hypogonadotrophic hypogonadism due to FSH-LH deficiency. Nearly 97% had hypogonadism. And then secondary hypothyroidism, hypoadrenalism, and panhypopituitarism was also present in 90% of the cases. So looking at another area from Kerala, they again studied around 50 cases of hypopituitarism. They found that again tumors were the most common cause, nearly 60%. So this area, snake bite was an important cause, snake bite leading on to hypopituitarism, and Sheehan syndrome. So again, hypogonadism was the most common manifestation here also. This is another study from rural West Bengal, and they found that in rural area where the snake bite exposure was there, snake bite was the most important cause in this area, followed by Sheehan syndrome. So overall, all these studies here, we can see that pituitary tumors, surgery for pituitary tumor or radiotherapy for the pituitary or suprasellar region like craniopharyngioma, then Sheehan syndrome, snake bite, these are the common causes of hypopituitarism in our area. So just Sheehan syndrome, so we know that this is postpartum pituitary necrosis. So in postpartum hemorrhage, so we have this already the pituitary gland is enlarged and there is compression of the vascular structure of the pituitary gland leading to ischemia. And in the postpartum pituitary necrosis, we have severe postpartum hemorrhage causing necrosis of the anterior pituitary leading on to hypopituitarism. So the prevalence of hypopituitarism, it is rare. Prevalence studies in general population around 0.05% only. So that's why it's underdiagnosed. There is a very heterogeneous clinical presentation. There is no single symptoms. Patients can present with different symptoms, non-specific fatigue. So different symptoms can be there. Difficult to pinpoint and say this is hypopituitarism. There are a lot of complexities in testing and understanding the reports. So a high index of suspicion is required. So obviously there is hypopituitarism. We saw that hypogonadotropic hypogonadism is the most common aspect of this. So this leads on to poor fertility. So because of deficiency of the gonadotropins, FSH we know that it stimulates the ovary and LH causes ovulation. So because both are deficient, this hypogonadotrophic hypogonadism and hypopituitarism causes infertility. Studies have shown that there are other factors other than the hypogonadism, like we know that thyroid is important for fertility, so secondary hypothyroidism, secondary hypocortisolism, growth hormone deficiency. So all these factors have to be corrected. So you, in addition to what you do for isolated hypogonadotropic hypogonadism, so we need to correct the thyroxine and the cortisol, growth hormone to optimize the treatment. So options for fertility treatment in hypopituitarism. So assisted reproduction techniques have evolved well. So there are different protocols for exogenous gonadotropins. For ovarian stimulation in hypopituitarism, we would prefer to use a combination of FSH-LH like HMG. Different protocols are available and with follicular steady monitoring. Once the dominant follicle is there, we can use ovulation trigger with HCG and followed by IUI or IVF. This is most often done by the fertility specialist. So the endocrinologist's role is to optimize the hormone replacement therapy. In addition to the fertility treatment, we have to optimize the other pituitary hormones like thyroid hormones, the glucocorticoids, the growth hormone, and vasopressin if required in patients with diabetes insipidus. So glucocorticoid replacement in the preconception period, the preferred glucocorticoid is hydrocortisone. So dose is around 20 milligram per day in split doses. So morning 10 milligram, afternoon 10 we can give, or 10-5-5. The major dose has to be in the morning to mimic the physiological cortisol secretion. So whenever we are giving hormone replacement, we need to try to mimic the physiology exactly the same way the body makes. So there is no need to increase the dose during fertility treatment. If the patient is on other glucocorticoids like dexamethasone or prednisolone, it is ideal to switch to hydrocortisone because this is what will be continued during pregnancy. Any patient on glucocorticoid replacement, we need to advise sick day rules, like stress doses of glucocorticoids, and for emergency, if they are having vomiting, diarrhea or dizziness, what they should do. So thyroxine replacement in preconception period is essential because we need to optimize the thyroxine. Thyroxine is essential for fertility through various mechanisms. Usual dose requirement is 1.6 microgram per kg per day. In the pre-conception period, no increase in dose is usually required, but when they conceive in early pregnancy itself, we may have to increase the required dose. So ensure the replacement at a target. Usually hypothyroidism, you will be titrating and keeping the TSH in the normal range. But here in central hypothyroidism, due to hypopituitarism, the TSH is deficient. So you cannot go by the TSH level in a hypopituitarism case. So there is pituitary problem, so you cannot monitor the TSH level. So don't titrate based on the TSH level. You need to maintain the free T4 in the upper normal range. But most often when we request, we always request a TSH because primary hypothyroidism is the most common thing. So we are adjusting based on TSH. But hypopituitarism, make sure that you don't adjust based on TSH. You need to do a free T4. This is one condition where you have to do a free T4. Normally you will hear all endocrinologists telling do only TSH, that is what is important. But here in hypopituitarism, the TSH will not go up because the pituitary is damaged. So you try to maintain the free T4 in the normal range. We should not try to adjust and make the TSH in the normal range. So follow the free T4 and keep it in the upper normal range. So growth hormone is shown to improve fertility in some studies. So it's shown to improve the ovarian follicle development. It also potentiates the gonadotrophic actions. It's having some action on uterine size and endometrial lining. So some are proposed as an adjunct in fertility treatment, but this is controversial. So it's not essential for fertility treatment and it's expensive, so we do not use it commonly. So we use it mainly for growth purpose. Desmopressin, if the patient is having diabetes insipidus, we give the usual dose, no change is required. So diabetes insipidus is a bit rare because it's coming from the posterior pituitary, which is coming from the systemic circulation, whereas anterior pituitary is the hypophyseal system, where it's a low pressure system. So when we are giving various hormones, we need to remember the interaction between the various replacement hormones. So like when the patient is having hypopituitarism, so you should not give the thyroxine first because thyroxine can metabolize the glucocorticoids and it can precipitate adrenal insufficiency. So in hypopituitarism, before giving thyroxine, you should exclude adrenal insufficiency and first give glucocorticoid. So sequence of hormone replacement, first glucocorticoid, then thyroxine. Similarly, when you give estrogen, there can be change in the thyroxine dose. When you give glucocorticoids, it may unmask diabetes insipidus. So we should have an idea of the interaction between the various hormones. So this is a systematic literature review on fertility and pregnancy in women with hypopituitarism. So the peri-pregnancy pituitary hormone replacement is preconception glucocorticoids. Hydrocortisone is the preferred glucocorticoid. There is no need to increase the dose during fertility treatment. And if the patient is not on hydrocortisone, we should make sure the patient is on hydrocortisone. Thyroid hormone, no need to increase the dose. Ensure replacement is a target. Don't titrate based on TSH. Try to keep the free T4 in the upper normal range. Growth hormone might improve fertility, but it's expensive, injectable, so not required for our patients. Desmopressin, there is no need to increase the dose. Fertility treatment, that FSH, LH, HMG and HCG, that is separate. So fertility treatment in women with hypopituitarism. Infertility is very common in hypopituitarism. Main reason being hypogonadotrophic hypogonadism and secondary hypothyroidism. All this contribute also, growth hormone deficiency. Optimum hormonal replacement therapy is essential for women seeking fertility treatment. So fertility part, we use FSH, LH combination like HMG for ovarian follicle development, and trigger for ovulation we use HCG. So endocrinologist role is also important. We have to optimize the glucocorticoids, the thyroxine, growth hormone and desmopressin. Thank you.
Thank you, sir. It was a well explained and nice topic. It's very rare, hardly we come across. And you said snake bite is the cause for pan-hypo. What's the reasons? How is it causes?
So various proposed mechanisms of that. Snake bite, they have this DIC, the coagulation abnormalities. They tend to present with shock also. So all this pituitary, I think the anterior pituitary is under this hypophyseal system, where it's a very low pressure system. That's why it's very prone. So due to various mechanisms like shock, DIC, capillary leakage, so then the pituitary is very sensitive, especially in postpartum pituitary necrosis like Sheehan syndrome also. That is why these two are common in the Indian setting. So if you are living in Bangalore, we are not having any snakes. So urban and rural studies show different. So in rural areas, if you do, then snake bite will come. And in urban areas, similarly, so Sheehan syndrome also, wherever the antenatal care is very good, patient is coming, you are avoiding postpartum hemorrhage, then you may not be seeing that much of Sheehan syndrome. But neglected areas, very far off people, rural areas, they may present with Sheehan syndrome. So these two causes are not there in the international literature commonly.
Apart from hormone test, we should do other tests like a karyotyping also is advisable. Karyotyping?
For hypopituitarism, it's not required, madam, in this case.
Okay. Thank you. Any questions from the audience?
Yes, sir. Mike.
Due to radiation therapy.
Yes, sir.
Head and neck, nasopharyngeal carcinoma, salivary gland carcinoma.
Yes, sir. So any radiation, so mostly it is described for cellular and supracellular tumors like craniopharyngioma is just lying on top of the pituitary. They do the surgery and they give post-op radiotherapy and they can develop. So
among
any radiation there.
Amongst the infectious diseases.
Yes, sir.
Tuberculosis is
Tuberculosis,
here, no?
absolutely, yes, sir.
So is it...
It's not very common, that site tuberculosis is reported, not very common. As per the series also I showed you. So only less than 5% of cases can be pituitary abscess, then tuberculosis. These are all reported, but not very common.
Okay, thank you. Yeah.
Thank you, madam.
I would like to introduce now Dr. Sunetra Mandal, next speaker. She is President at the Institute of, she is Assistant Professor in the Department of Endocrinology, NRS Medical College, Kolkata. She is background with a list of so many achievements. Yuvaratna Award 2023 for the Best Research in the Private Cap awarded by the Endocrine Society of India. A.V. Gandhi Award for Excellence in Endocrinology 2019. Awarded by Endocrine Society of India. She has a research experience published in the fall. More than 30 publications indexed in national and international journals. Editor of the book Metabolic Syndrome from Mechanism to Intervention. Area of interest is Turner Syndrome, Genetics in Endocrinology. Over to Dr. Sunetra.
Thank you so much. Good afternoon, everybody, and I'm very thankful to the organizers of Magnacode for inviting me to this program of very high academic value, I would say. So I have been given the topic of interpreting thyroid function and prolactin levels from an endocrinologist's perspective during fertility treatment. But there are still many gray areas in this zone, and so I may not be able to provide concrete answers to all your questions in this domain. So to start with, let's look at my first case, a 26-year-old lady, primary infertility, likely anovulatory, and trying for spontaneous conception with ovulation induction. And a second case, a 38-year-old lady trying for IVF pregnancy. So when such ladies with infertility are coming to us endocrinologists during their infertility treatment, there are a bunch of questions that we need to answer to ourselves. So do we routinely measure TSH in all of them? Do we routinely measure anti-thyroid antibodies in all of them? If TSH is high, do we treat them for overt, for subclinical, or even if they are euthyroid but having thyroid antibodies positivity, we do need to treat them, and whether there is any role of low TSH. So looking back to our physiology lessons, so thyroid hormones as well as to some extent TSH and TRH affect the gonadotropins, prolactin, SHBG, and to some extent leptin, and therefore any problems with thyroid hormone secretion is expected to cause hormonal alterations and anovulation. This apart, thyroid hormones also have some effect on granulosa cell aromatase activity as well as granulosa cell proliferation, and this way too hypothyroidism could lead to anovulation as well as luteal phase defects. Thyroid hormone receptors have also been found to be expressed in the uterine endometrium, and they do regulate endometrial receptivity as well as myometrial contractions, and thus hypothyroidism could lead to implantation failure too as a cause of infertility. So for overt hypothyroidism, a lot of evidence in support of its association with infertility. Up to 5% of infertile women can be having overt hypothyroidism. Regarding subclinical hypothyroidism, evidence is less robust, but yes, infertile women, those with ovulatory dysfunction, do have slightly higher median TSH than other women. So if there are there mainly till last year we used to follow the American Thyroid Association guidelines. We are still following that. So it recommends TSH for all women undergoing infertility treatment. But last year, this American Society of Reproductive Medicine ASRM 2023 guidelines came, which is a way more too strictly evidence-based guidelines, and it suggests not to do routine thyroid hormone testing for all these women. Talking about autoantibodies, yes, women with female factor infertility have been found to be having a higher prevalence of thyroid autoantibodies. Antithyroid antibodies have been detected not only in their serum, but also in the ovarian follicles, which might interfere with the fertilization potential of the oocytes. And of course, thyroid antibodies increase the potential for these women to develop hypothyroidism during pregnancy, and we know how they are associated with a higher risk of spontaneous pregnancy loss due to multiple postulated immune-mediated mechanisms. But more recent population-based studies have failed to find a strong association or a clear association of antithyroid antibodies and infertility. Nevertheless, if we look at practical implications, antithyroid antibodies, when we are talking about women with infertility planning spontaneous conception, not ART, they do not quite alter management decision in patients who are having overt or subclinical hypothyroidism. I will come into how, but may have a role in euthyroid and patients who are having TPO positivity. So let us assume three hypothetical scenarios of TSH, hypothetical TSH values for our patient planning spontaneous conception. Overt hypothyroid 23 TSH, subclinical hypothyroid 5.3 TSH, or euthyroid but having anti-TPO positivity. So do we treat or not? So overt hypothyroidism, no doubt we have to treat all of them. Regarding subclinical hypothyroidism, again the ATA guidelines and the ASRM guidelines differ in this regard. If we look at the ATA guidelines, their recommendation was based on this meta-analysis of levothyroxine treatment in subclinical hypothyroidism women. But if we look at the results, it was very much skewed by the findings of one particular study from Egypt by Rahman et al., whose who showed that the results of whom were around 4 to 8 times found to be more beneficial with levothyroxine treatment as compared to the other studies. But this study was grossly criticized because, and it came out with an erratum as well, because it was found that the authors did not report exact numbers, they gave percentages, and when back calculated from their sample size, their results were too good to be true. So there was actually a high risk of error, and this was excluded from the more recent meta-analysis, whose results looked to be a bit more modest and realistic. So subclinical hypothyroidism, the ATA guidelines suggest we should treat, but the ASRM guidelines says we should not treat. This is for women planning spontaneous conception. So coming back to our lady, so overt hypothyroid treat, subclinical hypothyroid may or may not treat, the guidelines differ. Coming to euthyroid but TPO positivity and attempting spontaneous conception, there is no RCTs in this regard actually, and because of this there is no recommendation as well. So to summarize my findings, for infertile women planning spontaneous conception, we routinely measure TSH, we may or may not routinely measure TPO antibody. Overt hypothyroidism we have to treat, subclinical can consider treating, euthyroid TPO positive we do not treat, and 25 to 50 microgram of levothyroxine is usually the recommended dose. Coming to my second case, planning IVF pregnancy, ART. So let us assume the same three hypothetical TSH value: overt hypothyroid, subclinical, and euthyroid with TPO positivity. Now, ART protocols, we know, begin by inducing controlled ovarian hyperstimulation, and this would cause the estradiol levels to rise very high, therefore giving to rise in TBG, thyroid binding globulin, reducing free thyroid hormones and causing TSH elevations. But at the same time, the HCG could also stimulate the thyroidal TSH receptors. So during and up to 1 month after the stimulation protocol, it has been found that the TSH could stay high, but the free T4 could either be increased or decreased or stay the same. So the recommendation is that for patients undergoing controlled ovarian stimulation, thyroid function testing should be performed either before or 1 to 2 weeks after the stimulation. And if non-pregnant, the mild TSH elevation is there, it has to be repeated after 2 to 4 weeks because the levels could normalize. If pregnant, however, the TSH level has to be treated as for any other pregnant women. Now, overt hypothyroidism, ART, of course, we treat. Subclinical hypothyroidism, ART, again, conflicting evidence. Most of the benefit, if any, has been seen for those with TSH more than 4.5, and the benefit is on delivery rates, not clinical pregnancy rates. So this could be due to the benefits during pregnancy rather than during the infertility treatment. Again, the guidelines differ in this regard. Subclinical hypothyroidism, ART, ATS suggests to treat to keep TSH below 2.5, but the ASRM guidelines, which is more evidence-based, does not recommend treatment in this regard. Coming to euthyroid TPO antibody positive, this is the lower part of the picture. As we can see, there is hardly any benefit of giving levothyroxine to these patients undergoing ART. Very few trials. In fact, there have been some trials showing some promising results of prednisolone in this cohort of patients, but again, the risk is unknown. So for these patients, euthyroid TPO antibody positive undergoing ART, levothyroxine ATS suggests may or may not be given, may be considered, but glucocorticoid is not recommended. So infertile women planning ART, TSH for all. If done, it should be before CO hyperstimulation or 2 to 4 weeks after. TPO for all. Overt hypothyroid as well as subclinical hypothyroidism we have to treat. Euthyroid TPO antibody we may consider treatment, it's not essential. So that summarizes our case 2. Talking about hyperthyroidism, so clinical as well as subclinical hyperthyroidism has also been found in around 2% of infertile women. Of course, we know menstrual irregularities are common in them. A word about male infertility, both hypo and hyperthyroidism can affect sperm count, sperm motility, apart from causing sexual dysfunction due to the changes in SHBG as well as the aromatase activity. The same reason why males with hyperthyroidism can be having gynecomastia. So for males or females presenting with hyperthyroidism, low TSH before fertility treatment, it is very essential to evaluate the cause and treat the cause before going for fertility treatment. In fact, one interesting finding in a study, Graves' disease was detected in higher proportion of women before pregnancy rather than during pregnancy. Coming to my third case, a 34-year-old lady, infertility, prolactin 87, no other secondary causes of hyperprolactinemia evident. So as we know, high prolactin levels would affect the kisspeptin secretion from the KIS1 neurons in the hypothalamus, leading to lower GnRH, lower preovulatory LH surge, and therefore lesser ovulation. This apart, it also causes luteal phase defects, hyperandrogenism, as well as sexual dysfunction. And as we all know, for any patient presenting with hyperprolactinemia, it is very important to rule out the common causes, most of the medications, the effect of renal insufficiency, pregnancy itself, and sometimes macroprolactin. And after all these have been ruled out, we are left with prolactinoma or any other non-functioning or other pituitary tumors raising prolactin by stalk effect. So till now, we were following the Endocrine Society Guidelines 2011 for managing prolactinoma cases. But again, this year, there was this consensus statement from Pituitary Society, which has actually caused a paradigm shift in the way we think about the first-line therapy for prolactinoma cases. From dopamine agonist, the recent guidelines have gone for a more pro-surgery approach, especially for microprolactinoma and well-controlled, I would say, within the cella, if it is a macroadenoma, even if there is visual compromise. Even for them, they have suggested, especially if they have visual compromise or other contraindications to dopamine agonist, they have suggested surgery should be the first line. And this is based on the findings of this meta-analysis, which showed that those who underwent preoperative dopamine agonist therapy had lower remission rates post-surgery, and this could be related to their adenoma fibrosis after dopamine agonist use, though this was more commonly seen with bromocriptine. So prolactinoma patients coming in the preconception period, so we know we should, when we are starting dopamine agonist, now when we are planning infertility treatment for a patient with prolactinoma, surgery of course should not be the first line. It could damage the gonadotropes in the pituitary. So when we are starting dopamine agonist, at the same time we should also advise barrier contraception, allow a few menstrual cycles to occur when we will know that ovulation induction has resumed, and then after that, if she misses a period, we would know that this could be due to pregnancy. And then after contraception is stopped, periodic HCG, and if it is positive, we discontinue the dopamine agonist. For macroprolactinoma during pregnancy, they have suggested the mass should be reduced as much as possible. The risks of, and as well as the benefits of the surgical resection of the adenoma must be explained to the patient with macroprolactinoma trying for pregnancy, and the rest is as before. Regarding the bromocriptine and cabergoline controversy, currently majority of the workshop participants in this international consensus statement, they favored using and continuing cabergoline during pregnancy at the lowest effective dose, especially for patients who are already well controlled on cabergoline, so as to avoid the risks of high prolactin and failure of fertility treatment. Coming to my last case, a 35-year-old lady with PCOS having failed several cycles of ovulation induction, now planned for ART. Prolactin is 67 without any other obvious causes. Now looking at the prevalence of hyperprolactinemia in PCOS, over the years it has actually fallen, and it differs from country to country, maybe depending on the definition used, the prolactin assay used. And we know the link between hyperprolactinemia and PCOS, it is due to the decrease in dopaminergic tone, which causes both the increase in prolactin as well as the high LH in PCOS. And there is a synchronization between LH secretion and prolactin. And also there is the effect of high estrogen levels in PCOS on prolactin. But studies that have found, that have evaluated causes of the hyperprolactinemia in PCOS, most of the women had other secondary causes as well, rather than PCOS per se causing the high prolactin levels. So it is important to rule out secondary etiologies for high prolactin, exclude macroprolactin as well in patients with PCOS and hyperprolactinemia. Now, 3 new things that I learned while I was studying for this presentation, that patients undergoing ovulation induction could have a transient luteal phase hyperprolactinemia, but whether this has a good effect or negative effect or neutral effect is not very clear. Recent studies suggested that there could be a positive correlation between prolactin levels in the luteal phase and higher quality embryos. Second new thing that I learned is that dopamine agonists could actually reduce the incidence of moderate to severe ovarian hyperstimulation syndrome to as much as 3 times. And this could be related to the cabergoline's effect on decreasing the receptor expression for VEGF, vascular endothelial growth factors, and therefore vascular permeability. And if given, it should be started on the day of HCG trigger for 8 days at a dose of 0.5 milligram daily. And even with this daily dose, there was hardly any adverse effects reported. Metformin has actually found to reduce prolactin levels in patients with prolactinoma, as well as in patients with antipsychotic and other drug-induced prolactinemia. So why that occurs, the mechanism is clearly not known for the non-prolactinoma causes. But ironically, while we would be happy if this effect was seen in PCOS patients who would anyway otherwise we also could be given metformin, this effect was less pronounced in women who also had coexisting PCOS. So coming back to my last case, a 35-year-old lady, PCOS, primary infertility, planned for ART, hyperprolactinemia. Of course, I would evaluate her for the etiology of her high prolactin levels. I would try to put her on metformin if she is obese or having dysglycemia, and maybe a short course of cabergoline during her HCG trigger could be given. And a bit about male infertility. Prolactinoma has been found to be as much as 35-fold higher in infertile male than general male population. As we know, macroprolactinomas in men are more aggressive and lesser responsive to dopamine agonists. So men with hyperprolactinemia, hypogonadism, we evaluate the cause, we give dopamine agonist. Persistent hypogonadism for 6 months, we put them on testosterone, but testosterone via aromatization could increase prolactin and reduce the efficacy of dopamine agonists. So important to monitor prolactin levels. Importantly, gonadotrophin axis may recover on itself with correction of hyperprolactinemia, so we should periodically re-evaluate the need for testosterone. And persistent hypogonadism and desiring fertility, of course, gonadotropin therapy. So to conclude, evaluation and management of overt thyroid dysfunction is, of course, essential in women with infertility, subclinical hypothyroidism, and euthyroid but TPO positivity. If we have to treat if they are going for ART, hyperprolactinemia in any infertile women, it's necessary to rule out the cause first. Dopamine agonists have a role in preventing ovarian hyperstimulation in women undergoing ART, and hyperprolactinemia and hyper more than hypothyroidism could be reversible contributors to male infertility. Thank you so much for your patient hearing, and I seek your solidarity in support for our fight for justice. Thank you so much.
Thank you, Dr. Sunetra. It was very informative. I just want to know, is there any role of HCQS with autoimmune thyroiditis?
Autoimmune thyroiditis, as in Hashimoto thyroiditis, we do not give HCQS to these patients, ma'am. We actually do not give anything to them. We let them be hypothyroid, and when they become hypothyroid in a level enough to treat, we give them.
Okay, thank you. Any question from the audience?
Hello Sunetra, I am Dr. Shobha Gudi from Bangalore.
Yes, ma'am.
And we do express solidarity, and
Thank you,
every day has been a day of anguish. We from Bangalore society especially, we stand for the cause of women's safety and health. We are really devastated that you have to go through this. So my question is pertaining to euthyroid women and the testing of antibodies for them. In the normal course, we do not test euthyroid women for antibodies. So I just wanted an explanation of it.
Ma'am, for patients who are undergoing ART, there has been few studies which have shown benefit in euthyroid women who are TPO positivity. And as I said, the recommendation by the ATA is to give levothyroxine to these euthyroid TPO positive women who are planning ART, not spontaneous conception. But the recent ASRM guidelines is against this treatment. So it's maybe up to the discretion of the endocrinologist.
Yeah, I have a query. You mentioned continuing cabergoline for patients macroprolactinemia in the lowest effective dose. How do we monitor them in pregnancy? What is the level of prolactin you want to maintain?
We do not measure prolactin during pregnancy.
So is it the pre-pregnancy that whatever the level, you continue that, the dose I mean? What is the recommendation?
Possibly yes, and we monitor if there is new onset headache and visual symptoms. Whether we can increase or not, we will know, but lowest effective dose, yes ma'am, it's difficult to understand.
Yeah, thank you. Yeah.
Thanks. Thank you so much.
Thank the speakers and chairpersons. So please collect, token of appreciation from us just by the dais, ma'am, there. Yeah. And I'll call upon the stage chairpersons. So can we have the slides? So Dr. Shyam Gupta, Dr. Annama Thomas, and Dr. Usha B.R. So Dr. Shyam Gupta is the center head and fertility and IVF specialist at Indra IVF Bengaluru. So he has done his clinical training in Gynae and Lap from ABGET Guangzhou, China. And he's been awarded National Fertility Award Best IVF Specialist South and Best Budding Endoscopist Surgeon South consecutively in 22 and 23. He has got the Leadership Award in the Indra IVF Hospital. So he has received a grant from the 9th Singapore International Congress of Obstetric and Gynecology in 2013. So, and he is also received as a young researcher of Nepal from Vinay Tara Foundation in 2012. So welcome, sir. Next slide. We have Dr. Annama Thomas. She's a senior consultant at Birthright Hospital by Rainbow Hospital. She's a former professor and HOD. I would say she was my professor and HOD at St. John's Medical College Hospital. So it's a pleasure to have you here, ma'am. and she's an expert to the Metropolitan Marriage Tribunal of the Archdiocese of Bangalore, and she's a member board of studies Obgyn at KMC Medical Colleges. Next slide. We have Dr. Usha BR. Madam is a consultant Obgyn and fertility laparoscopic and robotic surgeon at Fortis Hospital, Bannerghatta Road. She's an ex-senior resident from AIIMS, New Delhi, and she has a fellowship in minimal access surgery, and also she has a diploma in reproductive surgery. So over to the chairpersons to introduce the speaker and the topics.
Very good afternoon. Thanks for all the opportunity given for today's CMA seminar. And I would like to introduce Dr. R. Santosh, who is an endocrinologist. He is the founder director of the Magna Center for Obesity, Diabetic and the Endocrinology, and the chief endocrinologist in the Hyderabad Filmnagar. He is a visiting endocrinologist in the Fernandez Hospitals and Apollo Hospitals, Jubilee Hills. He has more than 45 publications to his credits, including the 4 textbook chapters. He has been awarded the Abdul Kalam Excellence Award for his work in diabetic endocrinology. He has addressed in more than 900 scientific forums thus far, which includes invited faculty talks in international, national and regional conferences. Area of special interest is the reproductive endocrinology, process puberty and the psychological aspect of the diabetic management. We all welcome you, sir, for today's dais, and over to you, sir.
Thank you. So, good afternoon, everybody. I'll be talking about this particular topic, glucose control in a patient undergoing IVF. So, I must admit, when I got the topic from the scientific committee, I was wondering what I will be talking about this particular condition. But let me take you through a small journey of a person who's already having diabetes and already trying to undergo IVF at the same time. So, we'll use an index case. This is Mrs. A. She's a 40-year-old dental surgeon. She has presented in June 2024, and she has been trying to conceive for the last 6 years. Now look at her now. She's having type 2 diabetes since 9 years, using glimepiride 4 mg per day, metformin 1 gram per day, vildagliptin, dapagliflozin, fixed dose combination, known case of hypertension on ACE inhibitors and beta blockers, and HbA1c is 10.2. This particular patient has been referred to Dr. Anantharaman actually. So Anantharaman is, they are told, please Dr. Anantharaman manage his sugar somehow and send him back, because we are planning for IVF and embryo transfer in the next 4 months. So vital signs are thus: 82, BP is 130/88, BMI is 35 with a weight of 82 kilograms. So how do we approach this topic? We'll talk a little bit about the way the diabetes affects the fertility in the first place, and how do we specifically manage diabetes and its related complications while people are undergoing IVF. What are the precautions to be communicated as a team, basically, as both as the IVF doctor as well as the endocrinologist, and what we do in Magna which can help in patients a little bit better. So reproductive dysfunction, it is a complication in diabetes which is talked very less about. So we talk about microangiopathy, we talk about cardiovascular disease, but reproductive dysfunction is also a common but very little studied complication of diabetes, and it hits mainly in type 1 diabetes women. So imagine a type 1 diabetes girl who has got diagnosed at the age of 9 years, 10 years. By the time she's planning pregnancy, she already has a certain degree of hyperglycemia and diabetes complications, and then she's planning for pregnancy. It becomes very difficult in people with type 1 diabetes. Type 2 diabetes, although later in onset, also causes problem with infertility and miscarriage. So much so that you go to any IVF center, you will see that the chances of IVF success will be lesser in people who have diabetes as compared to people who don't have diabetes at any age. So that is the problem with diabetes here. So how does diabetes actually affect the fertility in the first place? Now when we go to type 1 diabetes in particular, especially the girls who have got diagnosed at the age of 9 years, 10 years, menarche itself is delayed. And once menarche gets delayed, they start developing delayed periods also. Why do they develop delayed periods? Because there is something called as a cachexia-induced hypogonadotropic hypogonadism in these individuals. So they have very poor pulse generator of GnRH, poor response of LH to exogenous GnRH as well. Also, some of them may be treated with physiological doses of insulin, supraphysiological doses. So when you actually over-treat them with insulin, they go into hypoglycemia. It's not only hypoglycemia which is occurring, but there is hyperandrogenemia and PCOS development in type 1 diabetes also. Type 2 diabetes, as we know, has a common soil, that is insulin resistance. Insulin resistance causes type 2 diabetes, it causes abdominal obesity, but it also causes PCOD. So those people who are having type 2 diabetes have been having insulin resistance for a very long time, and they also find it extremely difficult to conceive. Even obese women who are having regular cycles are also finding it difficult to conceive, showing that the anovulation is the main cause as far as fertility in type 2 diabetes is concerned. We know for a fact that a person who's having a high HbA1c persistently will have a substantially decreased fecundability, a decreased egg reserve, and a higher proportion of spontaneous losses. Miscarriages are also high in these particular patients, and therefore as an endocrinologist we need to do our best to get these patients under control at all time, which is obviously easier said than done. But it has changed in over the last few years. So if you see the data from 1965 to 2004, the chances of becoming pregnant were less by 20% as compared to non-diabetics. But after 2004, the myriad of changes that has occurred for the management of type 1 diabetes, the different insulins, the different monitoring devices, now the fertility seems to be much better in people with type 1 diabetes as it was before 2004. The another thing that can occur with diabetes patients is the premature ovarian failure. So many of them, they develop menopause at an earlier age. It can occur up to 10, 12 years before the onset also. So premature ovarian failure is mainly autoimmune in etiology, especially in type 1 diabetes. And you know, it becomes very difficult for fertility achievement at that particular time. So type 1 diabetes is a place where there are a lot of autoimmunity is there. So autoimmunity is not only causing premature ovarian failure, it's also causing Hashimoto's thyroiditis. And Hashimoto's thyroiditis, as you know, causes a problem with dysmenorrhea, oligomenorrhea, oligoanovulation. It causes delayed in fertility and also causes miscarriages. Anti-adrenal antibodies, anti-ovarian antibodies are also high in these particular girls who are having type 1 diabetes. It's very difficult to measure anti-ovarian antibodies because assays are not very good. But many fertility specialists, they will prefer to use a low dose of steroids if the patient is having type 1 diabetes and hypothyroidism to begin with, to bring down the autoimmune levels as far as fertility is concerned. Another important thing that people forget is about the sexual dysfunction. So in type 1 diabetes ladies, the arousal and lubrication is very, very less as compared to those people who don't have type 1 diabetes. And in diabetic males also, if the male partner is having diabetes, there is erectile dysfunction which occurs much earlier and much commoner in patients with type 1 diabetes as compared to general population. Now what about this topic here, diabetes and male fertility? Does diabetes affect males as much as it affects female and fertility? So this is a particular data which has been seen, 3,000 couples who are trying to conceive, out of which 2.7% were having diabetes partner as male. 75% of these people had undergone some form of assisted reproduction, whether IVF or ICSI basically, or this thing. So, but the fertilization rates, they were good. Fertilization, so when you are talking about fertilization, they were good. They were equal to that of controls. But once implantation occurred, the chances of a live pregnancy were much lesser in partners who were having diabetes in males. There could be a myriad of reasons for that, but this is important data to understand. So what do we do now? A person like this particular dental surgeon who was referred to us, what are the specific management of diabetes and its complications while a person is undergoing fertility treatment? What do we do? So number one is blood glucose control. So the ADA recommends a blood glucose control to be as close to normal as possible without causing hypoglycemia. And this translates into an HbA1c of 6.5% or lesser. There are certain fertility doctors who want to bring it to below 6%. That's very, very difficult in a person who's having type 1 diabetes, especially when we are treating with large doses of insulin. So 6.5 is shown to have a good pregnancy-related outcome with less complications and positive pregnancies as well. So if a person comes with such a high HbA1c like that lady has done, probably we might even prescribe contraception for some time to bring down the HbA1c to less than 6.5 and then allow her to plan pregnancy. Once the lady becomes pregnant, that time the different values are applicable. Fasting should be less than 95, post-meal should be less than 120, HbA1c should be less than 6, because in pregnancy the targets are totally different, and because of hemodilution also the values are a little bit lower. Now with access to better monitoring device, continuous glucose monitoring, the diabetes management has become a little bit easier. What do we do as far as medication for diabetes is concerned? So this is a very crowded slide. You can just listen to me talking. Don't look at it also. So in females who are having type 1 and type 2 diabetes, we know we have to treat these people with insulin because they're planning for pregnancy. So in females with type 1 diabetes, if they're already on one particular insulin regimen which is causing them no hypoglycemia, it is causing fairly good glucose control, it is better to continue the same insulin only. But in type 2 diabetes, when they are shifting from so many oral drugs to insulin, maybe nowadays we are preferring to use analog insulins. We like to give Lispro, Aspart in this particular insulin, and insulin Detimer, which has the longest data as far as pregnancy in basal insulins are concerned. Nowadays we are using insulin Degludec also because it has a few open label studies. Insulin Glargine in some people we continue during pregnancy because of safety data, but long-term studies with Glargine are not there in pregnancy. So when we are initiating people on insulin, we don't give insulin Glargine. We probably give insulin Detimer or Degludec for fasting control and insulin analogs for postprandial control. Now what about human insulins? India is not a country where everybody can afford costly insulins. So human insulins are given in many ladies, but we have to remember that it causes hypoglycemia, and it becomes especially difficult during the 9th week, 10th week and 11th week of pregnancy when the insulin sensitivity suddenly improves during pregnancy. They develop a lot of hypoglycemia and we need to take care. The consideration while controlling the glucose is, now just imagine that a patient who came first, she's having an HbA1c of 10.5 and she's already on so many medications. We have to stop all of them. We have to start insulin and then control the blood sugar. So it's not a very easy task. It doesn't get controlled in 1 month. So we're just requesting everybody to allow us a little more time to control the sugar for these particular patients. Because when we start with insulin, we start with one particular dose, that's 0.18 unit per kilogram. And then we slowly increase it and bring it to a good level, which will bring down the sugar, not high, not low, but with an HbA1c close to 6.5. Ideally, the patient should give us time. The patient should tell us, come on, please, I am planning for pregnancy. Please control my blood glucose, then I'll go for pregnancy. But there are a lot of problems. So we see many patients who come from abroad, for example. They want to get IVF done very quickly. They have to leave within 1 month, 2 months. So that's where we see the challenges. But with local patients, additional 1 or 2 months will have excellent results. Hypertension. So type 2 diabetes is not about managing sugar only, is it not? So hypertension, most type 1 diabetes and type 2 diabetes, for hypertension, they'll be using ACE or ARBs. ACE, ARBs and spironolactone are contraindicated in pregnancy because it will cause renal dysplasia, pulmonary hypoplasia, oligohydramnios, fetal growth retardation, etc. So in these patients, we have to change the drugs. Ideally, we should change in the first contact only when they're planning for fertility. We should either give them alpha-methyl-dopa or labetalol, or for example, diltiazem or nifedipine we give. But many of them are also having a little bit of underlying nephropathy and all that. So in some patients, we continue till 1 week before the fetal embryo transfer is done. So till that time, we try to continue their ACE and ARB. And 1 week before, we try to change to the other antihypertensive medicines, because the other antihypertensive medicines don't have that much protection on the kidney and other organs. So we have to do it in a case-to-case basis, try to change as early as possible, if not at least 1 week before the FET. Dyslipidemia. So many of patients are using statins. Again, the guideline is try to stop statins in the first contact itself. But many of them will have increased cardiovascular risk then. They might be having fatty liver disease, and stopping statins might cause the problem. The time and again, there has been a lot of data showing that when you use statin in the first trimester of pregnancy also, nothing happens. So if possible, you stop the statin well before the lady becomes pregnant. But if the lady does become pregnant on statins, don't scare her. Please just stop the statin and continue the pregnancy. Screening for complications. So screening for complications, why is it necessary? Because diabetes complications, especially retinopathy, neuropathy and cardiac complications, they'll tend to worsen during pregnancy. So a lady who's already having, for example, severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy will worsen severely during pregnancy. So we need to tackle it before she enters pregnancy only. There are people who are using drugs for neuropathy. The drugs for neuropathy need to be modified. We cannot give all the drugs for neuropathy. Those people who are under nephropathy, we should try to get their BP and protein levels quite normal before they undergo pregnancy. And especially in women who are older and they are obese and they're having other cardiovascular risk factors, at least screen by doing an ECG and echocardiogram to show that they are fit as far as cardiovascular health is concerned for a good pregnancy. If not, we'll treat that as well. The next thing that we as group of endocrinologists do is also concentrate on weight. And we know that for years together, we know that if you reduce weight, you will have better fertility outcomes. But till 4 or 5 years ago, we didn't know what to do with that. So we used to not say, okay, go, we used to tell lady, go exercise and come, go follow diet and come. But now the approach to weight management has changed dramatically. How do we manage the weight? First is with the help of medical nutritionists. So medical nutritionists, especially in our institution, what we have done is, they don't provide information to the patient with one sheet like that. So nowadays we are forming something called as it's a WhatsApp group follow-up. So a nutritionist is involved, an exercise counselor is involved, a psychologist is involved, and the patient is being contacted daily, whether she is able to achieve the level of nutrition that we are able to want for her from. So ideally we want a BMI between 20 to 25, and we need to restrict 500 to 700 kilocalories per day. Very easy to tell, restrict 500 kilocalories per day, but for a lady to follow, it becomes very difficult. So a person who is monitoring continuously will help. The second thing now we are doing, especially in people with diabetes, is preferring this drug called as semaglutide. Now semaglutide, oral semaglutide is available and approved in India in doses of 3 mg, 7 mg and 14 mg. And excellent results we are getting with semaglutide as far as sugar control is concerned, and as far as weight is concerned, and as far as fertility is concerned also. Subcutaneous semaglutide for non-diabetic patients with obesity is also approved by DCGI, but we don't have stocks over here. We don't have it in the white market in India. Stocks are not available, but if it does come next year, we are going to start using that also. Injectable semaglutide, which helps in losing weight faster. How do these drugs work? They work, number one, by reducing the gastric emptying, so that their satiety is there. It also acts at the level of brain to increase the satiety and decrease the appetite as well. Is there any direct data of semaglutide and fertility? No. But semaglutide, as we know, does everything possible for good fertility. So it helps the person lose weight. Insulin resistance comes down. The ovulation improves. The androgen levels come down. So many things are occurring, but direct effect of semaglutide on fertility, still data is still going to come out. We don't have, but we have enough and more evidence to say that semaglutide, if you use in patients who are planning for IVF, who are obese and having uncontrolled diabetes, we are going to get good outcomes. Semaglutide helps in males also. So a male diabetic who is having a low sperm count and poor metabolism or sperm metabolism, if you give semaglutide, all these are improving. So people with weight loss, as far as male is concerned, we are treating them with GLP-1 receptor agonists for a better outcome. Some patients can't afford semaglutide. Then what do? We use orlistat. Now orlistat, what it does, it reduces the absorption of fat from the intestine into the blood. But it's a poor agent as far as Indians are concerned, because we eat more of carbohydrates, less of fats we eat. So it works sometimes, it doesn't work in all patients. But there is data with orlistat. Orlistat plus metformin in ovulation induction seems to be better than metformin alone. And orlistat in men with infertility is working better on sperm counts. So we have data coming with orlistat as a weight loss agent. So we don't see how it's not going to be possible with the other weight loss agents as well. What do we need to communicate as a team, as fertility specialists, as an endocrinologist to the patient? So our voice should be same. You know, we cannot have different opinions while the patient comes to us. So as far as blood sugar is concerned, we say that yes, we need to control the blood sugar well, because this will improve the fertility outcome. And we have to do it by giving insulin. We have to do it by achieving weight loss. And we have to increase the monitoring as far as blood glucose control is concerned. And as far as fertility treatments are concerned, ovulation induction might require higher doses of drugs. The chances of OHSS are more. Usually I don't get into this conversation. I tell, please follow the fertility specialist because they are experts in this condition. And the chances of miscarriage are still there. Even after you control the diabetes very nicely, miscarriage might still be there, but we as a team are going to take care that we minimize the chance to very less. So what do we do right now? Nowadays we have started a program called as Disease Management Program, or Magna 365. So a patient who comes to us, we just don't send them away with a prescription actually. We catch them, of course we charge them for that separately, but we catch them and we ask them to enroll in something called as Magna 365 WhatsApp group. There, not only the patient is involved, but there is a doctor involved, there is a dietitian involved, there is an exercise counselor involved, there is a diabetic educator involved, and they make sure that the patient's blood glucose is controlled. So let's go back to the dental surgeon. You can see that the fasting blood sugar is 269. You see slowly over a period of time with only the continuous monitoring, her fasting blood sugar has now come to 86 by only monitoring continuously. What all do those patients do in these chats? They are not only talking about their blood sugar levels, they are talking about their diet, they are talking about their stress levels, they are talking about exercise. And these are actual photos which the patients have sent. These are not photos which I have downloaded from internet. These are actual photos which the patients have sent as to what they are eating, what they are doing. They are constantly in touch with us. Fitness therapy is more difficult actually to convey to the patient, but nowadays more and more patients are also taking up. So our fitness specialists are helping them to do some simple exercises at home, which will help in improving the insulin resistance and better sugar management. So if you go back to the index case who came with an HbA1c of 10.5, where we had to stop all the tablets, we continued metformin and gave insulin. Through this program, we managed to get her HbA1c to 6.4 in 2 months only, because she became more conscious and she knows that she wants to go for IVF. She's waiting for a baby for a very long time. And one thing to be said is, those ladies who are planning pregnancy and those ladies who are already pregnant, they are always the best patients for us, because they listen to whatever we say. They are very receptive to whatever we say. So they follow it very nicely. And we got this patient to 6.4% control. And in fact, already egg pickup is done. Embryo transfer is now planned for this week. Future, we need to understand more about the HPO axis. We need to understand more about the anti-ovarian antibodies. We need to understand more about upper genital tract infections in patients with type 1 and type 2 diabetes. And we also want to know if we can prevent this premature menopause that is occurring in many patients with type 1 diabetes. I think with that, we'll stop over here and take any questions. Thank you.
Thank you, Dr. Santosh. It was a very clear talk, a lot of take-home points with that. Now, we as ART specialists, as we are seeing a lot of women conceiving past 35 years, and they come to IVF only when all the other treatment methods have failed. So we are seeing more of people past 37, and that's when we see more of diabetes and hypertension in them. So now say we have a situation where we have to start a patient on stimulation immediately, for whatever reason. It could be an outstation patient, it could be for egg freezing, whatever I see on day 1 or day 2, and I find out, I give you 2 situations I want you to explain. First is where she's a newly diagnosed diabetes. I see a HbA1c of 8. And the other patient is already diabetic, was well controlled in the previous treatment cycles. Now I'm going to start stimulation, I find HbA1c is of 8. Now I refer to you, and can I start stimulation in the same cycle? Should I defer? Or if I have to defer, for how long should I defer?
So as far as egg pickup
this is for ovarian stimulation, and yes, I'll do egg retrieval only.
Correct. So as far as ovarian stimulation and egg pickup is concerned, I think all we need to see if this patient is falling under risk for short general anesthesia. That's all. I think that's what we do. Just short anesthesia is what is given. So if the patient is not at a risk, we can go for egg pickup immediately, because the quality of the ovum is not going to be related to blood sugar. For an embryo transfer, however, we have to wait. We need
so I should not be planning embryo transfer in the same cycle.
Yes.
What is the rough time that I should be waiting to counsel her?
So we would, it depends on the HbA1c. Probably the HbA1c is like 7.5 to 8, means we can wait for a month also. In 1 month, we can achieve what we have set out to achieve. But in this particular case, if you have seen, she's using these many drugs and HbA1c is still 10%. So we'll have to tell her, you'll have to wait till your endocrinologist gives a green signal. And we are trying to do it as fast as possible now, because we also know the problems that are there with fertility centers, especially while dealing with outstation patients.
So you say about a month. In the following month, I could plan for embryo transfer.
First patient 1 month, madam. This last patient at least 3 months. The one which I told.
If the patient conceives on orlistat, is it safe if she becomes pregnant? What do you advise?
We just stop the orlistat, because as such orlistat does not have a problem except for hepatotoxicity in some people. So if it does not cause idiosyncratic hepatic problem in the first 1-2 weeks, it's not going to cause any problem. There is no studies with orlistat during pregnancy. So once the lady is pregnant, you stop.
Yeah, one small query, because patient having the pre-dyslipidemia and all, and was on the statins and all, and what is the follow-up in the pregnancy for dyslipidemia, or we can go for lipid profiles again and again, and we can restart the statins very, very high. What to do in those cases?
So statins, as per the guidelines, they say if a patient is at extremely high cardiovascular risk, you can continue during pregnancy also. But for 90% of the patients who don't fall under that category, it is better not to give statins because the teratogeny of statins has not been studied conclusively.
Again, a significant population of this would be polycystic ovarian syndrome patients who undergo IVF as well. Most of them will be on metformin combinations with minoxidil. Some of them will be not. And this crowd will also develop diabetes in pregnancy. Now, how do you manage them? If they are already on metformin, we continue them. If they are not, can we start metformin? What about the increased incidence of IUGR associated with metformin in pregnancy?
So, as far as initiation of metformin in the first trimester of pregnancy in a person who has never taken metformin, we don't do it because hardcore conclusive evidence of metformin is not available in the first trimester. But somebody who is already having PCOS and is using metformin for the control, I think there is enough data to say that we can safely continue metformin throughout. So medico-legally comes the problem when you are starting metformin in the first trimester for the first time. But somebody who's already on metformin, we continue during pregnancy. IUGR is the only problem with metformin, IUGR. So in the growth scan, if we are finding that the child is not growing appropriately, then we stop the metformin and go for only insulin-based treatments. Otherwise, nowadays, even for routine managements of GDM, we have started using metformin.
Because the compliance is good with metformin,
yes.
would it be a wise decision to have metformin in the first 2 trimesters and shift over to insulin in the last trimester?
First trimester is a very dicey thing actually. So the guideline says that if you are already on metformin, you can continue it. But if you want to initiate metformin in the first trimester, try not to do that.
No, for patients who have started with metformin preconceptually.
Yeah, then you can continue, yes. This is a very gray zone. So there is no, I think even among the group of endocrinologists here, we might not agree that who should be continued on metformin during first pregnancy in the first trimester and who should not be.
Any questions from the audience?
Yeah, a very grey area, as you said, about metformin in pregnancy. And I think the speaker has brought it out very well that women with PCOS who have required metformin preconceptionally, in them, often they come with pregnancy when they are still on metformin. And till today, data do not show any adverse effect on the pregnancy. We do tend to continue, but data are still lacking. But having said that, beginning metformin as a fresh agent during pregnancy does not have any grounds unless there is abnormal glycemic indices, unless there is gestational diabetes, there. Or she is already on insulin therapy, but then is requiring an OHA in addition, then we start metformin. But otherwise, only metformin as therapy for something which, for example, PCOS women, in the hope that it will reduce miscarriage rate or it will avert the onset of gestational diabetes, then in that case it is not required. So this is where we stand today. We don't have any more data than this for first trimester of pregnancy. Yeah.
In our institution, what we are doing, so in our institution, in the sense, I work in Magna in Hyderabad and Fernandez Hospital in Hyderabad. So what we do is if a person is already taking metformin up to 12, we continue the metformin in the first 12 weeks because that is when the chance of miscarriage are the most. Yeah. After 13th week, we stop the metformin. 1 week later, we ask them to go for early GTT because they are at high risk for GDM. So 1 week later, without metformin, we do an early GTT. If we again find that, as madam says, there is a gestational diabetes component, then we restart the metformin. Otherwise, we don't give it in the second trimester, we stop.
Thank you. There are no more questions.
Sorry, just to add that even if there is gestational diabetes, we would still go with lifestyle management to begin with, yes, and add an OHA only later if it is not working.
Yeah. Thank you, Dr. Santosh, for that excellent deliberation. There are no more questions. Can we move on to the next speaker?
Our next speaker, we have Dr. Saptarshi Bhattacharya, who is a senior consultant endocrinology at Indraprastha Apollo Hospitals. and also Apollo Hospitals, Noida. He's an ex-secretary at South Asian Federation of Endocrine Societies, executive committee member of Endocrine Society of India, and honorary secretary. He's an ex-president, Society for Promotion of Education, Endocrinology and Diabetes. He has more than 90 publications in national and international journal. Over to you, sir.
Thank you. So I think Dr. Santosh already told you that pregnancy is a major issue and you need to control glycemia. So we are now look into the other part of it. It's male hyperfertility. Actually, many people, physicians and even general public, most of the general public, they don't know that endocrinologists have a role in treating fertility related issues. They feel that urologist is the best person and they will go on to people like all strange sorts of people that they will go to some jari booty wala person and all. So you first of all need to understand so that I'm thanks to Anand Raman and the Laxmi and the Magna team and Santosh for bringing this topic up that we do have a role to play. So and how we can help will go on to that. And so first of all we need to understand what is male infertility on the first place. So it's not a male thing or a female thing, it's a couple thing. So it's if somebody is not able to conceive after 12 months of regular unprotected sexual intercourse with intention to conceive, if then only we label it as infertility. So it takes time. So with each cycle, so the chance of conceiving is around 15 to 20%. So ultimately it turns out to around 80 to 85% of normal couples will conceive after trying it for a year or so. So only 15% or so will actually turn out to be infertile as per the WHO definition. And the American Society of Reproductive Medicine, they actually changed the definition also. So if somebody already is having hypogonadotropic hypogonadism, so in that case, that lady will be requiring treatment right from the beginning. So you don't need to wait for 12 months to label that as a case of infertility or start treatment. So you need to start treatment right now. So they have changed. So even there are like, we know that we are becoming, maybe we're progressing in the right direction. So sometimes we have transgender related persons who come to us, who it's a same-sex couple, they want to conceive. So you can't label that is something which is abnormal, and even if they are planning to conceive, so you need to give the right treatment. So in those cases, you don't need to wait for 12 months to say, okay, this person is infertile. So you need to understand the situation and then label it as infertility. That is what the American Society for Reproductive Medicine says. And if somebody is more than 35 years, specifically the female is more than 35 years, so you just wait for 6 months to label it as need for further intervention. And if the female is more than 40 years, you don't even wait for 6 months. So you intervene earlier. So you need to know when you need to intervene. So the talk was subfertility, which was slightly different for infertility. So my topic will be mostly focused on infertility as such, but subfertility is a condition where there might be some degree of maybe oligospermia, and the couple actually can conceive without any medical information after 12 months or so. So, but I say for the sake of the discussion, I will keep my talk restricted to infertility rather than on subfertility. But by definition, subfertility does not require much of treatment, and almost 17.5% is the prevalence of infertility, estimated lifetime prevalence. And if you are looking into period prevalence, it's 12.6% at one particular point of time. So the talk is on male contribution. So 30 to 50% contribution is from male. So if there is an infertility related issue, so female contribution will be 35%, male 30%, combined 20%, and in 15% of cases you won't be able to get an idea why it's so. And so And when you start with an infertility related workup, the first and apart from the history and physical examination, the first workup is a semen examination, and apart from the female's routine examination, and if it's abnormal, you need to repeat it. So this is the first and foremost workup if you are looking into infertility related issue. So history, physical examination, semen analysis, more than one if it's abnormal. So it requires 2 to 7 days of abstinence to get a semen analysis done. Ideally, it should be done when in the same lab where the semen is being analyzed. So if somebody is giving a home sample, it's not going to work. If somebody is staying in a remote area and plans to send the semen through, maybe after 5 hours it's going to be analyzed, so there will be abnormalities. So the semen analysis examination, first and foremost, we have multiple labs springing up here and there, so it has to be done immediately, preferably in the same lab, so that we need to make sure. And if it has to be transported, it has to be, so most samples what we tend to do, we send in a refrigerator on a fridge, so it has to be transported in room temperature. So if the temperature is not very high or not very low, you don't need to do anything. But if it's in that, otherwise, even they have said that if somebody is carrying the sample in an axilla, if the vial in an axilla, so that will also work. So these are the parameters for semen analysis for normal semen count. So the earlier we used to think that 20 million is the cutoff for oligospermia. The current cutoff is 15 million. So there are some changes in the recent WHO guidelines also. So anybody having a 15 million, more than 15 million count has a more than 90. So you can see that these numbers are based on the generally accepted 5th percentile derived from a study of over 1900 men whose partners had a time to pregnancy of less than 12 months. So if somebody has semen parameters above this cutoff, the chance to pregnancy in 12 months is almost 90% or so, 95% or so. So now after that, if you are looking into the male infertility part, so there are 3 aspects. So there can be low semen volume, there can be low oligospermia, astenospermia, teratospermia, and there can be absolutely no sperm counts at all. So what we will do is we try to understand the definition. So oligospermia is something which is the number of counts of the sperm is less. So by definition from WHO and American Society for Reproductive Medicine, it's 15 million as of now. So anybody having more than 15 million is having a normal sperm count. Astenospermia, when the percentage of progressively motile sperm is below the lower reference limit, and teratospermia, when the percentage of morphologically normal sperm. So again, the value for morphologically normal sperm is like 4%. So even if you see a lot of abnormal sperm, so even if you have 4% normal sperm, that's going to work. And these are the definition further. If you look close into it, that cryptozoospermia is something, apparently you will see a normal sperm count. You won't see any sperms, but maybe it might be relevant for IVF, that you will be able to retrieve some sperms. So this is the classification for azoospermia or oligospermia by Canadian Urology Association. So most of the guidelines, if you see, actually come from the Urology Association. So you can have 3 levels of problem which can cause azoospermia or oligospermia. One is pre-testicular, that is, there we have a prominent role. The endocrinologist can actually make a difference. If it's testicular, if there is a testicular damage, I am sorry that it will be, so if we do an ICSI or advanced test, so we stay, that might be helpful, or that can be it can be post-testicular. So for testicular and post-testicular, so it will be primarily the urologist and ART specialists who will be taking their role. But for us, if it's a pre-testicular cause, there is a very, very strong role of endocrinologist, and you need to understand it. Again, thanks to Anand Mohan for bringing this up. So this is, we all know, this is the physiology that we have GnRH secretion from the hypothalamus, then LH, FSH from the pituitary, which governs semen production, and this is the male reproductive part. And again, I am not going to go into details of it, but specifically, if you have a situation where the LH and FSH is inappropriately low or normal in the setting of a low testosterone, so obviously there is a role of that is called hypogonadotropic hypogonadism, and there you need to actually intervene. That is how you interpret the male gonadotropic hormone axis. Low testosterone, low LH, low FSH. So even in the setting of low testosterone, less than 5 million sperm count, and you are having a low LH and FSH, so that is something. So in that case, the normal physiology should have been the LH and FSH should actually go up as a measure of the response to the physiology. But again, if that does not go up, so if you see a normal range, the person might come and tell, oh, mera to normal hai, but again it's not normal. So this is how you interpret. So low LH and FSH in the setting of of a infertility, you need to be careful. So if it's all normal, it's post-testicular or mildly evolving cases of infertility. If LH and FSH is high and testosterone is low, so then that is obviously a primary testicular failure. So we can't give, in that case there is no point in giving hormones and endocrine intervention. So if there is some sperms which are there, which can be retrieved by highly sophisticated methods, so that might help. So again goes on to the domain of the ART specialist or a neurologist, not our domain. But if you have a situation where it's low or low, and even if you sometimes have a high testosterone also, so in the setting of anabolic steroid use, it's not very uncommon. So people who are going to gym, they have a high testosterone and the LH and FSH will be suppressed. So then also you need to be careful that what you are dealing with and how you can access it, you can help it. And there are mixed form also, and there are some cases of androgen resistance, like androgen receptor mutations, where you have high LH, high FSH and high testosterone. So our domain from the endocrinology point of view will be primarily pre-testicular causes, and you need to understand that what are the central hypogonadism causes. So it can be, so somebody can be having a congenital hypothyroidism from hypogonadotropic hypogonadism from birth. So that person will even require testosterone for induction of puberty. And at the time of conceiving, we do not give testosterone, we shift to HCG and FSH preparations. So that is one area. And if somebody can have functional causes also, and if not very uncommon causes will be diabetes and obesity. Santosh just discussed this, that if you treat obesity, that the this might come down. So this we need to understand. So we'll look into some cases. So this was a operated cases of craniopharyngioma at age of 11 years. So all the hormone axes are deranged. So in this point of time, if this person is planning to conceive, you need to stop. You can see the treatment which was giving. So it was testosterone gel preparation which the boy was receiving. But whenever he marries and plans to conceive, you need to stop testosterone preparation and shift to HCG and FSH preparation. You start with HCG, once you build up the testosterone levels, you shift to FSH. So that's how you go about it. Another very common situation which can help by endocrinology intervention is a case of prolactinoma. Very large pituitary tumors, apparently very alarmingly looking, but again, if you start cabergoline, so most of these patients actually do improve, and there are some cases will be resistant who will require treatment. But again, another area where you need to understand is that if you are having a large prolactinoma, so that is again an endocrinology domain. So you don't send to a neurosurgeon or a neurologist for opinion, you send to an endocrinologist. We follow it up and we try to make sure that the person is having the prolactin in the normal range, be it a male, be it a female. So we need to do that. So this is a case where I showed that actually the pituitary tumor has actually settled down. So the 2 to 4 years, maybe for a microadenoma usually give for 1.5 to 2 years. For macroprolactinoma it might be longer, but again if you try to intervene neurosurgically, so sometimes the pituitary itself gets extracted out and the results might not be very beneficial, and you might to need, keep on giving hormone supplements for a very long duration. So another area is functional hypochondrotropic hypochondroism. So this is very, very common. Dr. Santosh briefly elaborated on it, and you can, so if you are actually able to bring down weight, so that will help in male. So it does not only help in female infertility, but it also helps in male infertility. So the sperm counts actually go up if you are able to, and we have RCTs to demonstrate that if you are able to, so be it lifestyle, be it diet, or be it something like a GnRH analog, so many of those are coming up. Some of them are there as diabetic medicines, others are coming up in the next 1-2 years as anti-obesity medicines. They will all help. And so another very, very important area which I need to reinforce is people who are going to gym, they take a lot of testosterone supplements, anabolic androgens, and there is a protocol for stimulating HCG. I will just one minute more. Stimulating the sperm count. So if somebody is having, so somebody goes to gym, takes anabolic steroid, the sperm count goes down. So you can actually give HCG based combinations, and that can actually help to retrieve. So there are advanced evaluations for also for semen analysis. Again, will mostly come under the domain of ART specialists, and this is the approach to male infertility. So you need to understand that if somebody is having a pre-testicular, or in even some cases of testicular, cases of infertility, male infertility, the endocrinologists do have a role, and we can actually help out. Thank you again for your patient learning. Again, you can, if you want to take a picture, you can take it. Thank you again for your patient listening. Thanks to Anand Raman for giving this opportunity. And if there are any questions, I'll be happy to answer.
Thank you, Dr. Saptarisi, and a lot of evaluations, the classifications, and beautifully seen. So I have some little queries, like what type, suppose there is FHS and LH is low and testosterone also low, how will approach, what is the doses, what you are recommending clinical practice?
So again, so we need to understand, so if we are actually having a diagnosed case of hypochondroism, it can be something like a congenital case, or it can be something like the person, like one of my patients, they had a operated case of kidneyopharyngioma, all the hormones were low. So LH was low, FSH was low, testosterone was low, already was an androgen supplement. So you need to start with HCG first. So the dose you will be like 2000 to 5000 you need to start with, twice weekly to start with. You can go up to even 10,000 thrice weekly. So once the testosterone level becomes normal, it usually takes 2 to 3 months. You start an FSH preparation also. It can be a recombinant preparation, or it can be a preparation which is extracted from like menotropin, and so which is extracted from urine of menopausal women, or something like that. So combination of LH, HCG and FSH, and it usually you need to, if before you are starting treatment, you need to counsel the patient that, so if the time for semen sperm development is 90 days. So if the person is coming and the cost of treatment like HCG will be like, if you are giving HCG, so that will cost around 1000 rupees every week. If you are giving a recombinant FSH, it will cost another 1000 to 1500 rupees every week. So the person has to bear the cost for almost like 10,000 to 12,000 every month. The dose might go up, and you need, before starting treatment, you need to counsel that it will require at least 6 months. 3 months is a very optimistic number. If somebody is starting with a azoospermia, if somebody is starting with oligospermia, it might still work. But if you are looking into like azoospermia, so you need to counsel the patient that it's going to take a long time. So the usual recommended time, and what I see in my practice also, will be anywhere between 6 to 12 months, and some cases it might be even 12 to 18 months or 2 years also. So before starting treatment, they have to, the good thing is that some of the preparations are like subcutaneous preparations. So if the patient knows how to do it, how to inject it, so they can inject themselves like insulin. So you don't need to go to a doctor or a nurse for getting it injected. So there are subcutaneous preparation, they can inject it themselves. But you start with a proper counseling. It's going to take a long time, but this is something which can be done.
When do you decide for HMG? I mean, you usually follow a protocol of HCG followed by FSH-LH?
Most of the guidelines, so there are some guidelines, there are some studies which have said that you give an FSH also followed by HCG. But if you go into most guidelines and most reproductive society guidelines and most current textbook recommendations, this is a gray area. So you don't have a lot of studies to say that this is the best protocol to do it. But this is the standard protocol which most of the endocrinologists and most of the guidelines will suggest.
What about clomiphene citrate?
See, clomiphene citrate has, so there are studies with aromatase inhibitor, there are studies with clomiphene citrate. So some cases of functional hypogonadotropic hypogonadism, that is a term used for you don't have a structural or defined organic cause of male infertility. So there is somebody is having diabetes, somebody is having obesity, and the LH and FSH is low, testosterone is low, some amount of oligospermia. There are some studies which suggest that you can give clomiphene.
That's an oral medication patient
So, but again, the results are not that promising. So maybe whatever you are able to achieve by clomiphene citrate, you will be able to achieve more by weight loss. So somebody is going for a GnRH, somebody is going for maybe a GLP-1 analog like a say semaglutide, and we have the tirzepatide medication coming up in the next year. So that will help more than clomiphene citrate. Clomiphene citrate results are there. It has been tried on multiple occasions, but the results are not very promising. So had it been that promising, so it would have come into the regular guidelines. Results are borderline. So if you actually have a low testosterone and it's related to functional hypogonadism, I would suggest the first treatment will be lifestyle changes and weight loss medications. And then if it does not occur, then shift on to HCG. You can give a trial of clomiphene in between, but since it's an oral medication with not much of side effects, not much of harm, but in my personal experience, it doesn't work that much.
Any questions from the audience, please?
So if the volume, testicular volume is less, so we have criteria for testicular volume. If it's like less than 2 ml or 3 ml, so that cannot, and if the LH and FSH is high, so there might be still a very low chance that you can do an XC and do advanced methods of ART where you can retrieve the sperms if the person is very keen on having his or his own sperm for fertility. So, but most of these cases will actually require a donor sperm for an ART. So again, so something we need to counsel the patient. So if ART is only okay, if we can still give a trial, we can do a testicular biopsy and testicular aspiration and see. And if we have actually sperms coming out of you, we also need to do a DNA fragmentation analysis. So to understand the viability and the effectiveness of the sperm. So it will require a much more advanced complex procedure before we actually subject person to it. If the testicular volume is low, less than 2.5 ml, and if the FSH is high, so ultimately it will depend on the aspiration, not on the testicular volume cutoff. So you need to have a objective criteria to tell the person that your sperms are not effective. So you need to have a testicular aspiration and do more advanced studies to understand whether the sperm is effective. For hypo, so you see, once we go into one criteria is testicular volume. So, but rather if you are treating hypo, if you are giving HCG, the testicular volume tends to go up. So in that case, again, you will go more by the testosterone levels as an objective parameter rather than the testicular volume as an objective parameter. So if the testicular volume is in the normal range, you can start an FSH. And if some people do start earlier also, but most of the guidelines will recommend that if you are treating hypo, you give HCG, bring up the testosterone to the normal range and then start FSH.
Thank you, Dr. Saptarshi. We are so happy to have you explain so simply all the principles of management. And for want of time, we will not entertain any more questions.
Thank you.
Thank you so much.
Thank you.
Thank you.
Such wonderful sessions. Thank you. I request chairpersons and speakers to collect small mementos from us. The next is a very interesting panel. Panel will be moderated by Dr. Pramila Kalra, and I'll ask Dr. Pramila Kalra only to introduce the panelists as well. Thank you.
So I invite the panelists on the stage, and good afternoon everyone, and thanks Dr. Anand Raman for inviting me for this session. So first it's my pleasure to invite Dr. Shobha. She is the professor and HOD at St. Philomena's Hospital. So we all know Madam, so Madam please come on the stage, and she has a lot of achievements to her credit. So everybody knows of Madam, so I don't think we need to go into the details. And Dr. Varun, he is an endocrinologist, and he is associated with Apollo Hospitals and Magna Hospitals. And Dr. Shanmugasundar, he is a consultant endocrinologist, and he has also many accolades to his credit. And I also invite Dr. Lata. She is the founder director of WMN Healthcare Services Private Limited, and she is the lead consultant at Rangadorai Memorial Hospital, Bangalore. Hello, Madam. So this is a very interesting panel because till now we were discussing about type 2 diabetes, and we all know that we are seeing more and more patients now with type 1. Thanks to the introduction of newer insulins, to better care for type 1. Because if you see 20-25 years, most of the type 1s would not reach that stage that they would plan for a pregnancy. They would have developed complications by the time they would be in the reproductive age group. But now we have patients who are living longer, they are healthier, and they get married, they have normal life, and they plan for a healthy child. So that's what we are going to discuss, that how this reproductive health of a type 1 diabetes woman happens. We are going to discuss as of this topic, which is only for women. So this is for type, not that the audience should only be women. The topic is discussing only type 1 diabetes and reproductive health in women. So we'll have some questions with the panel, and then we also welcome audience to ask and comment, and so that we can also take up those questions if the time permits. So these are our panelists. I've already introduced them. So the first question, I'll start with Shobha ma'am. So, like you must be getting so many patients, because once the patient has some complications, they'll try to first obviously go to the gynecologist, and now they are aware that they have to go for a health check before they plan for a pregnancy. So when a type 1 diabetes lady comes to you and she says that I'm planning for a child, so what do you see? What glycemic targets or what HbA1c do you see, and when do you think that you first need an endocrinologist opinion to decide further or guide her further? So what all tests do you think? Obviously she'll need all the antenatal workup we do for a normal woman as well, but she'll need some other tests as well, and you will definitely be worried about her HbA1c. So how do you go about that?
Yeah, so I think it is a very critical part of management is preconceptional care and advice, and Pramila is rightly saying that glycemic control remains the key factor for success of pregnancy. We often want our women to be preferably less than 6% HbA1c, though most guidelines tell us that it should be 6.5%, but we try to make it in a way that they kind of go for a stricter control. 6.2% or 6% is what we'll be looking for. It will also matter to us whether she is having any end organ damage. So we want an evaluation, especially of the eye, the kidney, etc. And then subsequently, if these are affected, of course, the heart, etc. Also important to find out if she has any other nutritional deficiencies, and also put her on preconceptional folate. The glycemic glycemic targets in terms of blood sugar levels will be pretty much, good only if the HbA1c is under control. It should not be, she should not be frightened into becoming pregnant, rather encouraged, and the diet needs to be also looked after. Even though we feel that it is less important than in type 2, the diet also needs to be looked after. So, yeah, and I would just like to thank Pramila for being here in spite of your personal commitment. Thank you.
So, as rightly pointed out, like Madam said, that the glycemic targets are the most important thing she would like to see, and then she would definitely like to see for complications. This is very important because many a time they may be having retinopathy which is undiagnosed, or they may be having nephropathy or neuropathy, whichever is there. It doesn't deter them from planning pregnancy, but we need to take care of that during the pregnancy. And also, as Madam rightly pointed out, that she would definitely like 6.2, at least below 6.5. If the patient is not getting much hypos, but obviously if the patient is getting hypos, then Dr. Varun will tell us how maximally we can go for the HbA1c, like to what limit beyond which he will say, no, this is going to be a little bit a difficult scenario. But Madam raised a very important point that we should tell her a positive thing. We should not tell that you will have all the complications during your pregnancy, because I have seen many type 1 diabetes women not planning for a child, thinking that they'll get a lot of complications. So that is not the message which we are trying to communicate. So that's a very, very important point which we should remember always in our practice. So Dr. Varun, now as Madam said that she would definitely want a 6.2. Now this patient has come to you with HbA1c of 7.5 say. So how would you do the workup now, and what would you try to bring it down to? We have a patient who is getting frequent hypos, and we have a patient who is pretty well controlled, not having much of hypos, but her HbA1c is 7.5. So will your management differ for both of these, and how will you go about it?
So the main concern with preconception diabetes with higher blood glucose levels is the chance of risk of like congenital malformations. The malformations risk increases with the increasing HbA1c. Especially when HbA1c goes beyond 8 or something, the risk becomes unacceptable. So in all these patients, I mean, some of the guidelines suggest to have HbA1c less than 7, and some of the guidelines suggest HbA1c less than or like around 6 also. Again, it depends upon the regimen of the insulin like the patient is on. Ideal regimen would be like patient who is on basal bolus, who is doing carb counting, and who understands who understands the management and is following up with us for a long period of time. We would definitely be targeting a HbA1c of 6 or 6.5 in patients who do not follow up regularly but still want to conceive, or there are some economic issues wherein a patient is still using on like premix. In such patients, we would like to keep HbA1c around 7.
So as Dr. Varun rightly pointed out, that it may be difficult for every patient to come down to 6. So we are not targeting 6 for everybody. But yes, we know that at least below 6.5 is a good target which we would try to achieve. But still, if we are able to achieve at least 7 and below, we have done pretty good job. But the thing is, also we have to remember that all type 1 diabetes patients who come to us for any reason, we have to see that they are on basal bolus. That's the first thing we have to counsel them, because many a times we do see that these patients might be on premixes and they may be thinking this is the best choice, and that counseling has to come from all of us, that there is no premix concept at all in type 1. It has to be a basal bolus. We understand that a lot of type 1 patients may not be able to afford the analogs, and that doesn't mean that they cannot control their glucose values. Yes, as Dr. Varun rightly pointed out, we might also be worried about hypos, and we will have to maybe do some monitoring, maybe a CGM for these patients to see what's happening and try to bring the HbA1cs to target. But yes, beyond 7.5 will be difficult. We know it's good to keep below 7, but sometimes that we go with that 0.5 thing and follow up, and we give them the adequate counseling. We have to tell them the right thing. We can't say that this is going to be the best and there will not be any problems. There may be a chance, but yes, we need to follow up. So coming to you, Dr. Shanmuga. So like you must be seeing so many patients of type 1, and these patients mostly will come and then you will diagnose that they'll have complications or they'll have some of the other comorbidities existing, and they are planning for a child. And nowadays we are also seeing that they plan for a child quite late, and they may be around 35 plus, and those hypertension, other comorbidities might be existing. So, or we know that these women may also be prone for PCOS. There are reasons for them that they can get also PCOS. And now I have lots of patients of mine who are type 1, who are overweight or obese, and they have PCOS also. And they have been on huge dose of insulin. So how well we can manage these patients, because this is a very big gray area where we do try to manage all the things together. So how well we can do that?
So one important thing is before conception, any patient with type 1 or type 2 diabetes, any form of contraception they should follow. So we should make sure that their HbA1c level and the overall the glycemic parameters are under control before they plan for pregnancy. Because many times we see, most of our patients we see, they will have unplanned pregnancy. They will come with HbA1c more than 7 most of the times when they become pregnant. So that counseling is very, very important. Absolutely. Because there are data to say that well-planned pregnancy with HbA1c control versus unplanned pregnancy, the stillbirth, the congenital malformation, perinatal events, all are very less in the well-planned pregnancy. That's very, very important. And particularly in type 1 diabetes, as you rightly said, there are complications we have to see. So we have to look for retinopathy. Again, it's very important, because if the patient wants to become pregnant and if you are treating over enthusiastically, sometimes the retinopathy can get worse with fast reduction in the blood glucose also. So before going for the treatment, we should check for whether they have baseline retinopathy, whether they have nephropathy, because again, type 1 diabetes, they are at risk for preeclampsia. So nephropathy can worsen and the proteinuria can worsen. And after delivery, the chance of going for a renal complication is more if the patient has underlying retinopathy, and also hypertension. Again, these patients are prone for hypertension, and again other autoimmune disease like hypothyroidism or hyperthyroidism is very, very common association with type 1 diabetes. All those things has to be seen, has to be controlled before going for pregnancy. And during pregnancy, again, there are clear-cut guidelines are there. So we should start aspirin at the end of the first trimester to prevent preeclampsia. So hypertension, as like non-diabetic patient, the target less than 140 and 180 should be targeted with appropriate medications. And retinopathy, if they have retinopathy, every trimester we should follow them for the retinopathy. And if they have the proliferative retinopathy, it's better to do the laser therapy before going for the pregnancy. And nephropathy, again, it's again a slightly dicey situation, because many times during pregnancy they will have proteinuria, but at least we should have a baseline status, what is their proteinuria status, and appropriately we can follow during the pregnancy.
So absolutely, these are very important points, because these women may be already having the complications. Again, the same thing that, as Madam also said, that we should never say that you cannot plan for a child. Definitely they can plan for the child, but we have to monitor. And also PCOS, because of the high dose of insulin, many of these women might develop PCOS because of exogenous insulin, and they may also be having anovulatory problems and anovulation. So coming for that to Dr. Lata, because
sorry,
you might...
Can I just add on a couple of points
please,
here?
Please,
if you don't
madam,
mind.
please.
Okay, pre-pregnancy counseling is very, very important.
Absolutely.
I think we have to take a lot of time to, with the couple to explain
Absolutely.
why it is so very important. Because it is not only congenital anomalies, complications of pregnancy, but it is the mental, cognitive disorders which can come in the progeny, especially the autism spectrum, etc. It's being related to the first trimester hyperglycemia, and also the complications of pregnancy are also related to the first trimester hyperglycemia. So, preeclampsia, prematurity, all these in type 1 especially. I think it's very important that we take time to counsel and make sure that their pregnancy HbA1c is normal. But even if she embarks on pregnancy with higher HbA1c, I think even with a HbA1c of 11 to 14, it is 20% congenital anomalies. Of course, the other complications might be higher. So, type 1 getting pregnant itself is slightly difficult, and fertility, because of the fertility issues involved. So, I think it's important to counsel them and encourage them to sort of continue with the pregnancy rather than say, look, you abort because there are many people who want to sort of say that pregnancy should be aborted. As gynecologists, we are very keen, we are very pro-life, as obstetricians. Okay, thanks.
Yeah,
sorry.
absolutely, madam. So
Yeah.
that is what we were coming to the question, that they may have problems with conception and they might need to undergo IVF. And it's not that only type 1 women might need to undergo, there may be other women also. But maybe because of their other comorbidities, or as we know that because of high dose of exogenous insulin, they might have developed PCOS. So we are seeing lots and lots of patients like this. So what are the specific challenges you face when you go for IVF for these women?
Yeah.
Yeah.
Anovulation is a common problem with type 1 PCOS. Obese, they can be very lean or obese. Both can cause some hypothalamic problems, and also insulin resistance itself can impair the fertility in when there is, well, of course, here it's type 1 we are talking about. So these are few issues, and also there can be implantation problems. There is the follicles can undergo apoptosis at the drop of the hat in these women because of hyperglycemia, fluctuating sugars. So the quality of egg might not be great. And also I even wonder, because of their proneness to premature menopause, in delayed menarche and early menopause is a problem with type 1 diabetics. So whether we should talk to them about follicle, oocyte storage, etc., I think that should also be sort of thought of if they are getting to 30 plus when they are trying for pregnancies. So anovulation can be a problem. They might need higher doses of gonadotropins and also the clomiphene citrate aromatase inhibitors. They are more prone for OHSS also, and implantation failure is more common, and of course congenital anomalies, etc.
Absolutely, like rightly pointed out, because as you told that, and also their insulin levels and the glucose values go very high when the hormone therapy started, and that also they may have a lot of fluctuations, and sometimes they may have a lot of sometimes nausea, and that's very difficult to manage, and we can't skip. So all these problems do happen, and as you rightly said that they may be prone for early menopause as well, and they may be having other autoimmune problems as well. So even hypothyroidism and other things, and even celiac may be there in many of them. So those are other things which become little bit difficult to manage, and absorption issues and all those problems do happen. So going ahead from there, because before they plan for a child, many a times we do see that type 2 diabetes patients have lots of their sexual health issues which the women normally don't discuss, and they don't think that it's pertinent for them to come out with that. So even in type 1 it's even less discussed, because they will not ever discuss with us. Even if we ask proactively, they'll tell it's all fine. But do you specifically see, because sometimes they like to talk about it with their gynecologist, so do you think that there are any specific sexual health issues which you see in these women?
In these women, I think there is more tendency towards vaginal dryness, and they do have the prolonged insulin therapy also probably reduces the sex drive. So there is a reduction in libido. The background of diabetes is actually enough to make a woman very worried to begin with, and in human beings it is not always just a kind of a physical drive. It is a lot to do. It is a psychosexual matter always, and the woman needs to be in a happy frame of mind. Well, fortunately, fertility and sexuality are not kind of interdependent too much. And women who want to conceive, even without a sex drive, she will manage to have no timed intercourse, and she will manage to conceive. So it's more of a reproductive health matter than a fertility issue. And we can guide her through these problems, because today a lot of agents, moisturizers, etc. are available. And then there are ways of dealing with contraceptive methods which will make them feel more comfortable for sexuality. So these are some of the challenges. I would just like to add on to that IVF complexity which you said. Now these women need to have an early resort to a fertility center.
Yeah.
We don't look forward to giving them one full year of trying on their own and whatever. So we don't exactly label them as infertile before 1 year is over of contraception free intercourse, but we can label them as subfertile and then refer them early to fertility specialist.
Absolutely,
Now,
yeah.
fertility issues, infertility treatment in this group of women is a very vast and difficult, may not come within our panel discussion.
Yeah,
but Lata has very cleverly told us that these women, we find it hard to get good quality oocytes.
Absolutely.
Very hard to get good quality. So every step is a challenge in them. So ovulation stimulation protocols and the fertilization rates, the implantation rates and the carry home baby rates, they are all, and added to that is a difficult pregnancy. So what she also brought out very well is a family counseling here. So we need to have a sit down. So whenever it comes to pregnancy, we need to have an added counseling to what you usually do. And that is invaluable because throughout pregnancy, there is a need for support and more intensive management and more monitoring and more expense. And then if there is a preterm delivery, then it adds terribly to the expense. So all in all, therefore preconceptional counseling, early pregnancy counseling, and subsequently also, and the team should be built up. You are very aware that there has to be a team which includes the endocrinologist, and which includes the neonatologist when the time comes also. Yeah, thank you.
That's very important, as you rightly pointed out, because if you see, macrosomia rates are quite high in these women, and it is very, very important that we counsel them, and counseling is the most important, because as endocrinologists, we have seen type 1 diabetes women, when they get married, many times they just stop their insulin because they don't want the husband to know or the family to know, and they'll shift to premix just to hide it or take less shots. So all sorts of these problems we see. And it's a very big problem for them, because to manage that and to take care and to make the family understand that this is not some disease that they're suffering from and they'll have problems. So this is how we have to counsel, and counseling of the whole family, even the family where the lady is staying, is also very important, because they need to understand that they have to be supportive and not cause problems more for her with her control. Because we had patients who were very well controlled before their marriage, and all of a sudden after marriage they come with decay. So these are the problems also, and we try to do the best, but we know that our social setup is like that. Sometimes it becomes unfortunately very difficult for some women. Dr. Varun, so we know that these women are getting pregnant and they are coming, and we try to maintain the values, and we know it's a very tough task. It's not easy to get the glycemic control to the target what you want. So do you use frequently CGM for these women, and how frequently you tell them to do the SMBG? Because obviously they will say, already there is so much of stress, and on top of that, this one addition of the cost is also there with so many strips, CGM. So how well you tackle that? Because there are women who may not afford to do so many, there are women who can do everything. So how do you tackle that?
So in ideal scenario, suppose if there is insurance coverage, or like if the patient is affordable, for all the type 1 diabetes should be on like CGMS.
Yes.
So that's the ideal case scenario. So in our setting, wherein most of the patients will not be affording, we should be using the self-monitoring of blood glucose in an intelligent way, in a more structured way, from which like we will be able to get information, and we should train the patients also in terms of adjusting the glucose values. So about it, like at minimum, like at least 3 meals is like one way of like going about it, or fasting and like 3 post meals is also another way of doing it, in case if the glucose levels are perfectly controlled, and the targets for them would remain the same for any other like woman in diabetes. During pregnancy, fasting level of 70 to 95, and post meal at 1 hour less than 140, that will be the target during pregnancy. And in case if there is a lot of fluctuations in terms of glucose control, for shorter period of duration, we can ask for all the like pre and post meals. And regarding the usage of CGM practically, especially when the glucose levels are going to be fluctuating around the end of the first trimester and around the peripartum, I mean, that would be just like 2 or like 3 sensors, which most of the patients should be able to afford. We can use it smartly so that cost also will be optimized for the patient.
Absolutely. So this is very important because as you said that judicious use of the things has to be done, because suppose we tell them, no, you start doing so many now only, then they may just do it in the beginning and may not carry on with that. But we know that we have to tell them that they have to do SMBG throughout their pregnancy. That's a must, and judicious use of CGM can be done depending on the patient's affordability, but it definitely helps in these patients for getting a better glycemic level, and especially in IVF patients where there are too many fluctuations. So, madam, you want to say anything? Yeah, please, ma'am.
Often compliance is a big problem.
Absolutely, ma'am.
Yeah.
Yes.
So, and also there is so much of social stigma. I mean, oh, should she be pricking so many times, and 4 doses of insulin at least, 6 or 7 SMBGs, 11 or 12 pricks a day. Nobody would like to sort of have it in pregnancy. CGM is a very great boon.
Absolutely.
And also we can have a much better control. Okay, the scientific evidence wise, there are still debates going on because SMBG has to be used as a, as a, what can I say,
along with the CGM, we have to do the SMBG, because
SMBG.
For lows and highs, the CGM may not be very authentic, and we
right.
might not be doing the adjustment on that basis. So we do need to do SMBGs with that.
Yeah, it doesn't sort
of, but it helps, because it helps.
Helps
because at least some pricks can be definitely reduced, for sure.
Yeah, thank you.
Yeah.
I also needed to know some facts on this, because I just needed to know the relative cost of from all of you. What is the relative cost of CGM and SMBG? And also, because see, what we have seen is that the expense is slightly more. It's actually, some women cannot afford
Absolutely,
CGM.
yes.
So what we are having in our practice, both for type 1 and type 2, of course our type 2 volume is very, very high.
Yeah.
So we do SMBG, and
Absolutely.
if that is not working, it's a very brittle diabetes and having an impact on pregnancy especially, then we quickly go on to CGM. But we'd like to offer the woman in the beginning itself, and most often they choose SMBG.
Yeah, Dr. Varun, you would like to comment?
The CGM, like, which is available in Indian market, only CGM, that is Libre, like it costs for, if you want like real-time monitoring, it costs around 4,000 to 5,000 range for 2 weeks. So for a month, like, a patient will have to spend around 10,000. So for a continuous CGM usage, it may not be practical for a lot of our patients.
But only thing is, like, we also have to see the use, because sometimes the child is very precious for them. And it doesn't, I have seen that whenever we talk about disease, we also talk about what is the long-term impact. So like, if a woman gets a pregnancy and it saves her marriage, I think it is justified. Maybe like what we do is we don't use CGM every month, maybe 15 days we use, and then we give a gap of 1 month, again use it. And SMBG is definitely to be done, and we get strips at a very less cost also nowadays. And if they buy in bulk, the cost is much lesser. So they can actually afford those things, and I have seen that they are ready to spend that much in pregnancy to get the child okay, because if they get a complication or some problem in the child, it will actually end up more of not only mental health, psychological, but more of money spending for them before life. So I think that way we tell them to balance. And it's not that everybody has to do CGM. SMBG is good enough. We have managed so many type 1s with just SMBG. But yes, we have options. So if they ask, do we have some options? Yes, these are there. If you want, use them. So this is how we offer. So as Dr. Varun also pointed out, the similar thing. So coming to Dr. Shanmuga, like this is also a thing, like we normally say, okay, we can use the conventional human insulins and that's no problem. But when a woman is pregnant, we are a little bit worried because she should not get a hypo also, because we try to control the hypers, but hypos are a big problem, especially in type 1s. We do have lots and lots of problems. And they then tend to become very panicky because of these. So what are the specific insulins, or is there any specific insulin, I should ask like that? Or do you think that all are equal, or you would suggest use of analogs more in these type of women? And also, any specific dietary advices? Madam did allude to about the dietary advice, but how do you best manage it? Because many a times they have their food fads, they are not able to eat few things, family doesn't allow. So how do you manage these things?
See, again, recent ADA guidelines has not recommended any particular insulin options.
Yes.
So again, case to case basis, we have to decide based on the affordability, the risk for hypoglycemia, the present glycemic control, whether the baby's fetus growth is adequate or not, or it's large for gestational age, etc. So, but according to the FDA recommendations, the Detimer and the human insulins, Aspart and Lispro are classified as Class B, and this Glargine and Degludec is classified as Class C. But if patient is already on the insulin like Degludec or Glargine and it's well under control, we usually continue the insulin. We don't try to change the insulin so that may change in the blood glucose control. So usually we don't do, we continue the treatment. But if we are going to start with the insulin analogs, and then preferably we start with Degludec plus Aspart or Lispro. And that's about the insulin. And the specific dietary advice, again, carbohydrate counting, as madam was telling, carbohydrate counting is very, very important. So according to their carbohydrate counting and their insulin sensitive from the previous experience. So usually we give 1 unit for 10 to 15 grams of carbohydrates. So according to that, they have to calculate. But guideline says we should not restrict too much carbohydrate also. That can lead to again IUGR, again increase the risk of preterm delivery, etc. At least 175 gram of carbohydrate per day, and 70 gram of proteins and 28 gram of fibers should be included in the dietary regimen, and it should be a nutrient dense carbohydrates, and more of MUFA and PUFA should be included rather than saturated fat. So this kind of dietary regimen, with the help of the dietitian, we should include in the diet regimen. And intrapartum management, again very, very important, because what we have discussed about is about the congenital malformation, large for gestational age, all those things. It all depends on the first trimester blood glucose control and long-term blood glucose control. But intrapartum blood glucose management is very, very important to prevent the metabolic complication in the neonate like hypoglycemia, hypocalcemia, hypomagnesemia, respiratory distress in the neonate, etc. So intrapartum management is again very, very important. Again, depends on the type of delivery, whether the patient is going for a cesarean or the induction for the normal delivery. So depends on that, we have to decide. Again, we should try to keep the blood glucose around 80 to 120 during the intrapartum, because data says anything more than 140, the neonate is at risk for hypoglycemia. So usually when the patient is allowed to take orally, we usually continue with the routine insulin regimen. When the food intake is restricted, then usually preferably give insulin infusion with dextrose infusion if the blood glucose is going very low. And if the blood glucose we are able to manage, we usually give insulin infusion.
Yeah.
Absolutely.
Just wanted to say a little bit on intrapartum, that when a woman is laboring, that itself is a kind of, a starvation state. So we would like her to have around 100 to 120 sugars,
right.
Not less than 100.
Yeah,
because
definitely.
that makes her feel very
Absolutely.
weak actually. The other thing is she should be very well hydrated. Hydration is very important for normal progress of labor. Pain relief is very mandatory. So those are general principles of labor management, and of course aseptic technique is paramount in them. There are more. So that is something very standardized, intrapartum management. My question was to all of you was about insulin therapy, because we do not resort to Lispro and Aspart to begin with. So we are more grounded, and we tend to use the rapid acting and the intermediate acting and the mixtard and human mixtard and human. So is that era completely gone? Because that is very cost effective for us.
Yeah.
And then only we go ahead with the other. Our endocrinologist doesn't give Lispro and Aspart.
So only thing is that first thing is, even if it's GDM, we give basal bolus only. That's what we do most of the times. But
So when
it's
you
not
say basal bolus, what exactly
it is
means?
meaning that either a regular or Aspart or Lispro, this is bolus, and then we give a basal, like which can be Detemer or Degludec. This is what we give as a basal. But your question, first thing is, if it's a type 1, it has to be basal bolus. There's no controversy. We have nothing, even if it's a before pregnancy, after delivery, during pregnancy, it has to be basal bolus for type 1. So type 1, we cannot use premixes for sure. Some of the people are comfortable using premixes for GDM, but the problem which happens, there will be postprandial excursions. So premixes are very difficult, and we cannot control those excursions nicely, and we cannot get that profile which we want. So we prefer using basal bolus only during pregnancy, even if it's GDM. She may not require all 3 times shots. She may require 2 shots, and maybe night she may require only long acting. That also happens. Third thing is using the type of insulin, like especially in type 1, where you have some excursions happening and then a fall is happening. Sometimes we are comfortable with analogs. In those cases, it's not mandatory to use analogs for all patients. There's no mandate like that. But you may use it on a case-to-case basis where you have hyper and then hypo and you're not finding it easy to manage with your conventional, you might like to go for analogs, but long-acting analogs are preferred definitely for sure in type 1 for the reason they are actually long-acting. Like if you give NPH, you have to give 2 times a day for type 1. It won't work with once a day. Yes. Even if the glargine is continued for a woman who is type 1, again it will not work for that much, like full 24 hours what you want. So most of the times nowadays we have tried using more of degludec in such women because it does give us a flatter profile and with 1 basal shot with the 3 bolus. For type 1. Type 1 it has to be basal bolus. Now, if she is pregnant, she is before pregnancy, after delivery. But a type 2, we have to also see post-delivery how she is doing and then we decide. A GDM woman would definitely do better on a basal bolus, not necessarily that she will need all 3 shots. She may need 1 or 2 shots and maybe a basal, or she may need only 1 shot. That we have to see. But premixes are difficult to titrate. Dr. Varun, you want to add something?
We have a high concern about hypoglycemia.
Yes, that's the reason we do this.
And especially towards term.
Absolutely, absolutely. So we tend to reduce the dose also. Sometimes nearing term, their requirement definitely comes down. We tend to reduce, but it becomes easier with the basal bolus to do that. With premixes, it's very, very difficult.
Flexibility is more with basal bolus compared to the other things.
Absolutely. And Dr. Lata, so just many women who are pregnant, like even type 1 or type 2, they will say, now I have to go for a cesarean for sure, and early induction is needed. So that question Dr. Shobha will answer next, but your question is, do you need to do early induction in these women who are type 1, or do you decide on the basis of the macrosomia or the glycemic control or baby's health, or it's a universal guideline?
Yeah. Thank you that you have asked about the induction.
Yes.
That indirectly means that we are aiming for vaginal delivery.
Yes, yes.
Okay. Otherwise,
yes,
most
that's
of
right.
the obstetricians
because that question is next, cesarean.
So, okay. So, yes, if there are no fetal or maternal complications, more towards 39 weeks. Yeah. Okay. Because the 35 to 39 is a very important period for the fetus for its frontal lobe development, and so it's very important. And also these babies tend to be 2 weeks behind in their lung maturity. Absolutely. Any sort of pre-existing diabetes. So we tend to induce them between 38 and 39 weeks. Okay. But early induction is indicated when there are comorbidities which are causing maternal or fetal complications, or if the sugars or the insulin requirements are reduced more than 15 to 20% and it is steeply coming down, we would be worried about intrauterine demise. But 36 weeks and beyond, insulin requirement is likely to come down slightly, but if it is beyond 15 to 20%, we have to be a bit more careful.
Absolutely.
The other thing is, if there is macrosomia, one has to be careful. And if it is crossing 3.8 at any stage of gestation, I would say we have to be careful because the chance of intrauterine fetal demise is quite high. Absolutely. So these are the few indications for this thing. What specific precautions for newborn? We have to sort of continuously monitor both the mother and the fetus during labor. There is no choice. We should deliver in such centers where these facilities are available. Absolutely. For surveillance, close surveillance, and also immediate cesarean section, and also a neonatologist who would be available. So neonatologist, why should he be available? Because there could be respiratory distress. And also transient tachypnea of newborn is much more common, especially with polyhydramnios and things like that. Neonatal hypoglycemia and also hypermagnesemia. All these have been, and also they are more prone for convulsions. So I think all these put together, we should be prepared, well prepared for the delivery of this lady. And we should be prepared for shoulder dystocia because of the increased bisacromial diameter, and we should have practiced skills and drills. And even with a smaller baby, you can have shoulder dystocia because of increased pad of fat. So Absolutely. These are the few things that one has to be careful about. Thanks.
So
again, this following up from there, because as I told that most of these diabetes women, when they conceive, even if it's type 2 or type 1, they'll say now 100% I'll be having a cesarean. So what is like, how do you decide, like this woman can deliver normally, like madam told few of the points about the complications, but like are there any other factors which make you decide?
Correct.
Yeah.
So mainly, I think obstetricians also need to have a little wake-up call here, that the indications for cesarean section cannot be diabetes.
Yes.
That is very important. And it can be fetal macrosomia though, which is as a consequence of diabetes. But evidence is very ample, and it says that performing cesarean section does not remove all shoulder dystorcias, because the main fear are two. One is shoulder dystocia, and the other one is intrauterine demise during labor. Yes. So these two factors makes everyone, because when we counsel, we tell them all these complications, so it makes them actually, you know, morbid fear will be there that something will happen to the baby. So that is the skill that we have to exercise, and we have to tell them that less than 3.8 kg, it is possible to have, you know, and then there will always be indications during the progress of labor, which tells us that, okay, this baby will not make it through this passage, like delay progress and early rupture of membrane and some amount of changes on the fetal head, and suppose there is a fetal compromise, etc. So that is, you know, that can be tackled at that time. So what the main message is, diabetes cannot feature as an indication for cesarean section. Even ill-controlled diabetes cannot, because even if it is not controlled at term, the primary aim should be to control it, because whatever the mode of delivery, the impact on the neonate is going to be similar, whether it is cesarean or whether it is a vaginal birth. Probably vaginal birth gives us more time to stabilize the metabolic changes in the mother, so that the baby has a better, you know, the better levels of sugar, etc. at birth. So therefore, there should be a high preference for normal delivery, and those units who have spent a lot of effort in the antenatal care for glycemic control are more likely to achieve vaginal birth.
Absolutely.
So that is how it goes. It is a success story of antenatal care, which will translate into a success story in the labor room. There cannot be any other way. All right, there cannot be any. So there are no shortcuts to the labor room wherein she just comes and says she wants a cesarean or she wants a normal, etc. It is hard work for the entire team throughout pregnancy. And then if we have insisted on the exercise part of it, because we spoke about diet and we spoke about insulin, we did not speak about exercise. So if we have told her that throughout pregnancy she has to be ambulatory, that will be very good for her, and especially in the third trimester. There's a good effect on the pelvic give way, good effort for initiation of uterine contraction. We may not even be needing to do an induction. She may go into spontaneous labor. So if she follows that, then I think there is very good chance of vaginal birth. Yeah.
Absolutely, absolutely, very rightly
One
said,
more
ma'am.
point,
Yeah, please, ma'am, please.
Vaginal birth prevents or reduces the chances of the progeny becoming diabetic because of the gut programming,
microbiome and a lot of
microbiomes. So I think it's important that we give them vaginal delivery. All of us should prefer to give them vaginal delivery if we had to reduce the incidence of early onset diabetes.
So, Dr. Varun, like that post-delivery will get a call, and when you go to the labor room, the sister will say, we put her on sliding scale. So, it's okay. So, how do you best manage that? Like, what do you do post-delivery? Because you know that's the type 1, yes. And if the insulin is not given, she may land up with a problem. So, do you manage with infusion? Because she might have undergone a cesarean, she may be NPO for some time. If it's a vaginal delivery also, they may allow early, but after cesarean, she may be NPO for till the next day morning. So, how do you manage without infusion or with infusion? How do you do that?
For a type 1 diabetes, even if the patient is fasting, we need basal cover. If we stop the basal insulin completely, they are going to land up. And in hospital setting, we know, like, although we tend to talk multiple times, like in conference, that sliding scale is trashed, like it has been trashed for like many decades. Still, like, yes, it is followed.
Unfortunately followed.
We need to re-educate.
Yeah.
We need to educate and re-educate our team in terms of like not just the doctors, also the nursing staff and like other person who are taking care of the patient. And once like post delivery, the requirement will fall back to almost the pre-pregnancy range. And in lactating mothers, the requirement tends to be slightly lesser, around 10% lower than.
Yeah, we are coming to lactation with Dr. Shanmuga. He'll be telling us. So Dr. Shanmuga, the next question is that only which he was coming to. How do you manage during the lactation? Because post-delivery, as he rightly pointed out, we have to see that insulin goes on, whether we give infusion. That's the best way sometimes to do, because it will be difficult. Sometimes there may be NPO and all those problems may be there. So we manage it, and the patient is now going home. And she says, now I have to breastfeed, so I don't need to take insulin, I think. They'll say like, or they will want not, they'll say, I'm feeling very hungry. So how do you counsel them, and what do you tell them? How many times they have to monitor, what they have to do?
See, again, immediately after delivery, there can be reduction in dose. That's very important. We need to explain to the patient there can be reduction to the tune of 30% from the pre-pregnancy dose requirement. So usually after 2 weeks, usually there will be again increase in the dosage requirement. So they should monitor regularly, so that they should not land up in hypoglycemia also, and later on in the hyperglycemia also. So that expected changes we should explain to them. And lactation, it's similar to the type 2 diabetes or any other non-pregnancy state. So lactation should be encouraged, and that is beneficial for the mother and for the neonate, for the both. Very early.
Yeah, early.
As soon as you should not delay.
Absolutely.
Because the neonatal hypoglycemia, again, the incidence also get reduced by early initiating the lactations.
Yeah.
So it's the same thing. And again, type 1 diabetes diet and insulin, it's easy. According to the carbohydrate count, they have to adjust their insulin based on the previous experiences. So same thing can be continued.
So basically, as you rightly said, that lactation should be promoted at the earliest, because sometimes they have this concept that they should not lactate their child, they'll pass the diabetes to the child or something. These concepts are there. So we have to counsel them, promote lactation as soon as the baby is born, as Madam said. And also, as Dr. Shanmuga said, that we have to reduce the dose and tell them to monitor. And then we can do the titration, but also we have to see that they take good amount of calcium, vitamin D, and protein also in their diet. Because many times they just only are taking carbs and they don't focus much on the protein intake. So that also has to be taken care of along with their good calcium intake. So now once this woman is going home, for both Madam, for you and Dr. Shobha, so what contraception advice is best for these women? Because that's $1 million question. Now they have conceived, they had the child now, but they'll many times come with recurrent pregnancies and they'll abort, and that we don't want that to happen. So what's the best contraception advice for a type 1 diabetes woman?
Yeah, if they don't have any vasculopathy, you can even give COC, but not when she is breastfeeding.
Absolutely.
But progesterone only pills
Right.
can be given, and also IUCD is one of the best forms of contraception, to sort of answer in brief. Okay. Or the Mirena, that is, which is, LNG I used, which is better than actually sterilization,
Absolutely.
the fecundity rates.
Absolutely. Yeah, Madam.
Yeah, so I think that was well answered. Just wanted to add that usually providers hesitate to prescribe hormones when a woman is already on insulin. They will think that that hormone, and I am also prescribing hormones. So there's no need to worry because the contraceptive hormones are very low in dose and they get rapidly metabolized, and they have gone through good safety profile. So Lata has clearly said that when there is no end organ damage, and I would add to that, and the underlying disease should be well controlled.
That's
so
very
in well
important.
controlled diabetes, it is possible to open the entire basket of choice for the mother. And there is one concept which says that immediate postpartum contraception is very beneficial for women who are having medical comorbidities. And one of them, as Dr. Lata said, is an intrauterine device. And there is a very good practice in public sector today of introducing the copper IUCD immediately after birth. And that is definitely not contraindicated even in a diabetic woman, provided she is having good glycemic control. So intrauterine devices do not promote any infections. They can be provided to the mother under aseptic precaution. So also can the new contraceptive, which is the implant. It has etonorgestrel, which is a simple synthetic progestin. It can be placed in the arm just under the skin. That also can be provided. And they are all safe in lactating mothers. They are all safe in it's only the estrogen containing COCs which we need to provide after 6
lactation
months.
stopped.
Otherwise, it can continue with that, but it should be well established. By 6 months, we can start COC and the woman can still continue. So estrogen containing pills can be started after 6 months. The woman can still continue the lactation. There is no problem with lactation continuation. Yeah. And then, Pramila, very important that these women define their reproductive intent. It's very important because that is something we fail to establish. They should clearly plan their reproductive life. How many pregnancy and at what intervals. That will make life easy for the care provider a lot, because we can tell them this many years of spacing and preconceptional care and then again another pregnancy. And definitely women must limit the number of pregnancies, especially type 2, even type 1, because every pregnancy put them at danger of, I think there is some advancement of the underlying disease during pregnancy. Definitely there is some advancement in the burden on the target organs of the glycemic burden. I must say that pregnancy deteriorates their long-term course. So less the number of pregnancies, the better it is. Yeah.
Dr. Varun and Dr. Shanmuga, you would like to add any few things? Final take home? Yeah, ma'am, please.
Okay. Yeah, I think it should be an MDT, which is very, very important, which should be available under one roof. And it's very important that we don't shunt our ladies to see again endocrinologists, come back to us, etc., etc. It should be a combined clinic with, it should be a proper multidisciplinary diabetes and pregnancy clinic. That is one thing. The other thing is the support group, that is the pregnancy diabetes group would be very important for women to support each other, feel comforted. These are the two important things that, Magna, congratulations for starting this group, but we would like to see more number of pregnancy diabetes clinic, Magna pregnancy diabetes clinic. Seriously. Thank you. Thank you.
You would like to say
I have
anything?
told it's a team effort. We should collaborate. Finally, if we want to really improve their outcomes.
Right. So as we had an excellent panel discussion, I think we have exceeded our time. So I don't know if we have time for questions. Maybe during or post lunch, people can take the questions. But we had a very nice discussion, and we understood that it has to be a multidisciplinary team approach. It cannot be just with one person. Counseling has to start from the time they get pubertal. It's not like it has to start later. And we know that sometimes a lot of problems are there at that time counseling, and people say, why you are talking about all these things? But it has to start from that time. Good control of type 1 is the key. It has to be from day one. Basal bolus, that is the regimen to be followed for all women with type 1. And they have to be followed during their pregnancy. And post-delivery also, adequate care has to be taken. And at each point of time, we have understood that counseling is very, very important. So thank you.
Thank you very much. We enjoyed
Thanks,
participating in the panel. Thank you.
Thank you. I must say that Dr. Pramila traveled back from Lucknow yesterday. Her father was not well, but she traveled back yesterday evening for this, just to be with us. So I thank all of you, and the very fact that you are all here and the audience is here, it gives me a lot of pleasure. In the sense that the effort that we took, it's paid off, I feel. And please accept a token of appreciation from Dr. Laxmi. Yeah. Yeah. And one small announcement. So we'll start a little bit late because we ran a little late in Hall A. So we'll start at 3 p.m. after 15 minutes. So because the first speaker is actually Dr. Pramila Kalra, so she'll give the talk a little later. This thing. So we'll delay by 15 minutes. Sorry for the delay. So we'll delay by 15 minutes. We'll start at 3 p.m. and we hope to catch up in the coming sessions. So without much delay, let's get started with the next session. So I call on stage the chairpersons for the first post-lunch session. So sorry we are delayed by 15 minutes. We'll try to make it up. So I first call... so I'm just waiting for the display to come up. So Dr. Syed Jawaz, Dr. Shalini Joshi and Dr. Anusha. I think Dr. Anusha will join us shortly. So she is here somewhere. So I'll start by introducing Dr. Syed A. Jawaz. He is Chief Consultant Diabetologist at Diascope Multispeciality Healthcare. So he's a diabetologist of long standing. He is a Director of Diabetes Chemistry Research and Education Foundation, so which carries out research activities and clinical trials and free medical camps. He has conducted so far more than 1,600 free camps throughout the country. He is a Chief Patron of Karnataka Diabetic Foundation. He is the present Chairman of the Karnataka State District Committee of RSSDI and Convener and Founder Honorary Secretary of RSSDI Karnataka Chapter. So, and he's also Chairman Ethics Committee for the Postgraduate DNB course at Santosh Hospital, Bengaluru. So his fields of interest include diabetes, obesity, metabolic medicine and podology. Next slide, please. So we have Dr. Shalini. Dr. Shalini is currently working as Additional Director, Internal Medicine and Preventive Health at Fortis Hospital. So she's Senior DNB Faculty in Internal Medicine Department. So she's an Immigration Panel Physician for Canada, Australia, New Zealand and UK. She's member of IPA, International Panel Physician Association. She's trained and experienced in treating diabetes, gestational diabetes, thyroid and tuberculosis. She's a tobacco cessation expert. She's SCOPE certified in obesity management. So madam is a very senior physician, taking care of patients in Bangalore city. So next slide. So we have Dr. Anusha Nadig also. She'll come to the stage shortly. I'll introduce her. So she's a consultant endocrinologist, VHS Hospital, Bangalore. She's a DM endocrinology from SWIMS Tirupati. She has done her MD medicine from JJMMC Davangere. She has presented posters, papers and national and state levels. Her special interests include pediatric endocrinology, GDM and pituitary disorders. We'll just wait for a minute. So just hop onto the stage. Thanks for joining us. And over to the chairpersons to introduce the speakers and take over this session.
In this session, we have 3 talks. The first is with Dr. Mahesh. Dr. Mahesh, a consultant endocrinologist at Astra CMI Hospital, Hebbal. And in the year 2010 and 11, he was the senior registrar in JIPMER, Pondicherry, assistant professor in the year 14 and 15 at CMC Vellore. He has many publications and more than 5 textbooks he has written, and he is an awardee of and he has received Frontline Award in 2023, wherein and featured as one of the top endocrinologists in annual listing of the best doctors South 2022, both in India Today and Outlook magazine. I welcome Mahesh for your talk to continue on the topic today that treat the trinity, taking the high glucose, weight and CV risk with oral semaglutide. How to tackle it? Please go ahead.
Thank you. Thank you, chairpersons. Thank you, Magna and Anantraman sir, for inviting me for this conference. So today we'll be talking briefly about treating the trinity, that is, we all know that we face in our regular OPD, high glucose level, obesity with cardiovascular risk. So we'll be, the agenda will be in 4 headings. One is decoding the trinity, next is comprehensive understanding, what is the evidence that we have, then the evidence we all know based on the pioneer studies of oral semaglutide and what is the future course ahead. So if we all know that obesity, diabetes and cardiovascular disease are interlinked and they form the unholy trinity, and sometimes it is very not so easy to break them, and for many years, if you look at the data, the UKPDS showed that there was only relative risk reduction of around 13% or 14% with strict glycemic control over a long period of time, which means that still almost 87% of the patients who had diabetes already were likely to suffer from some cardiovascular disease, and the most common cause of death was cardiovascular disease. Unfortunately, for many years we had insulin, sulfonylurea and metformin as the main drugs, and if you look at the data, the macrovascular risk reduction because of these drugs were not so robust, or the evidence was very difficult to show that we had extremely good benefit with respect to macrovascular diseases. The main benefit of glycemic control over long period of time was predominantly delaying or preventing the microvascular complications. And if you see the last 5-10 years data, that is where we have seen a change in our drugs that are available, and that has resulted in change in the guidelines also. If you look at the reality, 88% of patients with diabetes have either obesity or overweight. Among them, 31% and 31% of those with obesity have diabetes. Almost 1/3 of those with CVD have diabetes, and 1/3 of those with diabetes have CVD, and 50% of diabetes related deaths are related to CVD. And obesity and CVD are directly related, where 2/3 of the deaths because of obesity is cardiovascular diseases, and almost 80% of patients with CVD have obesity or overweight. So the common pathway of this diabetes, obesity is leading on to the cardiovascular disease is mainly inflammation, which is mediated by insulin resistance, leading to increase in the inflammatory markers, and obesity with increased free fatty acids, dyslipidemia, contributing to inflammation. This systemic inflammation results in this systemic inflammation, where we can see the inflammatory markers here, and the inflammatory markers with diabetes and obesity being similar, and they result in endothelial dysfunction, platelet dysfunction, oxidative stress, atherosclerosis, and together these 4 components contribute to cardiovascular disease. And if you add hypertension to this, we see that hypertension, obesity and diabetes leads to macrovascular diseases that are not easy to just overcome with glycemic control. And the evidence for that was the multifactorial risk reduction trial, which showed that unless you have glycemic control achieved along with weight reduction, cholesterol improvement and also BP reduction, we don't see significant change in the macrovascular outcomes. And for that to achieve, we need to look at lifestyle changes, weight management and glycemic management, lipid control, blood pressure control. Because of the multifactorial risk reduction trial, we all know that all of them have to be taken care of. And the addition in this is the recommendations that talk about drugs with proven benefit for cardiovascular outcomes. So this was not there in the guidelines before 2016-17. Since last 5-6 years only, we have seen this added, that we need to have drugs that have proven cardiovascular benefits. And if you look at the evidence for establishing these guidelines, this is the current ADA 2024 guidelines. Here you can see the first thing is goal is cardiorenal risk reduction with high risk individuals, irrespective of the HbA1c. So whether the HbA1c is 6.5 or 10, we have to first ask ourselves whether these patients have high cardiovascular or renal risk. If they have risk for hypertension, smoking, obesity, family history of CVD, or established CVD or microalbuminuria, even though the HbA1c is 6.5 or 7, we need to consider them for drugs that will give them additional benefit apart from just glycemic control, and those include the SGLT2 inhibitors with proven benefit, CVD benefit, SGLT2 with proven heart failure benefit, and GLP-1 with proven CVD benefit. So we have to look at the benefit of the drug in terms of its cardiorenal outcomes and then use the molecule. Again, GLP-1 we can see is there in the high atherosclerotic cardiovascular disease group, those with CKD, those with obesity, and also for glycemic efficacy. Patients on basal insulin, further for glycemic management, instead of basal bolus, you can always consider utilization of the GLP-1 analogs along with the other drugs. So if you look at the recommendations, today we have class 1A recommendation for GLP-1 analogs on patients with established cardiovascular disease or with risk factors for cardiovascular disease and renal risks, you can definitely consider SGLT2 inhibitors along with the GLP-1 analog. And if you see, usually it used to be glycemic control, blood pressure management, lifestyle management as the foundation for patients with established cardiovascular disease or those with high cardiovascular disease. The addition today is drugs that will benefit the patient in that direction, not just glycemic control plus, glycemic control plus. We all see, whenever we see anything, there is some plus added. So today we are glycemic control plus something that the drug will do for the patient. Again, if you look at why GLP-1 analogs are so important, is they tackle the increased glucagon secretion. They address the decreased incretin effect in type 2 diabetes. They also have an impact on the hepatic glucose production, insulin secretion, appetite regulation, decreased glucose uptake also, and also the weight loss and indirect benefits on the blood pressure and the lipid profile, which we will see next. So why GLP-1 analog can help us is because it not only reduces the blood glucose level, but it also helps in blood pressure, inflammatory markers, and body weight reduction, which all lead to improvement in the CV risk factors and causes CV benefit. So we have many GLP-1 today, but among them oral semaglutide is the only oral GLP-1 receptor analog, and we all know that injection itself is a barrier for us to prescribe any medicine for the patient. The moment we say injection, we see most of the patients say, sir, can you add one more oral drug? And most of the time, even though we want to GLP-1, we will not be able to prescribe earlier. Today, with the availability of oral GLP-1, we can definitely consider our patients for those who really deserve GLP-1 analogs and are hesitant to take injection. We can give the oral semaglutide because we have good amount of data that shows that this oral GLP-1 is almost same as the injectable GLP-1 once a week that's available outside India. So for that we have the Pioneer trials. These Pioneer trials, the Pioneer 1 looked at diet and exercise along with GLP-1 analog. Then the Pioneer 2 was 3, 4 and 7 looked at the comparison of oral semaglutide with the other oral drugs. Then Pioneer 8 was on those with insulin, and special population Pioneer 5 and 6 looked at those with renal impairment, and 6 was looking at the CV safety. So if you look at the data especially of Pioneer studies, you can see here that Pioneer 1 with monotherapy with empagliflozin, sitagliptin, with injectable GLP-1 that is liraglutide, renal parameters, flexible use of other molecules, and also with the use of insulin. You can see the HbA1c reduction with the help of semaglutide, that is 14 mg, is really almost more than all the other drugs, and even including the injectable liraglutide. You can see oral semaglutide doing much better than the injectable, the oral sema better than the injectable liraglutide. Therefore, semaglutide 14 mg is now just below insulin in terms of its glycemic efficacy. Insulin has the maximum glycemic efficacy, and we see that today oral semaglutide has almost next in line with respect to HbA1c reduction of 1.5%, and even those who are newly diagnosed, we can see up to 2.53% HbA1c reduction. Again, if you look at the weight loss with this molecule, you can see here with 14 mg you have around 4 to 5 kg weight reduction, which is more than any other drug in comparison, almost up to 5 kg weight reduction in all the studies when compared with all the other drugs. Now there is two things. One is CV benefit superiority and CV safety. So all drugs that are there today that are given for glycemic control should go through CV safety data. We don't have to prove CV superiority, but there has to be a CV benefit. And with oral semaglutide, the Pioneer 6 data shows that oral semaglutide showed that there was a 21% non-significant reduction in the major adverse cardiovascular events, and those were the CV death, non-fatal MI and non-fatal stroke, and this had a very good retention of 99% completing the study, which is not so common that we see usually in most of the studies. Further, if you look at the other risk factors, that is the weight, blood pressure, inflammation and waist circumference and lipid profile, we'll see the data again. Here again you can see waist circumference of almost 1.5 to 2 inches reduction in the waist with the help of oral semaglutide as compared to placebo, and even on adding to insulin also we have seen that semaglutide causes not just weight reduction but also improvement in the waist circumference. Why is it important? Because a reduction of waist circumference, that is abdominal obesity, definitely proves that there is reduction in the inflammation, and this reduction in inflammation will lead to improvement in the cardiovascular outcomes. Again, here it is very important to understand that oral semaglutide works only when we see that there is a calorie decrease intake in terms of weight reduction, and that decline is around 35%. So this is very, very important because it is an indirect indicator of the drug, if it is working or the patient is taking properly or not. When a patient comes and tells, sir, ನಾನು ಮಾತ್ರೆ ತಗೊಳ್ತಾ ಇದ್ದೀನಿ ಆದರೂ ಎಲ್ಲ ತಿಂತಾ ಇದ್ದೀನಿ, that means that either he is not taking the tablet properly or it is not working. And especially some people have the habit of drinking too much water in the morning, around half liter, 1 liter of water. If you take 1 liter of water, this drug will disappear immediately. So it has to be taken only with 100 to 120 ml of water, which is very, very important. Even before prescribing the molecule, which is around quite costly, around 9 to 10,000 per month, most important is to tell them to buy something that can measure 100 to 120 ml. Spending 100 rupees, 10-20 rupees for measuring cup is more important than spending 10,000 for the molecule, because if they take with little more water, the drug doesn't work at all. So you have to ensure that they take this drug on empty stomach with 100 to 120 ml of water. Then only the absorption will be adequate, and when there is absorption, definitely you will see the appetite reduction, especially when they are on 7 and 14 mg. If they see I am eating everything like I used to eat earlier, then something is wrong. This drug is not doing its job. There has to be at least 35% reduction in energy intake to see the maximum benefit that we see in our patients. Some patients come and tell that if they are really absorbing, sir, nange tinbeku anta anstane irla. And the husband tells, sir, ಆಚೆ ಹೋದ್ರೆ ನಾನು ಹೆಂಡತಿ ಏನು ಬೇಡ ಅಂತ ಹೇಳ್ತಾಳೆ ಸರ್, ನಾನು ಆಚೆನೇ ಕರ್ಕೊಂಡು ಹೋಗೋಕ್ಕಾಗ್ತಾ ಇಲ್ಲ. I'm not able to take her out for eating, which we used to do earlier. I say it's very good. She will not only lose weight, she'll stay with you for a longer period of time. Don't worry. So oral semaglutide also reduces the blood pressure, and we all know that 10 mmHg decrease in the blood pressure reduces the complications of diabetes by 11%, 16% reduction in deaths, and 11% reduction in MI, and also the myocardial benefit. Again, there is an improvement in the lipid profile, reduction in the HSCRP, that is inflammation. You can see when compared to EMPA, oral semaglutide, there is a significant 37% reduction in the HSCRP, which is a key indicator of inflammation, and that is related to high cardiovascular risk. So if you look at the data of oral semaglutide in India, what are we doing? We are seeing that HbA1c is around 8.9% when the drug is started, and around 90% were started for achieving both weight control and better glycemic control. 1 in 5 patients were having a diabetes diagnosis within 1 year. That is, within 1 year of onset of diabetes, this drug was prescribed in 20% of the patients, and almost 50% had a cardiovascular event related history, stressing the importance for using this drug in such patients, and we will see data on this coming soon. Now coming to oral semaglutide itself and its future. So this is the first oral GLP-1 analog. You can see the structure of this. There is a spacer, fatty acid spacer, and an absorption enhancer. This snack is the most important thing for this drug to enter into the circulation and absorption. Snack is nothing but sodium N-amino-caprylisate. This is an absorption enhancer, is a small fatty acid derivative that promotes absorption across the gastric epithelium. And oral semaglutide is co-formulated with around 300 milligram of this snack, and this snack helps in the cellular uptake of semaglutide, and around 1% of the semaglutide, if you give 14 mg, 1% is what actually gets into the circulation. The rest of it is degraded in the GI tract, and if you take more water, then not even 0% will get absorbed. That is nothing. So what is the future of semaglutide? The future of semaglutide is, it is also looking at CV superiority in terms of the CVOT trials, that is SOUL. FLOW is looking at the kidney outcomes. STRIDE for peripheral artery disease. STEP, heart failure with preserved ejection fraction, that is looking for heart failure symptoms. And ASCENT Plus is looking for primary prevention of CVD in type 2 diabetes patients. Most of them are in phase 3, and we are likely to get the result soon. Oral semaglutide SOUL study is ongoing since 2019. It is about to finish this year and probably will get results in the near future. So it's important. Why? Because to establish CV superiority or to look at CVOT trials, we need around a particular number of events, that is 1200 events, to say that this is really going to have an impact in the long run in terms of CV benefit or superiority. So in this trial, almost 42% of the patients you can see have some CV conditions, isolated or more. Then we have cerebrovascular disease, peripheral vascular disease, and CKD, and some of the patients are on SGLT2 inhibitors also. Now, why SGLT2 inhibitor is important? That they have different mechanistic benefits and they are complementary to each other. They are not against each other. So today, probably in the near future with data, we will be able to see why GLP-1 plus SGLT2 may be an ideal combination for our patients, along with metformin and the foundation of lifestyle risk factors being addressed by diet and exercise. So these are multiple benefits of SGLT2 and the GLP-1, we are all well aware. The important thing is they address the cardio-renal metabolic risks. So what is known as the caramel is nothing but the cardio-renal metabolic risk factors. All are equally important, and we need drugs that will take care of the causes that will lead to these problems, that is the cardio-renal problems. And these drugs not just bring down the glucose, but they also change the inflammation, blood pressure, cholesterol levels, and improve the weight. And with that, those 4 additional factors that are taken care of, with the combination of these 2 drugs, we should expect much better outcomes for our patients in terms of macrovascular diseases. So universal recommendation is to use the combination in many of our patients.
Hi, sorry to interrupt. Please could you summarize?
Yes, ma'am. Last slide. So the therapeutic benefits of these is addressing the residual risks, better myocardial salvage, reduction of risk with EGFR decrease more than 50%, reduction of MACE, lower the risk of end-stage renal disease, and more CVD-free life years. We all know that diabetes reduces the lifespan of an individual by 8 years, and I'm sure with the addition of these 2 drugs, we should be able to get back at least 4 years of our patients in terms of the benefits of adding life years. Thank you.
Excellent talk, Mahesh. We will take up the questions a bit later as we are running short of time.
Sure, sir. Thank you.
Next speaker is Dr. Pramila Kalra. You introduce.
Welcome, Dr. Pramila. She doesn't need any introduction. I think everybody knows her in this part of country and in North as well. She is a professor and head of endocrinology, Rama Medical College and Hospital, Bangalore. Publications, almost 70 scientific publication in national and international journals and 23 chapters in various books. And she's been presenting in various national and international conferences. Graduated with honors, gold medalist, won prizes in paper and poster presentations, ICMR scholarship in 2006 for her thesis work, and there are many, many awards which I can keep on reading. But I welcome again the delegates post-lunch and our speaker, and over to you, Dr. Kalra.
Yeah. Thanks for the kind introduction. Good afternoon, everyone. I think post-lunch session is always the most difficult for the delegates, for sure. So I'll just be discussing in the next 15 minutes about the use of basal insulin, because we already had discussions about the management of diabetes to some extent, and we know that now we have so much of so many options available for treatment of type 2. Previously, we used to say when the patient is on 3 OADs, it's OAD failure, but now you have patients who are on 4 OADs, 5 OADs, and then also the patient will want to add one more. So because the options are so many, but we know that at some point of time, when the patient has not got the requisite control, we know that these patients do need insulin for their treatment. So the slide will show up on the screen because it's not showing up here. Will it show up on the screen? It's not moving and neither showing up. So if you can just see, yeah. So I will be talking about the, will it come? Yeah, it's, side. Sorry for the technical glitch, we are just sorting it out. This one is my slide. No, not this one. That is the one. Yeah. So I'll be discussing about the use of basal insulin and where do we best put it. So to start off, we have a case study. This is a 48 years old person who is a lecturer, and you can see his obese, his BMI is 27.2. Patient has diabetes for 8 years, which is a usual story for most of us, like we'll get these type of patients commonly in our practice. Has hypertension for 8 years, predominantly cystic, has dyslipidemia for 3 years, and the patient has a family history. Even if they don't have, sometimes we know that they may say, we don't have a family history, but sometimes they'll tell, yeah, my father got it at the age of 65, so that's not a positive history. Or even it may skip one generation, we know that. So all these things are important, because sometimes even we say that the family history is negative, but if we dig deep into this, we'll find out that it's mostly positive. And patient is taking occasional alcohol also, and he's taking more than actual to 2 drinks per week. And patient is not smoking, irregular pattern of exercise as we normally see. Now this patient, if you see, is not having the control. You can see his glycemic control is not good. His HbA1c is 9.7, the fasting glucose values are 218, and his postprandials are not too much more than the fasting, it's like 236. And the patient has dyslipidemia. You can see the LDL value is 188. Now this patient has a eGFR of 68, which we know we always now calculate eGFR. We just don't go with the absolute value of creatinine. And this patient has a high CV risk and has albuminuria as well. And he has been obviously advised to stick to the lifestyle modification and maintain a healthy weight. And now this patient is already on total of 2 grams of metformin with GLP-1. This patient is on injectable liraglutide and is also on SGLT2. Now you can see the case scenario. This patient is having diabetes for around 8 years now, and the HbA1c is way beyond the target. How many of you would like to target HbA1c of at least 7 for this patient? With a show of hands. This will help us to wake up also. Yeah, so we at least want the HbA1c to be 7, if not even lower than that, but at least 7 is what we are targeting, and we know that we want a drop of 2.7. How many of you think that SUs can be added and we'll bring it down to 7? Again, with a show of hands. This is just for wake up, yeah. So one person has definitely woken up. So we definitely know that if your patient is started on SUs at this point of time, when the diabetes duration is already 8 years plus, you are not going to get any major benefit, and you are not getting to the target of 7 definitely with this. You can definitely reduce by maybe 0.8%, 1%, but you will reach maybe 8.7, but you will never reach 7 with this. So we'll keep on hovering around that level, and then what will happen, patient is already on GLP-1, patient is already on metformin and SGLT2, so we know that SUs are not going to add majorly. Yeah, you may get some drop, we may contest that he may get some benefit, yes, definitely, but you are not going to reach 7%. So we are definitely going to waste that much of time for the patient again with hyperglycemia, and that's what we don't want. So basically our challenge for this patient is definitely the hyperglycemia. Patient has a work schedule, which we call it as hectic or not. All of us have the work schedule like that, so we cannot expect patient to follow to the book for the lifestyle what we tell. And obviously traveling is also there, which is true for many of the patients, which is a usual story again. So what we know about the insulin initiation, we always know that you definitely think about the option of GLP-1. In the previous talk, Dr. Mahesh did allude to about the uses of GLP-1, and we know that they are one of the best therapies we can offer to our patients, but you know that always there is a failure rate for everything. So there is a point of time when you know that this patient has not achieved the target, like this patient who is already on GLP-1, SGLT2 and metformin, you need to add something else, and which would be the ideal thing in this patient would be a premix or a basal. Show of hands for premix. Okay, show of hands for a basal choice in this. So yes, most of the audience rightly have pointed out that it is definitely a basal option, which would be a good option. We may still not achieve the target in this patient with just basal. We might have to go for a basal plus approach over a period of time, but to start with and make the patient ready. I have seen many times in my practice that the patients are not at all ready for insulin, and when you tell them, okay, you take in the night when you are at home, then they feel a little bit comfortable. You might know that this patient will soon require a basal plus approach, but to give one basal shot, make them comfortable, let them start the thing, at least bring it down by 1.5% or so, and then maybe slowly add the other part of it. But this makes life easier for us to make the patient understand and patient knows how to take it, gets comfortable with the insulin, and you get to the target. And especially in this patient, you would have seen that the fasting was 218 and the postprandial was 236. So there's not much of a postprandial rise. There's a high fasting. So what you're trying to do is control the fasting, and you know that once you control that, the postprandial will definitely come down to 160, 170 range. And this patient may be controlled for quite a good amount of period of time with the basal option, and definitely you can reduce the risk. So now we know that when we talk about ideal basal insulin, we have been studying this from our DM times, that yes, we had NPH initially, and then we had glargine, which was supposed to be a wonder drug for us, because when we were students, like glargine was something which was a very good insulin, because that was the only option we have. And then we had that time, and now over a period of time, we have got so many options of like glargine U300, degludec coming up, which have changed the scenario, because now we know we have the true basal. Because as residents, I remember we used to struggle with that 4 o'clock and 3 o'clock hypoglycemia, and if you give a little bit more dose of NPH, the patient will go into hypo. If you give less, there'll be a hypoglycemia. So that used to be a big problem, especially even in type 1s, we used to have a lot of problems. So now we know that now we have this quest for the basal insulin, and we definitely have understood the point that the basal insulin should be actually a peakless insulin, which should give the coverage for more than 24 hours, and that's what we want. And what the patient wants, flexibility. That's another thing which is patient choice, because we will say, okay, flat profile, no peak, but patient says, this is none of my business. What I want is I should not get a hypoglycemia. I should be able to take the insulin as per my convenience. Is that there? Yes, that is also there. And our part is long duration of action with a good control. Is that there? Yes, that's there. So that's what are the features of the basal insulin which we want. We may want for more. We may say, now we know we have the once weekly and other things coming up. But at the moment, this is what is available. And we know that the journey has been long, and we have seen that how the things have come up over a period of time. When we talk about the degludec insulin, we know that because of this fatty acid side chain, it allows the degludec to form the multi-hexameric chains and in the subcutaneous space, and over a period of time, it dissociates slowly, and that is how it gives the prolonged action of degludec. And it has a flat profile mostly across the 24 hours, because we know that as we go further ahead, we understand that always there may be some mild peak, but we know we have all been using degludec, and we know that it is almost flat, and that is what the PK/PD studies have shown. It's just not our clinical experience, it's the data which is available to us. So we have multiple studies available with the efficacy. We know that if you see for the efficacy of a basal, what we are trying to see, we are trying to see that we should be able to control the fasting. Once you control the fasting glucose values, you control the postprandial spikes as well. Like in this patient where the postprandial rise is not too much, but the fasting glucose values are like 218, but the postprandial is only 236. So you know very well that if you control the fasting and you bring it to maybe 100, 110 for this patient, may not be on the day one, because we won't like to bring it down so fast, we will go slow. But finally your target would be 100, 110 if it's safe enough for this patient, because this patient doesn't have any major issues. He's a high risk ASCVD and should be able to manage. Then you can definitely bring the postprandial down to 150, 160, which will be a very good thing for this patient. And what we are targeting finally is the HbA1c reduction. And this is what was seen in this study, where they found a significant reduction in the HbA1c and fasting glucose after 1 year of degludec insulin. So if you are transitioning, like when we are talking about transitioning from first generation basal insulin analogs, we know that, as we have already discussed, that the duration of action is the most important for the basal, and it should be peakless. It's not that if it's a long duration and it is having multiple peaks, then it makes no sense for a basal. We don't want the basal to act like a premix or a bolus. We want the basal to be a true basal, and that's what we know we have with glargine, also with degludec, which is the duration of action is more than 42 hours, and it has a faster onset of action also. So, and if you see, the degludec has a prolonged duration of action as compared to glargine U100. And another thing we are worried about is the glycemic variability. We talk about interday and the intraday. So they have tried to see the glycemic variability with degludec versus the glargine U100, and they found that there was a lower within day, intraday variability and better round-the-clock coverage with degludec. So this is acceptable because we know that the duration of action is longer, a flatter profile is there, so you will definitely have a better reduction of the glycemic variability, which was exactly what was seen in this study. And again, you try to also see for day to day, because just not the 1 day glycemic variability, you're also worried about day to day. The patient says, today I take the same dose, and again, next day I say, take the other dose, then how will I manage my insulin? So this is this study which was done in type 1 diabetes patient, euglycemic clamp studies, and they tried to again compare degludec with glargine U100, and they found that there was a lower day to day variability with degludec. What is the importance of this? It's not just the control, because what we are first worried is hypoglycemia. As a doctor also, when we write insulin, we always say that, oh, my patient should not get a hypoglycemia. Then the other things come into picture. My patient should get the best control. I should prevent the complications. But the first thing which I want is the control of the hypoglycemia and the prevention of the hypoglycemia. And you can also see here clearly that lower glycemic variability actually reduces the risk of hypoglycemia as well. So this is how it works. Then we also talk about time in range. We know that if you want the patient to have a reduction in the glycemic variability, the next thing which we start looking for is that patients should spend the maximum time in the good glycemic control. We don't want our patients to be in hyperglycemia, one time in hypo, and then bringing an average which is good. We don't want that. We want our patients to have a flatter profile and not having too many highs or lows. And similarly, in this study, they tried to see the time in range, which was a Switch Pro RCT, where they tried and they found that degludec was superior to glargine U100 for the time in range maintenance for a longer periods. Also, another thing which is always there is safety. So again, they have tried to see the safety, and they have consistently found in all the studies where if you talk about BEGIN or SWITCH or DEVOTE trials, the hypoglycemia benefit has been consistently proven in all these studies. Again, as I told you, this is not for the doctor most of the times, but we are always worried because my patient may not take the insulin at the right time. But the patient is always happy if we give them this option, but we never give them this option. We never tell them do this. But we know that if this patient is not going to take the insulin at the same time every day, it's not going to cause any problem for my patient. But definitely we are not going to tell this to the patient that you can take it at any time of the day, because then what happens, then they may not take it at any time of the day, they may take it at any time of the week. So that's why we never tell these type of things, but we know that if the patient is doing even this, it is not going to cause any problem. So they have tried to compare, and they have found that obviously it has a faster onset, a longer duration, and a more flatter profile with a less interday and an intraday glycemic variability with adequate safety data. So when we are talking about the basal insulins, we know that the degludec has a faster onset of action, and it has a longer duration, and even they have compared with glargine U300, and they have found that the HbA1c reduction is comparable. And in some of the studies, they have shown that it provided a greater reduction, but we know that there is data even to show the comparable reduction with U300. And if you talk about the fasting plasma glucose reduction, we know that we have the BRIGHT RCT, where degludec was compared with glargine U300 in insulin-naive type 2 diabetes patients, and they found that there was a good fasting plasma reduction with the degludec insulin. Within day, again, they have tried to do the same studies with glargine U300. Here they found that there was a lower within day glycemic variability, but we know that we have data both ways. We have data with the U300 with other studies as well. So we can say that there was definitely in this study a better effect, which was seen in the type 1 diabetes patients. And even for the euglycemic clamp, they tried to see the day-to-day glycemic variability as well. And if you see the confirmed study data, which was the data from the real-world evidence, they found that the hypoglycemia risk was lower. Dose time flexibility is definitely one thing which we have plus minus 3 hours for glargine U300, but we have like a longer, very long flexibility duration ranging from 8 to 40 hours with degludec. And potency-wise, we also know that there are studies which are proven benefits. Some studies have not proven the major difference, but there is a benefit shown in some of the data like I showed you. So if you see again, the comparison is that action may be faster, maybe longer, and you may get a better fasting glucose reduction with the similar dose. So the dose requirement may be higher for the other insulin. So we know that this is one of the very good basal insulins we have, which gives us the option of offering it to our patients for the reason that we know that the risk of hypoglycemia is less. We have a flexibility option for the patient, but we definitely don't tell that, but we know if the patient doesn't take the insulin on time, it's not going to hamper the glycemic control or cause more hypoglycemia for our patients. We have a good control of the glycemic variability, and studies are there with time in range as well. So it's one of the options and one of the best insulin options for basal insulin, because it has a very long duration of action. We can definitely offer it as an ideal basal insulin at the moment to our patients. On time. Okay.
So much for the lovely presentation and crisp and on time dot. We didn't even have to do anything. Thank you so much. We'll reserve the questions at the for the later part. And with this, our third speaker.
I welcome Dr. Arvind Jagdish. Sir is Chairman and Chief Diabetologist at Dr. Arvind Diabetic Center, Bangalore. He has lot of awards, and he has presented more in 100 conferences, publications, and is involved in clinical trials. And he is a speaker at both national and international level conferences, webinars. And he was the president of RSSDI Karnataka chapter in 2018 to 19. Over to you, sir.
So good afternoon, everybody. At the outset, I thank Dr. Raman for making me a part of this wonderfully organized conference. I'll be talking on harmonizing diabetic care with insulin co-formulation. Dr. Pramila spoke about the basal insulin, the benefit of it. Now this is another new concept where it can be useful for our patients, especially where the postprandial spike is very high. So that is about the insulin co-formulations. So diabetes in India, if you take a bleak outlook, so nearly 101 million people with diabetes and 136 million people with pre-diabetes is there. That is the magnitude. So we need to be aggressive in controlling our and managing our type 2 diabetic patients. Asian Indian phenotype, we always are different from when compared to the Caucasians. So diabetes develop at an younger age, progress faster stages from pre-diabetes to frank diabetes, high levels of abdominal fat, increased insulin resistance even at low levels of body mass index. So beta cell dysfunction occurs quite early and rapidly progresses. So the main thing is we are thin fat Indian, which is very, very peculiar. So we need to have our own guidelines as followed by RSSDI and ESI to follow our diabetic management, which is most important when we are comparing with the Caucasians. So high carbohydrate diet is a common Indian reality. I am sure all of you will agree, whether it is me, south or north or east or west, the most of our food habits are rich in carbohydrates. So you can see in the India map that nearly 60 to 67% across India we consume carbohydrate. And if you see the HbA1c, mean average HbA1c, in spite of having so many molecules, the HbA1c is 8.56. Fasting plasma glucose of 172, postprandial of 253. So in spite of so much of education, discussion, patients are always patients. So we need to be more aggressive and educative to our patient for a better control of diabetes and prevention of morbidity and mortality. On the right hand side, you can see for an ideal carbohydrate load, they see the Caucasian and see the South Asians. So postprandial glucose peaks, it is 2 to 3 times greater in South Asian when compared to the Caucasians. So indices for the holistic choice of insulin therapy, it should have a lower hypoglycemic risk, mealtime flexibility should be there, simple regime, convenience of device, better quality of life, cost effectiveness, and most important, the efficacy. So the one of the co-formulation which is available in our market is the Novo Nordisk Hydag Asp. This is one of the important co-formulation where we can have a basal control as well as the postprandial control as well. So Hydag Asp, it's the world's only co-formulation insulin. On the left hand side you can see the ultra long acting degludec, which occupies the 70%. On the right hand side you can see the rapid acting aspart 30%. So the two insulin components do not interact in the solution and in the subcutaneous tissue, thereby retaining their individual property. This is very important. They will not mix up and do not cause any confusion. They are kept at a separate entity in the subcutaneous tissue, and they do their job accordingly. So you can see in this slide distinct prandial and basal glucose lowering effects is there. The yellow part is the mealtime control with the insulin aspart, and the blue part is the flat and stable control with insulin degludec. So which has got a phase 3 clinical trial program. This you can see the number of phase 3A and phase 3B. You can see the comparators, like it has been compared with the insulin detimer, insulin biasp 30, glargine U100, basal insulin plus aspart, and versus Hydag Asp as well. So in the various clinical trial program it has been studied. So you can see the vast majority of real world experience backing the effectiveness and safety. It has got nearly 15 real world studies across India to show the effectiveness of Hydag Asp. So Hydag Asp co-formulation is efficient glycemic control with low risk of hypoglycemia. This study is a SMART study. The study design is adult type 2 diabetes patient, leaving to the clinician discretion when to start the particular insulin. When we think of using insulin, when it started with the Hydag Asp, that was they did the assessment of changes in FBS, PPBS as well as the HbA1c in 3 months, 6 months and 12 months duration. This is SMART study efficacy parameters. If you take 45% of the patients on insulin therapy were on basal insulin plus or minus OAD. You can see there was 27% were insulin treated, 73% were OAD treated. On the right hand side you can see in patients with previously on insulin plus or minus OAD treatment with Hydag Asp resulted in 82.5 milligram decrease in postprandial blood glucose, 50.4 reduction in the fasting plasma glucose, and 1.8% is a huge number, 1.8% reduction in the HbA1c. Regarding the safety of this molecule in the SMART study, the red one what you are seeing on the left side is the before you start the Hydag Asp. You can see there was the 176 incidences of hypoglycemia, that is confirmed hypoglycemia, over a period of time, that is visit 2, visit 3 and visit 4 for 12 months. You can see how the number has come down. Over the 12 months you can see only 11 incidences were there. On the right hand side you can see the severe hypoglycemia. Before you started the severe hypoglycemia with the previous molecule was 24. When it was shifted to Hydag Asp, you can see almost nil, starting from 3 months, 6 months and 12 months. So there is no severe hypoglycemia with this Hydag Asp molecule. Next, coming to the dosing convenience and flexibility, this is an important aspect. We can see Hydag Asp initiate with 10 units OD administered with the major meals of the day, any major meal of the day. Administer Hydag Asp OD with the most carbohydrate heavy meal of the day. That is more, when you ask the patient, you ask about the carbohydrate. In most of our case, it will be carbohydrate rich only. I am sure even for breakfast, whether it is lunch or dinner, so carbohydrate rich is there. So you can decide upon the carbohydrate rich by discussion with the patient. Preferably it will be most of the time, it will be night times when most of our patients consume heavy foods. So later it can be converted into BID dosage. So the administer Hydag Asp BID with the two most carbohydrate heavy meals of the day. The meal size and postprandial glucose response should dictate the ratio of 2 doses. It doesn't have to be 1-to-1 split. So the practical recommendation is adjust the dosage by +2 or -2 depending upon the fasting plasma glucose level. So OD dosage is start with the major meal, assess the dosage levels by looking into the fasting plasma glucose, adjust depending upon the pre-dinner level and the pre-breakfast level, increase or decrease the dosage accordingly till you get the targeted blood glucose level. So then this is in this study same, they have looked into the quality of life questionnaire. What they have seen is on the left hand side you can see 89.8% reported improved quality of life with reduced pricks. In the middle you can see 86.7% found it comfortable to inject high-deg apps in different social situation. On the right hand side you can see the 94.2% could manage their day-to-day activities better with initiating high-deg apps. Most important aspect we should note here is the reduction in the pill burden. The reduction in pill burden with high-deg apps initiation. Once this molecule was started, the 70% of the patients who are on 3 OADs were shifted to 1 or 2 OADs. 50% on 2 OADs a day were shifted to once a day. So this shows the good amount of reduction in blood glucose so that the OAD number of OHAs or OADs can be reduced as well. The reduced pill burden improves quality of life and adherence to treatment in individual with diabetes. Next is the simplicity in dosing regime. You can see on the left hand side it's such a busy thing. You start with the OADs, basal insulin with OADs, basal plus aspart, basal with aspart twice a day, basal with aspart thrice a day. So this way goes on for the intensification. On the right hand side and the other side, once the patient not under control with OADs, if you start on high-deg apps with the major carbohydrate meal, that will be very easy to explain to the patient. We can start at once a day, later it can be made depending upon the glucose levels to the twice a day, thereby increasing and uptitrating the dosage till you get the target range of blood glucose. You can see in this slide on the left hand side basal bolus versus high-deg apps. Basal bolus, if you take, it is a complex regime, different titration schedules, persistent monitoring can be painful and expensive. On the right hand side you can see with high-deg apps is a similar reduction in HbA1c, lesser hypoglycemia, requires lesser dose and very simple to administer. So switching to high-deg apps from the insulin regime is simple. So you start with a high-deg apps OD, increase to BD and accordingly titrate the dosage. The switching needs to be individualized based on the careful consideration of basal bolus doses. Close blood glucose monitoring is required. So we are all use this high-deg apps in many situations. You can see in the special population, elderly individual with type 2 diabetes, definitely it can be used. Type 2 diabetes patients with renal impairment, type 2 diabetes individuals with hepatic impairment, type 2 diabetic individuals during religious fast, and adult type 1 individuals. So in all this scenario, this can be used very comfortability without any major issue when compared to the other insulins. So high-deg as a choice at insulin initiation, if you take, it causes lower hypoglycemia, mealtime flexibility, simple regime, convenience of device, better quality of life, most important is cost effective and efficacy. When we always discuss about this particular molecule, the cost will always come into the discussion. But when you see the amount of dosage reduction or the amount of molecule, that is OHA reduction happens with this molecule, the cost may be in the long run may be comparable. So once we start this particular molecule, the discussion will always come with your patient as well. Sir, what about the cost? It looks a bit expensive. Then you will start explaining to the patient, see, these are the 4 drugs you are taking, tablets, or 3 drugs you are taking. So we can reduce with this, one tablets can be taken off, or you can see the insulin dosage requirement also. It can be used in other things. When you start on this particular molecule, the dosage can be reduced as well. So the pricks will be reduced as well. When you tell all these things, the patient will definitely understand. And when you tell about the risk of hypoglycemia, when it compared to other things is much lesser, the acceptability is good. So it requires a little bit of explanation to the patient, just as we do for SGLT2 inhibitors or GLP-1RA. When you discuss with the patient about this way, this particular molecule, educate the patient, show them the pen, see this the comfortability. Always it's a challenge, as Dr. Pramila said, when you are starting an insulin, it's always a big challenge, big no to your discussion initially. But when you subsequently keep on discussing, tell them, see, this is a once a day molecule, this is good for you in a long run, this is the benefit you are getting, the patient definitely will try to understand. When the family members are involved, I always try to involve the family instead of telling only to the patient, involve the family, whether it may be husband, wife, or the family members. If they get involved, collectively we can definitely educate ourselves, and acceptability is very good. So thank you for your patience hearing. If you have any questions, we can discuss other things. Thank you.
Thank you, sir. Thank you for that wonderful talk. Any questions from the audience for any of our speakers? Anybody has any questions? Cost of?
Cost, I think, I thought the market exact number I don't remember now. Anybody, what is the cost of Rhizodec? Srinivas?
1,300 rupees per
cartridge.
Per cartridge. 300 units.
It's got 300 units. We start with the 10 units per day, depending upon the response. If it is response is good, so 10 units start means roughly it comes for 1 month. But it all depends upon the dosage requirement. So if the patient on OAD is only on tablets, you start with that simple 10 units, the response is very good. If the patient already on insulin, pre-mixed insulin, you are trying to convert this, the dosage may vary. But when it compared to other pre-mixed insulin, this particular co-formulation, the amount of insulin used will be lesser. So in that way, when you calculate the price thing, in a long run, you will be justified in taking this.
Yeah, I think it is very cost effective, the way you are telling.
Yeah.
It looks very, very cost effective, very doable for our patients. What I am interested in is what kind of monitoring tool you use, which the patient has to maintain. We are only drawing some charts, and sometimes I see printed formats from other endocrinologists, but we don't know what is the standard and what you feel is the standard. For us, we do follow some, but I am interested in knowing.
So monitoring is simple, self-monitoring of blood glucose, which can be easy to monitor. Once you have started this insulin,
glucometer RBS.
Yes.
The format of
pregnancy,
second and third trimester, how often, and like that.
Yeah, it all depends upon the glucose levels, like how bad the sugar is, how good the sugar is. If the sugar is very bad and very erratic, so it needs to be done often. If you take the RSSTA guidelines also, depending upon the severity, the guidelines says it has to be monitored as well, whether it is different for type 1 diabetes, different for gestational diabetes, different for type 2 diabetes uncontrolled. So depends upon the response. If you can definitely within 1 week or 10 days, you will be able to assess this particular sugar is not under control with this. So we can educate, no, your sugar is giving us a challenge. We need to assess more responsibility. So you check it 3 to 5 times a day, or pre-meal or post-meal, anytime, morning or afternoon or evening. For in pregnancy, what I generally do give them a 7-point SMBG. 7-point SMBG, that is a good thing to do that.
7-point SMBG per day, 7. That includes a midnight or 2 a.m.
Yeah, absolutely, 3 a.m.
Yeah, that is for the one
very
who
bad,
is getting controlled now.
Yeah.
But going forward, well-controlled patients, what is that? That is my interest.
Yes, well-controlled, nothing to do. Whenever SOS, whenever it is indicated.
Regularly, you don't ask them to monitor?
But depends. If you are gestational diabetes, regularly has to be monitored. If it is a type 2 diabetes, well-controlled, no, nothing. Like maybe once a week or so, pre-meal and post-meal.
No.
There is no clear.
During pregnancy, the control goes haywire. We want to From our side, actually, we tell them to monitor, even if it is a pre-gestational diabetes. We
Absolutely.
tell them to regularly monitor.
Pregnancy,
Maybe 1 or 2 levels, 1 level per day at least.
Yeah.
Yeah.
Pregnancy is an important aspect. Pregnancy is a different thing. Pregnancy is altogether different.
Dr. Arvind,
Pregnancy only I am asking.
CGM in pregnancy?
Yeah.
Just GDM?
Pregnancy, you have to monitor fasting, post-breakfast 1 hour, post-lunch 1 hour, post-dinner 1 hour. These are mandatory. The
So
rest,
you go for 1 hour or 2 hour levels?
Pregnancy, we monitor 1 hour. So if you have a patient where you are just regularly following with the insulin, as Dr. Arvind also said, that if the patient, when we start on insulin, we tell them to do more frequent monitoring. In non-pregnant, like normal patients, we monitor fasting normally pre-lunch, pre-dinner and 2 hours post-dinner. Because that's important, because the time, like patient may go into hypos and other things, so 2 hours post-dinner we always do. Other values will depend on SOS basis. When we start the insulin, we do more frequent monitoring. Once the patient is stabilized on a particular dose of insulin, not pregnancy. Pregnancy monitoring has to continue
that
throughout.
is what. In pregnancy,
Throughout
well
it has to
controlled
continue.
Throughout, but 1
Yes.
sugar per day will do, or 2 per
Normally
day?
no. Normally we don't advocate that in pregnancy, because there will be excursions, and little bit of excursions, 30% of the values beyond will definitely lead to complications. So we don't
So 2 per
advocate
day.
that.
In a graded way, 2 per day.
If the patient is not wanting to monitor, then we tell graded staggered monitoring, but normally this is not advised in pregnancy. We also use CGM devices, as we discussed, even
Yeah,
in type
that is
1,
a
type 2
record.
diabetes with pregnancy, and even in GDM women, especially when you are not getting the match from the values and the patient's profile. Like you have a baby who is already grown 4 weeks more or 3 weeks more, and your glucose profile, which the patient has done staggered, is looking very good. So what happens, it's a tendency that the patient might have not monitored on those days when she feels that it might go high. So it's a good idea in pregnancy to do all these 4 at least, and the others like 2AM and all can be done on a SOS basis. CGM can be used on a case-to-case basis if you think it is going to help, or you're not getting the match and you want to reduce little bit of pricks. Some CGM monitoring will help you, that's for sure, but it will add to the cost. But in a normal type 2, when you are starting premixes, we definitely tell them to monitor. Once you have stabilized the dose, then you can do less monitoring. Like you can tell 2, 3, 4 sugars in a 3, 4 glucose values in a week staggered, like 1 day fasting, 1 day pre-lunch. But we always tell them to do 1 or 2 on weekends and few on the weekdays, because the weekend and the weekday may be different. So sometimes the patient will bring a fantastic value for the weekdays, but the weekends they will be eating out, so you will cannot catch it. So we tell them to do at different days, different values each week, so that you catch everything. So that's the concept. But when you are starting insulin, it's always a good idea to tell them to do, and the regular patients we do like this. And if they are not ready to do 4, then we tell them to do staggered. So like 1 day fasting pre-lunch, 1 day pre-dinner, 2 hours post-dinner.
Another important, madam, what you rightly pointed out, if there is a challenging cases, we come across in gestational diabetes, erratic sugars. Simple thing is now the CGM is quite affordable, which can be usually done, and accordingly you can titrate the dosages.
Thank you, Dr. Pramila. And thank you, Dr. Arvind. Any questions for the first speaker? So I would like to thank all the speakers for the great presentation. A big round of applause for all the delegates to be here post-lunch.
Thank you to our speakers and chairpersons for that wonderful session. We request you to collect the mementos. Moving on to our next session. The next session will also be on some newer insulins. So to chair this person, I would like to invite Dr. Rohit Warrior onto the stage, please. So Dr. Warrior is the Head of Clinical Operations at Twin Health India, Senior Diabetes Consultant and Medical Officer at Apotec Healthcare Center, Bangalore. He's also RTS Certified Tutor for Postgraduate Medical Training Program in Diabetology, Acute Medicine, Obesity, University of South Wales, UK. Over to you, sir.
Thank you, Doctor, for the introduction. So I invite the speakers for the next session. We have Dr. Varun Suryadeva, who's taken the next session. He's a consultant endocrinologist at Apollo Hospitals and Magna Center for Obesity, Diabetes, Endocrinology. His research interests mainly include osteoporosis and sarcopenia and diabetes in cretins. Can we go back to the introduction slide? Yeah. He's got travel grants from Endo 2023, research grants from ESI, RSSDI. He's got numerous publications to his credit. Over to you, Doctor, for your presentation.
Thank you, Chairperson, for the kind introduction. So over the next half an hour, we are going to discuss about another new insulin. One of the generation 2 basal insulin has already been discussed. We are going to discuss the other generation 2 basal insulin, that is Glargine U300. So first, before going to the discussion regarding the data regarding the Glargine U100. First, if you see the status of diabetes control in India, so as we know, the prevalence of diabetes is reaching to 8 to 10% of the general population, and over the next 1 or 2 decades, it's going to be almost similar to the developed nations, wherein so around 30 to 50% of patients will be having obesity, and the same urban prevalence will be a pan-India prevalence of diabetes. And to assess the status of glycemic control throughout the India, so this was a wonderful study, landmark study conducted throughout the India. It's an observational study, but based upon the real world evidence. So almost say 70 to 80% of the patients were having HbA1c level above the target level that we want, and of the patients who are diagnosed with type 2 diabetes, hardly less than 25% of the patients are using insulin, although the requirement might be still be more, and the average HbA1c in the study of the cohort, which included around 6,000 patients, was 9.2, which is way beyond the target that we want, that is 7%. And this has got an important implication in the sense that, especially into the early part of the diabetes, when we do not intensify the treatment into the in the early part of the diabetes management. So we all know the legacy effect from the UKPDS study. So due to the epigenetic changes, the patients who have really good control over the initial 3 to 5 years, they tend to get lesser and lesser micro and macrovascular complications over a period of time. Although long-term control is, even though if it is almost similar, early blood glucose control is important. So it's, this highlights the importance of initiating the insulin at correct time in patients who have poorly controlled glucose levels. And yes, we have initiated the insulin, but beyond that, what happens? So there is inertia in terms of, there is clinical inertia and also patient inertia in terms of intensifying the insulin dosage. Almost 70 to 80% of patients, either the clinician goes slow in terms of intensifying the insulin dosage, or the patients get afraid that they may get hypoglycemia, or patients may skip meals and get hypoglycemia once in a month, and because of that they tend to take lesser doses, and this happens for a while, leading to poorer outcomes. And to identify the titration inertia and to give the best practices and tools, so there has been a consensus, and in this publication, so in India, based upon the consensus, the average titration dose of basal tends to be around 18 units in the practice, which will be around, for most of our adult population who are say 80 kgs, that will be around 0.1 to 2 unit per kg, whereas the requirement tends to be on higher side to 0.3 to 0.5 units per kg. So, and the titration period also predicts the long-term outcomes. When we are talking of diabetes outcomes, the damage to the target organs is cumulative. So it's better that we minimize the period of exposure to the hyperglycemia for all these patients. And early responses predicts the long-term glucose control, and with almost those who have early HbA1c response at 3 months within range, within the target range, they tend to fare better
over the long term. And in case like a patient gets early onset like hypoglycemia while initiation during the titration phase, that causes insulin fear, and that significantly affects the compliance part. And so there had been basically like survey-based analysis of patients. What is the main issue? What are the like factors which contribute to the titration inertia that we are seeing? And the most important factors that patients feel are like fear of hypoglycemia, and apart from that, the lack of health education regarding the insulin injection technique. And it's important that we, when we are initiating the insulin, it's also important to educate the patients regarding the glycemic controls, and also educate them that they need to titrate the insulin. The intention of initiating the insulin is to have a better glycemic control to the range wherein the micro and macrovascular complications will be minimized. So to balance the glycemic control versus hypoglycemia risk, as we had discussed in the previous sessions also, compared to the previous insulin, previously like a decade or like 2 decades ago, the basal insulin quality was we did not have any like true basal insulin. So the even glargine U100 for that matter acts for like around 18 to 24 hours only. So with the advent of generation 2 basal insulins, we are able to achieve a smoother control with better glycemic control with significantly lesser amount of hypoglycemia. So when we discuss about, think of like ideal basal insulin, we want it to work throughout the day without any fluctuations, without also like it should minimize the glycemic variability, and with flexible dosing in terms of the timing. In case if a patient takes a meal late on one day, or like if a patient goes out like does not carry insulin, they should be able to take the insulin relatively like early or late. So that's the ideal basal insulin. In terms of our journey towards the ideal basal insulin, we are almost towards the pinnacle. In terms of 24-hour like insulin, once in a day insulins, so the both the generation 2 basal insulin work for slightly more than 24 hours, giving us very smooth glycemic control. So when it comes to glargine U300, so the glargine U300 is nothing just but a concentrated form of glargine 100. So since in each ml of glargine 100 contains around 100 IU per ml, whereas glargine U300 contains 300 IU per ml, and all of since it is the surface area of the precipitates are somewhat less, the insulin gets released slowly, and because of that, the duration of action is prolonged. And when we see the real world and the randomized control trials data, so we have data in all the subpopulations of diabetes, both in type 2 and type 1 diabetes. And apart from that, we also have sub-analysis of these trials in special populations like pregnancy, elderly populations, or patients with other comorbidities like CKD and CLD. So we will be discussing a few studies of these, multiple studies. So coming to the H.No study, so this was done in insulin-naive participants with around 4,000 patients, and 1/4 of these patients were from Indian subcontinent. So in the study, like almost the HbA1c reduction noticed was close to 1.87%, and the documented symptomatic hypoglycemia was hardly 0.13%. By 6 months, 1/4 of the patients achieved glycemic control, and by 12 months, like by about 1 year, like almost 50% of the patients were able to achieve the glycemic control, along with the OADs with insulin. And coming to the insulin doses, in the randomized control trials, the glargine U300 was the doses of glargine U300 from the basal insulin was shown to be slightly higher, whereas it comes to real world evidence, the dosage increment was not very significant. And this glycemic control can be achieved with significant lesser hypoglycemia risk. So the key messages from this trial was that subgroup analysis has showed that in real world scenario setting, the glargine U300 was effective at reducing both fasting and post meal levels, as post meals also will be reduced because of lower baseline. And among those who titrate the insulin, so during the titration, the hypoglycemia incidence was significantly lesser, and over time these patients, most of the patients were able to achieve their targets without much hypoglycemia. And so we will be discussing on one more study, BRIGHT study, which has compared head-to-head glargine U300 versus the other second generation basal insulin, that is degludec. So when we see the HbA1c level over the study period, over the 24 weeks of treatment, so the degree of glycemic reduction has been, the difference was not statistically significant, suggesting almost similar glycemic improvement. And along with that, so during the titration period, according to the study protocols, the incidence of the hypoglycemia was significantly lesser with glargine U100 as compared to the IDEC. So during the titration, we can be more confident in terms of, since we have lesser hypoglycemia risk, we can be assured, especially in patients where we expect the hypoglycemia incidence will be more, like elderly or CKD patients. In such patients, during titration, if you are going to have lesser hypoglycemia risk, the clinician and also patient will be more comfortable. So beyond the HbA1c, when we want to improve the clinical outcomes, we want to improve the time in range and also reduce the glycemic variability. And most of the current clinical guidelines are accepting this. And so if you want to improve the time in range, we need to have a smoother glycemic profile with lesser glycemic excursions and lesser incidence of hypoglycemia. And having a generation 2 basal insulin definitely is going to help. Even in the PKBD studies based upon the CLAM studies, so the glargine U300 has been shown to have almost equal action over 24 hours. And so the response of glucose with glargine U300 has been studied with CGMS also. So in the type 2 diabetes flash glucose monitoring study, when it comes to target in this study was basically to compare the U300 versus IDEC, and it was a randomized control trial in a small population of 24 patients with 50% for glargine U300 and 50% for IDEC. So and the primary efficacy was the TAR with the range of 70 to 180%. So when we had seen the TAR was almost comparable, and when it comes to nocturnal hypoglycemia, so the nocturnal hypoglycemia was comparatively lesser with the glargine U300. And the other commonly used second generation basal insulin, as we had discussed, insulin co-formulation, IDEC GASP. So even IDEC GASP was compared with combination of glargine U300 and combination of short-acting insulin, that is Blasel plus. So in this study, twice daily IDEC GASP was compared to glargine U300, wherein short-acting insulin was given according to the glucose levels. And the CGMS data was compared between the two groups. And when we see the target in range, so the TAR was higher in the basal plus regimen as compared to the second generation premix insulin. To certain extent, it's also explained that we will be able to titrate the short-acting insulin in glargine U300 in combination with short-acting insulin versus insulin which has fixed doses of fixed combination of long-acting and short-acting insulin. So in addition to that, the clinically important hypoglycemia, nocturnal hypoglycemia are also found to be lower with glargine U300 in combination with short-acting insulin. And even in insulin naive patients who are uncontrolled on OADs, this can be considered. In a systematic literature review, there were 4 trials with broadly similar patient characteristics were included. In this, there was no significant difference in terms of the HbA1c and insulin doses. As we have seen in the CGM-based data, the incidence of hypoglycemia was significantly lesser, and the glargine 300 was associated with lesser weight gain as compared to pre-mixed insulin, or insulin co-formulation that we would like to call. And it was also with lower risk of any hypoglycemia or clinically significant hypoglycemia. Coming to practical considerations on the use of glargine U300. So during titration, as we had discussed in all these trials, the hypoglycemia incidence is significantly lesser, and different trials have used different different titration algorithms. It can be titrated on a daily basis also, or on every third day, or every week. Whereas in the generation 1 insulins, when we are titrating on a daily basis, we can have with very high doses, it can have peaks, and nocturnal hypoglycemia risk can be there with glargine U100. Whereas it comes to the second generation basal insulin, glargine U300, so that chance is significantly less, and also we can comfortably titrate depending upon the need of, suppose in a patient who is admitted and planned for a surgery like CIBG or something, wherein we want a better control on a faster basis. In such patients, we can titrate on a daily basis. Whereas on OPD basis, if you want to follow up a patient who was on OADs not controlled, we want to titrate relatively on a slower basis according to the current glycemic control.
Doctor, sorry to interrupt. I think we are running out of time.
Yeah. So when it comes to, I will just summarize in 2 slides. So the initial dosage is around 0.2 units per kg, and we can go up to maximum 0.5 units per kg. Even in the special populations, as I have told in the studies of these trials, it has been shown to be significantly safe with lesser incidence of hypoglycemia. And even in pregnancy, there is observational data as of now, although none of the second generation basal insulins are approved by FDA. And the device is isolated device, so there should not be any confusion in terms of the dosing. So to summarize, so second generation basal insulins over a period of time, at this point of time, cost is a significant factor, but over a period of time, these are going to become daily practice, instead of the generation 1 insulins that we are using in majority of the patients.
Thank you, Doctor, for the very illuminating discussion on glargine U300. So I think we'll have the questions post the second speaker. Can we have the intro slide for the next speaker? Yeah, so we have Dr. Abhijit, who's going to take the next session. Very eminent doctor. I don't need to introduce him. He's the consultant endocrinologist at AI Health Clinic and Manipal Hospitals, Hebbal. He's had 17 years of rural medical service at Padma Shri Dr. B. Ramana Rao's village clinic. He's conducted numerous free diabetes health camps, as you can see here, and treated over 3 lakh patients free. He's involved in many clinical trials using big data analytics and using diabetes technology. He's won numerous awards: Economic Times Doctors' Day Award of the Inspiring Endocrinologist of India, and he's won the MedTech Startup of the Year 2020 award by Express Health Heal Foundation. Over to you, Doctor.
Thank you, Dr. Warrior. Thank you from the organizing committee from Magna and Dr. Anantharaman for giving me this opportunity. We have seen now a whole spectrum of talks about insulin. And whenever we talk about any insulin, we have now crossed 100 years with the molecule. Now, what different can a molecule bring to the table, and how combinations can now start helping us, manage our patients better is what I'll be looking at. So this molecule, what we will be covering today, is insulin with GLP-1, and why this is considered a novel therapy is what I'm going to be making my case for today. When you look at any patient with diabetes, we are dealing with a huge number of challenges. And when we especially talk about adding an injectable to the picture, it starts complicating our life, and whether they're able to follow their diet correctly, whether they're doing their exercise when it comes to lifestyle, it becomes even more challenging. And when we add an injectable, it's as if we are committing a crime. But in the end of the day, we have to do what is good for the patient, and by starting the right combination of treatments, because we have so much of choice, that is where we are going to make a big difference to their lives. When we want to talk about what is new, well, this kind of combination of basal with GLP-1, what we call a double basal therapy, has been around, and now we will be talking about glargine U100 with lexniatide, which is the molecule which we'll be covering today. I'll be making my points on why this kind of a combination makes a difference to our patients, and let's see with the 3 studies that I'll be showing how and why this is important combination for most of our patients. This particular slide is the most important component when we treat diabetes. What are the different pathophysiologies our combinations are bringing to the table in order to fight diabetes in this particular individual? And when you have a combination almost covering 7, and if I add an SGLT2, I have all 8 out of 8 of the omnis octet. So I can definitely add an SGLT2 with this combination, and I've covered all pathophysiologies. And that is how we should be looking. What are the the pathophysiologies we need to approach, and how do we need to hit all at one shot? And that is why this combination here in the center, there's one award that is there, but all of us managing our cases and how the patient feels at the end of it is the award that we need to get. I want to highlight only 2 main points when it comes about when it comes to this combination. Is the aspect when we start an injectable, the ability for us to deal with issues of hypoglycemia and especially nocturnal hypoglycemia. Usually it will be a basal, and that is definitely a challenge when we talk about the older generation basals that we have been using. And the next main aspect what we want to do is the beneficial aspects and the cardioprotective effect that we can bring to the table with this molecule. So these are main components. Apart from that, insulin does all of the fasting, PP, A1C. It is the best molecule that we have when it comes to managing diabetes. So it's how we are using these combinations in order to get the best result is what we need to focus on, and why this combination makes all the differences is the boost that we are getting at. And when you look at guidelines as well, especially the international organizations, from 2023 onwards, this kind of therapy combinations after basal, what next? It's always a GLP-1 or an SGLT2 that we are starting to add in order to tackle the multifactorial problems that any type 2 diabetic would have. And as early as the ADS 2024, when we are not getting optimum control with an OAD, then this kind of combination, especially a basal or a basal double basal therapy like glargine with lexniatide makes all the difference. So let's look at 3 studies to make our case. Multiple studies have been done with this molecule in order for us to get the confidence of why we are talking about these combination insulins. The phase 3B trials, phase 3 trials, real world evidence, which is extremely important, and all of us are also learning on the go. The more and more we are starting to use this molecule, and definitely we are starting to see the advantage it brings to the table when we are combining GLP with a basal to manage our cases. So the 3 studies that I will be focusing on is one looking at the glargine lexniatide with idagasp as the first study. So this was done with 582 patients from China. It was a 24-week open label phase 3 trial which basically looked at iglard lexi with once daily versus idagasp once daily. And relatively most of the patients were in the 7.5 11 range. Uncontrolled on OADs were the groups that they included into this study. and basically wanted, the primary endpoint was to prove non-inferiority with the regular therapy that they were using. And they had multiple other secondary endpoints also from this study, which basically to look at obviously A1C control, fasting PP, the effect of hypoglycemia, and any adverse reactions in comparison to Resudeg in combination. So the overall patient baseline characteristics were well matched between the two groups, and the interesting point, even though it is a 0.2% reduction, it was significant in the end when they looked at overall A1C control at the end of week 24, which is extremely important. Now we have covered the basics, good control with this molecule versus IDEGAS. Now let's look at the secondary endpoints as well. Whenever we are starting an insulin, definitely it's an anabolic effect. The concept of weight gain is definitely evident, and we have seen those challenges when it comes to weight gain. But when the overall point that we are making with this combination, when it's in the ratio it exists as a GLP-1, you're not going to see such major weight reduction. But when you're combining it with insulin, you're not going to get that kind of weight gain that you would see, is what we were seeing. And the next important point when you're looking at this double basal combination is the overall A1C control. Not only 72% of them were able to achieve less than 7. The point is we are able to achieve a good A1C control. Almost 26% of them were able to get this great control without having any hypoglycemic episodes. So these are definitely key components. The great part, we are not gaining weight, we are not, the chances of hypoglycemia are much less. So that definitely solves the major challenges that we've been looking at when we look at basal therapy with the patients. Another important point, when they looked at 7-point SMEG values in the solid D trial, was the amount of variability in comparison to with IDEGASP in comparison. And the variability at the end of 24 weeks, whether it was fasting as well as postprandial, was definitely much less. So we are getting better glycemic control with lesser variability, with lesser amount of hypoglycemic episodes. It makes all the difference at the end of the day when we are managing our cases. And another point, when you have good control, definitely the dosage of insulin also starts to come down, and that is what they realized in this study as well. Almost in comparison, 34 units at the end of the study, that was around 0.848 units per kg with IDEGASP, and with a glargine lexinatide combination, it was almost an average of around 28 units. So lesser insulin dose in the end of the day. The level of any hypoglycemia, level 1 hypoglycemia, level 2 hypoglycemia, almost less than 29% in the study that they studied, what they looked at with the data. So this is definitely something important, and when they looked at specifically nocturnal hypoglycemia, almost 2.8% versus 5.8% with IDEGASP. So it is important that we are looking at a molecule from every angle, and in the end of the day, when we see these combination of problems our patients have, it helps us navigate the management much more better. It's not that one molecule is better than the other, but you will get a good group of patients having these challenges. So now you have these options, and that is what the study is trying to highlight in the end of the day. So it is non-inferior and statistically superior A1C control, overall superior weight loss benefits was there. The composite endpoints were achieved in higher number of cases, lower risk of hypoglycemia, and there was no unexpected safety concerns with the molecule. Now moving on, when we look at what to start with, why should we look at this combination insulin of glargine and lexinatide versus, any other, probably just a basal or just a GLP-1. So that is what we are looking at this Lexilan-O study. We are looking at why having this dual combination of formulations is more better. They looking at just lexinatide with people who were uncontrolled plus metformin. They looked at the insulin glargine lexinatide metformin combination and glargine metformin combination. So the overall to primary endpoint was to look at non-inferiority in A1C was the end of what they looked at, and evidence is pretty much clear with the A1C reduction in this combination of almost minus 1.6%. Fasting plasma glucose also was superior to our postprandial glucose, was good in the GLP as well as the double basal combination. The average throughout the day profile was much more stable in this combination, and the number of percentage, 74% of them were able to achieve their A1C target at the end of the study is what they realized, and the weight reduction was also superior. So definitely as a first start, and looking at all these the patients usually come with multiple complications, and in the end of the day we are, with this evidence, we are able to clearly show that in the Lexilan study that this combination works. And now let's look at our any kind of most first choice in when it comes to the Indian scenario, when it comes to the use of the kind of carbohydrate rich diets that we do. So it's always a premix or a premix analog that we tend to start off with, or has been the most common combination, and let's see how glargine lexi does in this study that was done with around 887 patients. So they looked at type 2 diabetic population and people who are already on the basal insulin OAD uncontrolled, and with uncontrolled diabetes of around 7.5. So around 440 patients in each of these groups, and the Indian, it was a multicentric study, and almost around 182 were from India. Looking at the overall A1C reduction and weight benefit when you look at any premix versus the glargine GLP-1 combination, almost 1.3%, minus 1.3% in comparison to 1.1% weight, almost weight loss of around 0.7 was seen, kgs was seen in comparison to the premix insulin. So you have a superior A1C reduction with weight reduction benefits, and the secondary endpoints also with regard to the number of patients achieving A1C control without hypoglycemia events, almost 19% was seen in this combination, which matches the previous premix analog that we also spoke, co-formulation versus now we are talking about a premix analog. So the total insulin dose also was almost 10 units versus 22 units in this study. The lower risk of hypoglycemia also is continued when we are using this combination in all the levels of hypoglycemia, and so when we look at the Solimix as well, we are seeing similar results in comparison to the other studies that we have discussed. So in summary, when you look at this combination, we are seeing better glycemic control, lesser hypoglycemia, fewer daily injections, and the number of adverse events in the end of the day, it is almost similar. So to talk a little bit about how we are going to start off and what is the dose and titration.
Sorry, doctor, the time is running out, but
yes, sir.
You can conclude.
So anyone with less than 10 units already taking a basal insulin, you can start with a similar dose. Anyone more than 20 units of any basal insulin, you're going to start with a 20 dose step. Anyone who's also drug naive, you give him a 10 unit. And the dose titration also as per 4 units if not in control, if anywhere between 140 to 160, 2 units. And in all the special group population except in pregnancy, the molecule is safe. Hepatic impairment also, we are seeing the safe use of this molecule. So to summarize, one injection once daily, 1 hour before the meal is what we are saying with this molecule, and the evidence speaks for itself. Thank you for your patient listening.
Thank you so much, Doctor. Very enlightening session on glargine lexosinide combination. So any questions from the audience for both the speakers?
Regarding glargine insulin, there are various brands. Is there any comparison between different brands? And even generic also is available.
Yes, sir. So quite a lot of studies have been done with biosimilars to prove this non-inferiority, and I think most of our Indian companies, kudos to them for able to crack the code to come up with their own biosimilar. So we are not seeing there's good enough of volume of data to say that in comparison to the innovators, we are seeing similar results with both all brands of glargine, sir.
Generic one?
So now that is the challenge with the generic is the who's monitoring the safety, how is the cold chain being stored. So that is why a trusted company will have their audits done. So when an insulin leaves the factory, goes to the distributor, farm distributor, to the final point of sale. In all of these places, the audits have been done. Now when you start looking at, I'm trying to cut costs, where do I cut costs? So they will, the ability for us to monitor, to have audited data to say that, the generics have followed all these protocols is difficult. But when a company is saying, look, I have all the evidence, it's not that we are saying the generic is better or not, but when you talk about certain generics, if they have the evidence to suggest that the cold chain is maintained, as I mentioned, the biosimilar studies that we have gives us the confidence with the use of these molecules. And your patient control, being controlled with one brand, suddenly they've changed. Outright, you will see changes in the end of the day.
Any other questions? Sir, I have one question. What is your insight on comparing glargine lexosinide with degludec lira? We also had a combination like that.
So thankfully I have not put the comparison, but the point we want to make, we need to be targeting diabetes from a multifactorial approach. And the studies what are there, the head-to-head as we are still yet to see that kind of data with these two particular molecules. But the evidence is all in favor of starting GLP-1 when we need to start to look at fasting postprandial as well as reducing variability without the hypoglycemia. Both these molecules are on a level which are giving us the confidence to to manage our patients much more better.
Any other questions? So, Dr. Varun, a quick question. So, I know you talked about the BRIGHT study, which glargine U300 has a lower risk of hypo compared to degludec. But on the other hand, we see degludec claiming that, we see the DEVOTE trial and all that, we see degludec says there is lower risk of nocturnal hypoglycemia from their study.
That's only during titration period.
It's only during the?
Titration period, like during that study.
Which one? In the
BRIGHT study, like lesser incidence.
Okay, okay. It's only during the titration period we see the difference.
Yes, yes.
Okay.
two, so these trials will have a specific titration protocol. So with that protocol, the hypoglycemia incidence was lesser. So
okay.
we had to take these with pinch of, not
Exactly.
buckets of salt. Yeah.
Thank you. Any other questions?
This 7-point SMBG, you have said that 7th point is, 6th point is 2 hours after dinner, 7th point is
Midnight,
before
sir.
bedtime.
Bedtime, yes, sir.
Is it bedtime or 3 a.m.?
So 2 a.m., 3 a.m. mid.
They have to keep an alarm.
So that is so it was done for the study purpose. So they made sure that they were looking at 7-point levels. Sir.
Because 2 hours after dinner will be almost bedtime only.
Yes.
That's why.
So
All right, if no other questions, we can wrap the session. Thank you so much, Dr. Varun and Dr. Abhijit.
Thank you.
Thank you.
Dr.
Thank you.
Thank you. Thank you, Dr. Varun. Thank you, sir. Next time we'll work on that.
Yes. Sure. So, Dr. Abhijit, you have to be next chairperson, so you can just. Dr. Ruth, thank you for coming. Please collect a token of appreciation from us. So, for the next session, so we have already had introduction of Dr. Abhijit Bograj. We are happy to have you here. And for the other chairperson, I am delighted and privileged to have my senior and my senior colleague, Dr. Dwarkanath sir, to be here. So sir is a consultant at Apollo Hospitals, Bannerghatta Road, Surya Endocrine Center, and also at Kanwa Diagnostics, Nagar. So he had been organizer for many meetings like ESM, SECon, and also ITSCon, and he is one of the senior most endocrinologists in Bangalore. Thank you, sir, for coming. Sir had some personal commitment, but still made here. Thank you very much. I request the chairpersons to introduce the first speaker, Dr. Bhavana.
Thank you, Dr. Anantharaman and magnacode for having invited me as a chairperson for this session. I have the pleasure of introducing my friend's daughter, Dr. Bhavana Sosle. She did her MBBS MD from MRCPS. She has done a certificate course in diabetology, Global Research Scholar Program in Harvard Medical School, and she is the director of Diacon Hospital, Bangalore, vice president of Premier Academy of Medical Sciences. And of course, she has been a principal investigator, co-investigator in so many clinical trials, especially in the field of diabetes, hypertension, CV risk, artificial intelligence, and diabetic retinopathy. I will hand over the mic to you.
Thank you. Thank you, Dr. Dwarkanath and Dr. Abhijit. Thank you to the organizers, Laxmi, Varun, Dr. Anantharaman, for inviting me here, and for all of you who have stayed back. This is an old topic, but we're going to see how sulfonylureas and metformin are still relevant today in our clinical practice when we treat patients with type 2 diabetes. So while we have a lot of different newer therapies available for us today, we have a ton of newer insulins, second generation basal insulins, we have co-formulations, combination injectables, we have SGLT2 inhibitors, GLP-1 RA, so we have all of this. But the core of management of diabetes hasn't really changed all that much in the past decade. So it tells us still the same basic things: control your sugars, take care of the patient comprehensively, minimize complications, look at what your patient's comorbid conditions are, what they need, and then you want to think of safety, minimizing adverse events, and cardiorenal protection. So over a period of many years, at least the last decade that I have been working, the guidelines have more or less told us all this. And it has only gone and become more individualized, where we're looking at specific goals, what the patient needs, their routines, their weight, hypo risk, CV risk, renal risk, and then also there's MASLD added into this, which is not shown in this particular slide. So we're doing all of this, and that remains the basic foundation of management of diabetes. Now going back to an older graph that you've probably seen several years ago, this just is to remind us that over a period of many years, people develop insulin resistance. And this starts increasing with age. Maybe we'll put on weight, we start getting older, our lifestyle changes. So there's a positive calorie balance, a little bit of fat getting stored in different organs. And then at some point, the beta cell dysfunction sets in, right? So initially what happens is the beta cell is able to compensate, so it's able to produce more insulin, and then it reaches a sort of a Lakshman Rekha where it can't do that extra work anymore, and then it starts to fail. So there's insulin deficiency. So even though we see an initial compensation, at some point it's only and only when that the pancreas is unable to compensate that a person gets type 2 diabetes. So remember, in your spectrum, you have thousands of patients who have obesity, but not all of them get type 2 diabetes. They may have other comorbid conditions. So they do have hyperinsulinemia, and at that point they are able to compensate. So the pancreas is still the core of the several pathophysiologic defects that we see today when we're treating patients. So we're still using a lot of therapies that address multiple problems. So we're not, going back to the UKPDS days of I will only give sulfonylurea, metformin or insulin. Certainly not, but this is just to emphasize that despite the fact that we've come a long way in CV risk reduction, we shouldn't forget what the core defect actually is, and it's the fact that our beta cells need a little bit of a push to produce insulin when it can't do on its own. So when we think of using sulfonylureas and metformins today, we do use modern sulfonylureas today. We're not really using glibenclamide anymore. We use it because they work together on two different pathways. Metformin reduces the hepatic gluconeogenesis, and sulfonylureas act on the beta cell, and it makes the person produce insulin. Now, the UKPDS study has gone on for several years, and there's actually a follow-up study from May 2024, and even that study tells us the same thing, that the lifetime risk of diabetes-related complications after all these years of follow-up was actually better. The risk of complications was lower with intensive control. So again, as I said, the drugs that we use are different. Today we use modern sulfonylureas. We're not using the ones that were used in this particular study, but it still brings us back to the concept of aggressive control, early control, intensive glycemic control, keeping in mind that we shouldn't forget that the pancreas actually is not functioning, and this is really the reason why someone has type 2 diabetes. Now, what are the other reasons in clinical practice to consider using these two agents? They work fast. Okay, sometimes people have really high sugar, so we might even start them on insulin temporarily, even at diagnosis. But even with that, they want faster control. Patients are not going to be happy if they see the values declining over a month, which would what happen, or maybe 2 months if you were to use a GLP-1 RA. So many times the choice of therapy dictates the patient characteristics and preference. So you want faster control, sulfonylureas work faster. And we also see patients in clinical practice who don't always come to us in time. Okay, so no matter how specialized a setup you're working in, your patients are coming to you later than whenever you have advised them to turn up. So they're not coming at A1Cs of 7 or 7.5 or 8. They're coming to us at values of 9 and 10 when they've tried everything on their own, all kinds of diets that may or may not work, and then exercises and fads, and then they're coming to you with a high level and they want to see results. We also have sufficient safety data with sulfonylureas and metformin. I'm not going to go over tens of thousands of slides, but since these are time-tested molecules, we also have data from Carolina, and there was no increased risk in CV outcomes when this was compared to a DPP-4 inhibitor. Of course, it was actually comparing Glina with glimepiride, but we didn't see an increased risk in either arm. Now this particular slide is a slide from the JADE study. Okay, so this was looking at multiple centers across Asia between 2007 and 2019, looking at primarily treatment practices in patients with young onset diabetes, and trying to see what medications were being used and when medications were being up titrated. So this was a real world study over a long time. And what was seen is that across various countries, India, China, Hong Kong, Indonesia, so whichever Asian country you look at, the SU use was over 50%. So sulfonylureas, even then, a couple of years ago, and even today, still form a major chunk of our prescriptions because the two medications do have good efficacy in glycemic control. In addition, what are the advantages? They're cost effective, they're available everywhere, and this is very important for our patients because we don't always see, I work in Bangalore, I don't always see patients from Bangalore. I see patients coming from Mysore, coming from Hindupur, coming from Tumkur, everywhere but Bangalore actually, because it's the person in Bangalore who wants to go to the clinic next door. So the spectrum of patients you see are actually probably wider than your actual geography. And we also have a ton of trials to back up the data with modern sulfonylureas. So we have ADVANCE, we have START, we have Toscaid, Carolina, great study, and of course the UKPD's latest results as well. So if we need to think of a few reasons why we need to consider using glimepiride plus metformin, they work differently, so complementary mode of action. Using both together, obviously better glycemic control. We have a data from a ton of studies that better control reduces the risk of outcomes. I'll emphasize on low dose because if you're worried about hypoglycemia, making sure your sulfonylurea dose is lower can actually mitigate this risk. We achieve better control using 2 molecules than with just 1. Works well if you want faster control. Cost effective, certainly. Time tested, a ton of clinical trial experienced, practical experience that everyone has. The medications are oral, available in multiple dose strengths as an FTC also. So historically, these 2 molecules have been the cornerstones of treatment for diabetes for several decades now. They've been very well studied, they're cost effective and widely available. They're compatible with all the other anti-diabetic medication that the patient is on. So the patient can be on an SGLT2 inhibitor, the patient can be on a GLP-1 RA, the patient can be on insulin, and they can still be on a sulfonylurea with metformin. There's no reason to actually take this off. So it's also acceptable to a broad spectrum of individuals with type 2 diabetes. So we can use it at diagnosis, we can use it after several years of diabetes, long-standing diabetes, diabetes with complications, in special populations, even in the elderly. There are even studies that have been done in individuals over 90 years of age taking sulfonylurea metformin. In people who are fasting, there are studies. Then there are also studies that it can be used in comorbid conditions as well. Of course, the dose may need to be down titrated if we see changes in the GFR and as the patient gets older. And I think that's where modern sulfonylureas and low-dose sulfonylureas actually come in. So while all the backlash the SU has got is because of the hypo, there are several ways for us to use a sulfonylurea safely. Use a modern sulfonylurea. So we have glimepiride, we have gliclazide. Start with a lower dose, then up titrate. If your patient's getting older, think of de-intensifying or reducing the dosage. Talk to the patient about hypoglycemia, monitoring, and how to avoid hypo, and what to do in case they do have a hypo. So currently, sulfonylureas still are very, very relevant in our practice. They make up a ton of our prescriptions. We use it very, very frequently to get our patients to control. What has evolved is the place in therapy. When there were no other molecules, obviously these were the only 2 agents that were used. Today we have a lot of other agents that we can use. And I think we're wise enough standing here today to know no one cares about what is first line, second line, third line anymore. it's not, you know, an Olympic medal that someone has to win. What we need to figure out is where we place it. So your first line therapy might not be an SU metformin today. You're likely reducing CV risk, protecting the kidney. Your first line therapy is mostly going to be an SGLT2 metformin today. But what next? Or what if a patient can't take it and then the patient needs faster control, or a patient has high sugars, and that's where sulfonylureas metformin come in. And because we can use it with all the other oral therapies that are available, and there are multiple FDCs available, it certainly makes it easier for our patients to take it. So the place in therapy has evolved, and while there is no first place anymore, we are already moving towards a more personalized and individualized care, where we look at the age, we look at the comorbidities, we look at the hypoglycemia risk, we look at the cost-benefit ratio. It's not going to be one for everyone. Every patient will need different medications, and sulfonylureas and metformin, the lower doses, certainly have a place in therapy. So I had a patient who came 2 weeks ago. He was an industrialist. Money never an issue. He was put on the DPP-4 metformin and EMPA, and he had stopped all of it, and he said, why? I will take glimepiride, and he had started taking 8 milligram on his own. And this was after 2 bypass surgery, and I said, okay, you want to take the sulfonylurea, we'll give you the sulfonylurea, but you are going to need these other medications. So our role has changed to also incorporating what the patient needs, because they read all these things and they say, why can't I use 8 milligrams in my practice? So this was the first time someone had come, a patient had come and asked me that. So we have a role for sulfonylureas. It just has to be a lower dose, and we can use it with all the other newer medications that are necessary for cardiorenal protection. So with that, thank you very much. Thank you. Done.
I invite Dr. Swati Jadhav to come onto the stage. Madam is a director of Endocan and Hormone Clinic in Nagar, Bangalore. She is a consultant endocrinologist at Trustwell Hospital. She also deals with endocrine oncology cases at HCG and is associate professor at WIMS, Bangalore. Madam is a recipient of A.V. Gandhi Best Clinical Research in 2016. She has won many oral presentations, and she has a varied interest in diabetes, osteomalacia, endocrine cancers, almost 35 publications in national and international journals, 3 chapters in international textbooks. Over to you, madam.
Thanks a lot, sir. Thank you for the kind introduction, and thanks the magnacode team for giving this opportunity. And I think the time that we are in today, towards the end of the day, it's like testing the human attention span and the tolerance of it. So I'll be really quick here. So my topic is, the name itself suggests what are the 3 important things I'm going to speak about. It's metabolic care and not glycemic management only. Combination and dapagliflozin. So SGLT2 inhibitors, my previous speakers have also referred to that. Whatever diabetes molecule you are talking about, there is always a reference to this, and the combination. That is the key for today's talk as such. So we strive to control the sugars, not for the sake of achieving some numbers, but the path to the mortality is by cardiovascular, stroke, renal, and MAFLD. And how do we delay this path, or how do we change the outcomes? So as everybody has referred to, that old paradigm would be achieving the specific numbers, but now it is looking at the weight and looking at the specific molecules which will help us achieve the cardiovascular, metabolic liver disease, and renal outcomes. And based on that, the pillars for the foundation always remains the lifestyle modification, but Glycemic management is just one aspect, and we have to look at other things also. And one of the important pillars becomes the agents which have proven to have cardiovascular and kidney benefit. So moving on to dapagliflozin, because that's what I'm supposed to talk about today, and let's see about its cardiovascular effect. SGLT2 inhibitors, we understand they cause glucosuria, they cause natriuresis, but apart from that, there are several pre-human clinical studies, animal studies also to say that there are a lot of pleiotropic effects in other organs as well. And as a result of which, if we look specifically for dapagliflozin, the DECLARE-TIMI 58 trial, it is the largest trial for SGLT2 inhibitors which shows its benefit, and across a different across a different patient populations, which involves those which don't have established ASCVD but those who have multiple risk factors, and as we can see, it has shown effect in reducing the major cardiovascular event in those who have established ASCVD but not in others with risk factors. But there are definite benefit in terms of hospitalization for heart failure, that is true. And DAPA heart failure study, it has shown that it definitely has got effect in reducing the hospitalizations and mortality from heart failure in irrespective of whatever the patient underlying baseline characteristics are, whether they are diabetic or not diabetic, whether they have whatever the etiology of heart failure, whether they were on pre-existing diuretic therapy or not, across different subsets, dapagliflozin definitely has shown improvement in heart failure outcomes. Regarding MAFLD, which is very talked about now, that NAFLD has been renamed as MAFLD, and the guidelines have incorporated how do we manage that. And in the specific group of patients where we have NAFLD and type 2 diabetes, very few agents have been shown to reverse the steatosis and reverse the fibrosis. So SGLT2 inhibitors have found their way in management of these patients, because a lot of studies have shown the reversal of at least steatosis and in these set of patients. So definitely it has got a place therein. Regarding renal outcomes, again DAPA-CKD trial has shown that there has been definite benefit in reducing the incidence of worsening of CKD to an average sum of all these parameters, with a number needed to treat of just 19. So very beneficial, and now the more and more focus is going on the use of it even in non-diabetic proteinuric diseases. So depending on the data that is available, so SGLT2 inhibitors have got a very prominent role in preventing progression of CKD in ASCVD, in heart failure, with a very low hypoglycemia risk, and definitely with the weight loss as additional benefit that we can accrue to. Even in renal society guidelines, it is considered to be first line therapy in management of diabetes in patients with CKD. So coming to that, when we say this, when we want to achieve this comprehensive metabolic care, what are the unmet needs which are there in managing the type 2 diabetes? Definitely we require, if we have to address so many aspects of this octet, we can't have drugs. We have drugs which have overarching effect on that. So many drugs act on different aspects of it, but sometimes we have to take the combination. As sir has also said, that if we add SGLT2 to most of GLP-1RA or this thing, we can cover most of the aspects of that octet. Let's talk about the data of SGLT2 inhibitors and DPP-4 inhibitors as a combination therapy. In trials, it has shown that when dapagliflozin is added as an add-on to sitagliptin monotherapy, there is definite improvement in glycemic parameters. And why would that be so? Because again, we are covering several aspects of the diabetic pathophysiology. SGLT2 inhibitors will cause glucosuria, and they will reduce the glucose load, reduce glucotoxicity, bring about the weight reduction, and reducing the systolic blood pressure because of a kind of natriuresis they set into it. But they have been shown to have indirect effect on pancreas. When I say indirect, there are no studies to suggest that they directly have effect on beta cells, but indirectly by causing the kind of state what we see in mild diastolic starvation kind of a state where they increase the glucagon secretion and bring about more beta cell sensitivity. As against this, DPP-4 inhibitor have effect on incretin effect, and overall they will result into a good synergistic action in controlling hyperglycemia, leading to weight loss, if not at least weight neutrality. So there had been this expert opinion which has been recently published, which has talked all the evidence base regarding SGLT2 inhibitor and DPP-4 inhibitors in Indian setting per se. And what they have said that this combination is safe, it's rapid, it sustains the glycemic control, it improves insulin resistance and beta cell function, it has got favorable effect on body weight and blood pressure, and more importantly, combination as the logically it will improve compliance by reducing the pill burden and eventually leading the pill cost also. Very interestingly, we all know that SGLT2 inhibitors can cause genitourinary tract infections. But what has come up from this meta-analysis is when we combine SGLT2 inhibitors with DPP-4 inhibitors, actually surprisingly, the genitourinary tract infection incidence was shown to be a little lower than that of SGLT2 inhibitors alone. We don't have a valid pathophysiological basis to explain this phenomenon. There are several proposals, pathophysiological proposals, which are led to that DPP-4 inhibitors are also expressed by the microbes, or the renal tubular epithelium, which has got both SGLT2 as well as DPP-4, they may have some effects to repel or to let the microbes not get advantage on attaching to the renal tubular epithelium. So there are a lot of things, but this is observation which has been seen in several studies. Whichever way, SGLT2 inhibitors, the risk and benefits we always have to weigh to see in an individual patient what we can advise them. So if the initial HbA1c is more than 7.5, then early combination therapy with 2 agents is needed. If it is more than 9 or 1.5% above goal, then even 2 to 3 anti-hyperglycemic agents can be initiated. That is what most of the algorithms also say. And that's again the basis of ADA 2023. What I'm trying to impress upon is the combination therapy is endorsed by most of the guidelines. Advantages of this combination is it can have rapid and sustained glycemic control, improvement in insulin resistance and adiposity, decrease in metabolic vascular risk because of the proven agents that we are using. It is simplicity for better adherence is also there. Real world data of this combination of dapagliflozin and sitagliptin has also been shown to be effective in terms of reduction in HbA1c, reduction in fasting and plasma PP control also, and it is safe as well. There are some other studies for dapagliflozin and metformin fixed dose combination that also has shown similar kind of effect in weight reduction. And when we talk about weight reduction, this is a meta-analysis of several studies which has shown that weight reduction with dapagliflozin or SGLT2 inhibitors is definitely a reality. Amongst the SGLT2 inhibitors, dapagliflozin itself has got a lot of database for its safety, efficacy, and cost-wise also it's better. And when I'm talking about combination, I will end by saying that why only SGLT2 and DPP-4, we can have the combination of metformin as well, just give one pill, and then we address as many components in the octet as possible, and that way we can ensure improved glycemia and several other benefit, which has been proven in some trials also. So combination therapy, metabolic care, and dapagliflozin, the 3 components of my talk. I think there is a lot of database for us to have faith in that and start using in our patients. Thank you.
Thank you, madam. Yes. I now invite Dr. Rajeshwari. I had the pleasure of working with madam in now Manipal, Yeshwanthpur, before erstwhile Columbia Asia. Madam also visits once a week at her clinic in Tumkur. She is a presenter in multiple programs, and she has vast clinical experience and many publications. Over to madam for the next discussion. Thank you, madam.
Thank you for the kind introduction, Abhijit. I thank at the outset Magnacode and Dr. Anantharaman especially. So we have seen so many speakers talking about oral medications, and then we have injectable, various types of injectable, insulin, non-insulin, etc. But why is it? Why are we talking? Is it that because of hypoglycemia, new and newer medicines came in? No. Then what is the problem? There is beta cell failure in type 2 diabetes. So we know type 2 diabetes is a progressive disease. It's not like, a single, like, one time thing. It's over time. We see even in reality, in day-to-day practice, many patients keep coming and saying that, they were on one medication, then the next one, like that. So it is a progressive disease, so we should understand and explain to the patient it's not their mistake. They feel very guilty about it a lot of times. So sugars keep going. Why? Because the beta cell failure happens. So when we say diabetes, what is the two causes? One is insulin resistance is there, then there is beta cell failure or reduction in beta cell function. Combination leads to diabetes. So what is the role of insulin secretion? Glucose, as it enters into the cell, then there is, it's oxidized, right? Phosphorylation happens, energy is released. What happens in the beta cell? The energy is used to secrete the insulin. That's what happens. So there is influx of, potassium levels increases in cell, leading to influx of calcium and insulin release. So when we talk about insulin deficiency, I would say it's a relative deficiency in type 2 diabetes, unlike in type 1. One is beta cell function reduces, other is beta cell mass itself reduces over a period of time. It has been studied in many autopsy studies, they have shown. So both lead to the insulin secretion. So when we see this one, the blue dots, this is the normal glycemia lean patient with normal glycemia, and then there is the green ones, which is the obese normoglycemic patients, and then IGT, and the blue one is obese ones. IGT is the green one and the red. As we see, gradually the beta cell glucose sensitivity is also comes down. So it's the best one is in the lean patients, normoglycemic, and then in the obese. Compared to the obese, even in the IGT, it's even lesser. So approximately by the time we diagnose diabetes, almost 50 to 80% of the beta cell function is lost. Okay. So when they progress from pre-diabetes to diabetes. So when we look at the beta cell function pathogenesis in type 2 diabetes, one is by the time clinical onset of diabetes, major beta cell function is, or the function, secretory function is lost. Whether beta cell itself reduced, we don't know to what extent. I don't say it's more than 80%, but function is reduced. And different people will have different degrees of insulin resistance. Even in clinical practice, we see a lot of patients lean, minimal or no acanthosis can have diabetes. So it all depends. When we look at the beta cell function itself, I would say it is contributed by, one is the genetics. By genetically or intrauterine life, there is some amount of beta cell all of us are born with. Okay, and how long it is going to work will also depend on what all the things. One is insulin resistance. There is excess insulin resistance, but that itself doesn't lead to diabetes, right? So there should be beta cell function. After some point, to overcome this resistance, the pancreas works harder and harder, it fails. That is, insulin resistance itself will lead to beta cell loss, one. And we know, even in type 1, we call honeymoon period, whereas in type 2 also, once we control, initially they come with very high sugars, we give them insulin temporarily, and after a month or so or 6 months, we can taper off easily, and they may be on simple medicine like metformin or a DPP-4 combination, and so that's because that is glucotoxicity. Similarly, there is lipotoxicity, high triglyceride lipotoxicity also reduces the beta cell function. Of course, inflammation is one more thing that we see. Pancreatic probably is chronic inflammation, like in other organs could be causing, and amyloid deposit in the later stages of diabetes. Of course, a small number of patients may have some amount of autoimmunity, what we call as the LADA. That may be also. Of course, other speakers have spoken how each of these can be tackled with different medications, including insulin. This is the UKPDS style, which they looked at. By the time, they projected it backwards from the time of onset of diabetes, how it is declining. They projected it backward and said, by the time diabetes onset happens, almost 50% or more of beta cell function is gone. When we come to our Indian population, South Asian phenotype, we are different from the Caucasians because we may be the same BMI. When we compare, amount of abdominal visceral fat is much more in Indians, and we have more hyperinsulinemia, insulin resistance. Of course, probably our beta cell mass itself probably is going to be lesser, I feel. And we have a typical dyslipidemia, hypertriglyceridemia, very low HDL. These are very typical for us. And we are and very highly susceptible for cardiovascular diseases at pretty younger age also. So this is the pathological what we see, and ultimately what it amounts to a real life practice. The percentage of diabetes is higher in Indians, and it onset is also, most patients are in 50s and 60s, but the onset we are seeing in younger age, in almost late 20s to 30s. A lot of patients are newly diagnosed with diabetes, and when we look at complications, especially in the younger onset diabetes, it doesn't take 10 years. In fact, by 5 years you see already some changes of complication, albuminuria already there. They can have macrovascular disease itself. So we get complications also much earlier in our population, and very difficult to maintain glycemia due to various reasons, patient awareness, accessibility to medicines, and so many things. So overall summarizing, younger people, younger onset, more complications in a very younger age, and poor glycemic control. So we have various OADs we have seen is available for us right now, not just metformin and sulfonylurea. There are so many which are other benefits like cardiac, renal, everything. But some of the question is, over time we are going to add more and more medication, and beta cell function we are not bothering about. How can we prevent or reduce the rate of falling of the beta cell function? Is it possible? How do we achieve without major side effects? This is one of the studies. This is it's very crucial, very important to initiate the treatment very early. Even ADA 2023, we start. Many of them even A1C of more than 9%, definitely 8%. You start with 2 medicines or 3 medicines, even insulin also they say. So start very early. Don't wait for one treatment to fail and then start another one, because the more exposed to hyperglycemia, lipotoxicity, more beta cell function will drop. So one strategy is to start early treatment, hit hard, hit very early. And if you need combinations, yes, please do you start using combination very early. Don't wait for one treatment to fail. So this is the verified trial which I think Dr. Swati also mentioned, where the ADA says, start with dual medication even from the start. That is from the evidence got from the verified trial. Basically, this looked at the long-term durability of this dual combination. When patients, it is around 2000 patients over a period of 5 years, they looked at the beta cell function and durability of the treatment by starting combination, that is metformin and vildagliptin from day 1 of diagnosis. And they didn't have very high sugars, like it was 6.5 to 7.5. Despite that, they added that combination and followed them over a period of 5 years. We have seen like many trials looking at the complications after starting many OADs, whether for cardiovascular risk, renal complications, all this ACCORD advanced trial. Then we have many others for cardiovascular, to canvas, leader. Every drug has been shown. But unique about UKPDS is day 1 they started the treatment and monitored them. And verified trial did also the same thing. What is the difference here means, in verified trial they didn't wait for one medicine. For example, in UKPDS they say they started sulfonylurea or metformin, then one failed, they added the insulin, like that they went step by step. Now we are much more wiser. We are not going to add that stepwise, instead start the combination. They wanted to see if by doing that we get any benefit in preserving the beta cell function. So this is what you can see. The red ones is with metformin, that is where they use a sequential. Start with metformin, then if it fails, then add vildagliptin. Same medication they used. The other one, they used combination of metformin and vildagliptin from day 1. And by 6 months, some of them didn't function. They are the primary failures. Probably they have maybe, I said LADA, that type of group. So they didn't work for them at all. Then after that, by 6 months, you can see the gap. many people with metformin were failing to treat more and more, failure to therapy. That is, so that was there, whereas with vildagliptin and metformin from the start, if they have a combination, they did better. We can see monotherapy, like metformin monotherapy, the median time for failure was 36 months. Okay. So, whereas when they combined, it was about more than 61, because it was extrapolated. The study ended at 5 years. So, beyond that also they could have actually seen, but they had predetermined times. So, initial failure, as I said, 15%, a primary failure was there. After that, people with sequential, they failed the treatment much earlier compared to the early combination ones. Even though the same medicine was used sequentially, that is the point to be noted. Then secondary failure, initially in the achieved treatment failure, the combination after adding metformin also, vildagliptin also, then they see these two. Those people whose vildagliptin was started later, they still tended to fail much earlier compared to the one who were started early. So starting early on helps in preserving the beta cell function. That is the reason probably they didn't need insulin much earlier. So the time to first adjudicated macrovascular event, not only that, beta cell preservation, macrovascular events also, if you see very early on, you can see with the sequential treatment they had. So you remember the UK PEDIAS trial. Initially, when they did the trial for first 10 years, they could show the reduction in microvascular complications. But in the first 10 years, when they actually did the study, they didn't have much benefit of macrovascular. But when they started looking at follow up the patients at 15 years, 25 years now they see there is benefit. So when they started this combination therapy, in this they could show even by within 1 year, there was benefit in the macrovascular complication events. Even though the number of events were very small, because of the number and the duration was much smaller, the numbers definitely are lesser in the combination group. So benefits of using the combination, early initial treatment failure is lesser, and later secondary failure is also lesser, and there is reduction in the macrovascular complication risk. Of course, the combination of they use vilda with metformin, there is no risk of hypoglycemia, right? And the other thing one may ask, why should we ask 2 medication at once? Right now they are not even cost wise also not very difficult to achieve. So probably it's a good thing. When we say any A1C of 6.5 to 7.5, what is theirs? Can we use any other combination than this? For example, SGLT2, yes, definitely, probably, we don't know, but whether the longevity of the treatment, all that has been studied for long. Shorter periods they have done, but not for long. Whether can we use sulfonylurea? Probably at this dose, risk of hypoglycemias are higher. GLP-1, no one will be ready for it. Starting off an injectable one or oral one, unless obesity is a major issue compared to diabetes. So looking at what happened to the insulin secretion, we are talking of beta cell preservation, right? So the change in the area under curve for the insulin secretion, that one over, the first panel is starting of the one period where the initial failure happens. We can see that the drop in the the insulin production or the curve is lesser with vilda combination early rather than the green one, which is only metformin. We can see over a period of time also, the first failure and the second failure also, the drop is much more when they use sequentially rather than combination at the first. And looking at annually also, every year, you can see that area under the curve, actually in fact the amount of insulin secretion increased with the combination initially rather than the adding of the drug later part. So over a period of time also, it's not overall group, but over a period of time there was shown that insulin secretion is preserved better. Then they looked at sub-analysis, whether younger patient or older, late onset diabetes, is there a difference? If we use this combination, definitely we can see young onset. The first 2 graphs are monotherapy 1 and combination therapy. We can see the difference, mono and in young onset ones. So, and that the benefit is much more than the people who got diabetes later. So, as I said, in India, younger onset are getting diabetes complications. So, if you use a combination even early in the young patients, probably we are going to preserve the beta cells for longer period, and so hence complications also can be preserved, and we can use minimal medication over longer period of time. So the difference is about 48% benefit in the young onset compared to 24% in the late onset diabetes. And looking at the sub-analysis, improvement in the beta cell, that was found to be higher at the end of the study. Definitely you can make a very significant difference as numbers. So the question we asked was, is it initiating dual medication right from the beginning beneficial in preventing the beta cell loss? Definitely. Instead of sequential one, using combination from the start definitely help in reducing risk of treatment failure by 49%. By more than within the 2 years period itself we can make out, and the durability was been shown up to 5 years also in this trial. So is there any other drug that has been shown? One is sitagliptin. However, the effect was not for a longer period, about 1 year or so, among the DPP4 inhibitor. Any other drugs, like they have shown for pioglitazone and GLP-1 receptor analogs mainly, but not for such longer duration of treatment. So this is a small study, about 10 patients they studied who had DPP4 naive patients and enrolled in the study before.
Any more slides?
Yeah, that's all, almost done. 3 months after the twice a day, what they found is, again, the initial first phase insulin secretion is much better after the 3 months treatment in the combination group, and also the insulin sensitivity index also improved, all again showing the same thing. So there are a lot of studies showing the benefit of vildagliptin over many different aspects, cardiovascular safety, renal safety, etc. So from this, what we can say is beta cell preservation and glycemic durability are very important in our patient, and starting very early on with dual combination helps in preserving the beta cell function and also reduces the macrovascular complications. And ADA, as I said, 2023 said, based on this trial result, they said dual combination even with very early diabetes and minimal HbA1c you start, that will be beneficial. Thank you.
Thank you. Thank you, madam. Thank you, Dr. Rajeshwari, for giving a detailed discussion on verified trial with regard to the durability of the medication and the preservation of beta cell function. Thank you. I think the session is now open for any questions.
Regarding I have a few questions. One is regarding the sulfonylurea. Is it wise to do insulin level estimation before starting sulfonylurea? Because if insulin is already in excess, higher insulin level, it may be atherogenic. So is it wise to do that?
See, a lot of patients early on in the pathogenesis of diabetes, when we see type 2 diabetes, they have insulin resistance, hence their insulin levels usually are higher. We are not giving insulin or sulfonylurea just because they have low insulin levels, correct? So, but we have to control the blood glucose, whatever they have, over and above that they require. That is the reason. So I don't think it is. But however, a long-term diabetes patients who require lots of medications, then probably there is a point in checking the not insulin levels, C-peptide levels to know the pancreatic function. See, in day-to-day practice, we cannot do any other, clamp studies. Definitely baseline, a C-peptide will definitely help us to know whether this patient, is there a point in giving a lot of sulfonylurea or directly go on for insulin.
Then second thing, why not use the combination of pioglitazone, sitagliptin and dapagliflozin, because all of them are having long life in one tablet, and metformin separately?
It is a good idea actually. We do that in our clinical practice. once a day drugs we can use. For example, Vilda is twice a day, we can combine with metformin. If sitagliptin we want to give as a one time, so sitagliptin with dapagliflozin and pioglitazone, this combination can be done, and we do use in clinical practice. Yeah.
Then last question, this supposing somebody is on dapagliflozin, EGFR is 32, and we start with that, and after 1 or 2 weeks it comes down to 23. Should we continue this dapagliflozin or?
See, the recommendation says guidelines, above 30 use it. But I see nephrologists will say they don't have problem, they will continue to use for nephro reasons. But for diabetes, if GFR is so low, it should be excreted first to have an effect, benefit on glycemia. So it's of no benefit. So below 30, I don't use.
No, once we start it, the EGFR comes down. Then should we continue?
Or initial drop.
Initial drop will be there. So only thing is.
Continue?
Yeah. So when we start someone on already EGFR very close to 40, I'll be really cautious to use, and also monitor them much more closer, like after a couple of weeks, and if it's not a significant drop, maybe it comes to 24, 25, within that 5%, probably I would wait for some more time if there is going to be beneficial for the patient. But if the drop is much more, definitely I would withdraw it. But in such a patient, we should explain to them, if this benefit is there for you, further loss can be prevented over some time, but sudden acute drop may be there. If it is too much, we may stop it.
One more point, this once we start this oral anti-diabetic drugs, the blood glucose comes to normal, but and then the urine glucose also becomes less. So then the urinary tract infection will be less common in those patients.
Right.
That's
so if someone comes with HbA1c of 9, for example, I said when we can start the combination drugs, but if the HbA1c is something like 9 or some, I wouldn't start them on a combination which has a SGLT2 inhibitor, because to prevent the infection. So first control with sulfonylurea or insulin if you require, and then once the sugars are better, I would be more comfortable adding a SGLT2 containing combination.
Thank you, madam. Thank you.
Thank you, Speaker and Chairpersons, for that wonderful discussion. I request both the Chairpersons and Rajeshwari Ma'am to collect our token of appreciation from the stage just behind me. So for the next session, the last session of Magna Endocrine Update 2024, I request the chairpersons, Dr. Rajesh Shukla and Shyam Sundar, to come on to the stage. Dr. Rajesh Shukla is a consultant physician at Chinmay Mission Hospital, Bangalore, and also he is a faculty for DNB General Medicine program in Chinmay Mission Hospital. And Dr. Shyam Sundar is a consultant endocrinologist at SS Persh Hospital, and also he is co-founder of Gandhi Adult Pediatric and Endocrine Skin Clinic. He has multiple publications to his credit. I request the chairperson to invite the first speaker for the next session.
So we move on to the last session, and we have a very important rather than a controversial topic, that is the artificial sweeteners in diabetes. So we have with us Dr. Harish Darla, who is going to give us the final verdict about that. And sir is a consultant physician in diabetes and endocrinology at Darla's Healthcare. Over to you, sir.
Thank you, Chairperson. At the outset, let me thank Magnacode, Dr. Anantram, Dr. Varun, and Dr. Laxmi for inviting me for this conference and academic feast. So we are going to talk, I'm sure we have heard quite a lot from morning. So we are going to talk about sugar substitute, or called artificial sweeteners. They are otherwise called non-nutritive sweeteners or high intense sweeteners as well. So we know that the world is going through an epidemic of obesity. Almost 40% of the world adult population is obese or overweight. and almost about 40 million children are also in the same category. So this is, because of that, the WHO has seen that whether can be any non-nutritive substance which by taking that can reduce the weight, but how much is it justified, or whether there are any side effects of this sugar substitute is what we are going to see. So the beginning is about 10,000 BC. The only nutritive substance was honey, which was called the queen. And we all know that some places where there was more snow and more cold, there were no bees there. So they domesticated bees, and honey enjoyed the legacy for about 4,000 years before we went into developing cane sugar. And in 6000 BC, we had the first refined sugar from India, which was exported elsewhere across the world. And then they started cultivating sugarcane. And sugar was quite precious at that time, and a lot of people started enjoying sugar to the maximum. And then comes the problem, as the doctors say that, oh, this is not good for you, this is a kind of poison. So what do we do? I mean, we have had sugar taken for a long time as a nutritive, but then it becomes a problem because of obesity. So why can't we let it go? What is the problem of letting sugar go? Is because it is as addictive as cocaine. So they have equated sugar taking and is an additive as much as cocaine. And there is a lot of emphasis which is given along with sugar or sugar products with cigarettes. I mean, if you look at the media, there's a lot of talk about a good food and nutritive substance which is laced with sugar but anything in excess is not good for health. So this is most commonly causing non-communicable diseases such as obesity, and obesity can lead to arteriosclerosis diseases. And again, we know that obesity can cause cancers. So there has been a lot of issues with sugar. So we all know that the sugar is quite an additive one. And if you look, you eat more sugar, the blood glucose spikes, and you need more insulin. And then you get an hypoglycemia. And again, those people crave for more sugar. So this is kind of a vicious circle. And if you look, an average Indian takes direct sugar about 19 grams per day, or almost about 140 grams per week. And this is much higher in a Caucasian population. So this is the amount of direct sugar is what I'm talking about, which is consumed by an Indian population on an average. So then comes serendipity, is nothing but you pleasantly surprised to find something new accidentally, which is beneficial. So what did they find? Yeah, a chemist was accidentally discovered a sweet substance because he forgot to wash his hands, and he was working in Baltimore a lab on coal tar, and he found that there was something sweet taste. And that is when he named this substance as saccharin, which was discovered as long back as 1879, which is the first synthesized non-caloric sweetener. So doctors at that point were prescribing it for more of weight loss because it didn't have any calories. It was as sweet or more sweeter than sugar. So they found that the people were started losing weight even in a non-diabetic patient. And the one who propagated it was Theodore Roosevelt, who was then the Prime Minister of United States of America, who was using this for his own weight loss. And there was a lot of talk about having side effects because of this saccharin. And then there was a talk to ban that one. Then he gave a statement, anyone who says saccharin is injurious to health is an idiot. And again, it was banned before World War I in 1912, but was revoked quite quickly. So then followed, the other things which followed were cyclamate along with saccharin combination, and there were reports of bladder cancers in rats. And they found out that the rats metabolize saccharin differently compared to humans. So there was no increased risk of bladder cancer in humans. And then it was immediately banned. Again, it was revoked. Aspartame entered the market, and others joined, such as sulfam-K, sucralose, and allulose. So sweeteners, they were told as referred as healthy substitute for sugar, being advocated in diabetics so that there is no sugar spike. And 50 years after the first discovery of sweetener, they found that there was a darker side to these sweeteners as well. So there are multiple research papers which are associated that somebody who takes high degrees of artificial sweetener are more prone to develop type 2 diabetes, heart attack, and stroke. So these are all, again, the other synonyms of artificial sweetener is high intensity sweeteners, artificial sweeteners, or non-nutritive sweeteners. So by definition, It's a high intensity sweetener, is a food additive which mimics sugar on taste. It is many a times more sweeter than sugar, so you need a very small amount to have. They do not contribute to any calories or only contribute to very few of calories, and it does not raise the blood glucose level. So this was quite useful in a diabetic patient as well. So when you look at non-sugar sweeteners, there are nutritive sweeteners which gives you calories such as sugars, modified sugars, sugar alcohol, or natural caloric. But what we are going to concentrate is more on non-sugar sweeteners such as artificial sweeteners or natural non-caloric sweetener. Natural non-caloric sweeteners is stevia. So when you look at what are the natural sweeteners, they are table sugar, honey, jaggery, agave sugar alcohols, and stevia. And artificial sweeteners which are synthesized are aspartame, asulfate potassium, saccharin, advent, and sucralose. So FSSAI, that is Food Safety of Standard of India, has approved these sweeteners in our daily products such as saccharin, aspartame, asulfate potassium, sucralose, neotim, and stevia. In India, they are all available. So when they are available, we need to know how much we can eat or what is the acceptable daily intake. So the concept was developed in 1961, and it is expressed in milligrams per kg body weight. So if it is consumed in the advisable limit, it doesn't cause any harm or no adverse effect is being noted. Based on the results, there is something we call as no observed effect level. Is when you take at that level, it doesn't cause any problem. For any molecule or any medication, normally when an animal study is done, they use a very high dose of that particular component to see if they form any adverse effect. But they take the minimum amount which is more physiologically useful. So when you look at no observed effect level, it is 100 times less is what is advisable or acceptable daily allowances. So what are the approved sweeteners? If you look at this asulfame, they are as sweet as 200 times the table sugar. Aspartame is about 180 times, but you look at neotim and advent, which is almost 20,000 times more sweeter than the table sugar. And then you require is quite high. I mean, 23 sachets of asulfame potassium, and I'm sure we are not going to eat that much of sweetener in a daily per day. So these are the products which are available, and sucralose which is available in India, is sugar-free Natura, Splendia. Then these are with the aspartame which is available as sweeteners. And these artificial sweeteners are also seen in your diet, Coke and Pepsi. Also it is used in mouthwashes, it is seen in toothpaste. So there was a short perception was looked at from the physician's point of view, how often would they use a natural sweetener. So they included most of the specialty such as general physician, internal medicine, endocrinologist, cardiologist, nephrologist. Across that spectrum they saw is how they would prescribe artificial sweetener. So the first question what was asked is, if they have to rate from 1 to 5, do you recommend artificial sweeteners to those who have weight gain related issues, who are non-diabetic? And if you see, 55% did not recommend an artificial sweetener at all. About 19.4% recommended on rare occasions, 22.2% recommended sometimes, but very few recommended mostly, and not that everybody recommended it every time. So the perception is completely different based on their what medical profession they are in. And the next question asked was, to scale between 1 to 5, do you recommend artificial sweeteners to person with diabetes as sugar substitute? Again, 47.2% would not recommend at all. 17.6% on rare occasion, 22.9% on sometimes, 8.3% mostly, and there are very, very small physicians who would recommend it always. And what was the correct indication for artificial sweeteners? I mean, obviously everybody knows that yes, it can be used in diabetic as an alternative to sugar, but yes, it is also been used for weight loss who are taking a higher calorie of sugar content. So 50% of those artificial sweeteners would not use that at all. About 9.5% would use as a weight loss in a non-diabetic patient. 25.7% would use in a diabetic patient instead of sugar, but 14.3% of the physicians did tell that they would use for both weight loss and for in diabetic patient. And they were also asked if they would prefer banning the sweeteners. Almost 43% said yes, but majority said no to that. So this is the perspective of the physician, which was done on a real world time. So what the WHO has come out with the use of non-sugar sweeteners as early as 2023. Now they have looked at, there is a group called Nutrition Guidance Expert Advisory Group, which looked at the prevention of unhealthy weight gain and diet-related non-communicable disease. And basically they looked at non-diabetic patient. So they did a meta-analysis of 283 studies. There were 50 were randomized control, 97 were prospective study, and 47 were case control study. Just a couple of words about these randomized control and prospective cohort study was, randomized control trial were done for short duration of time, anywhere between 3 months to 3 years. But prospective cohort study was done between 3 years to 30 years for follow-up was done. So that the results were completely different in both the groups. Now, I'm not going to go much in detail as how those non-nutritive substances they act, but it is also said that there are receptors which are different for the sweet compared to the artificial sweeteners. There are different receptors in the tongue. They also have receptors in the gut. And if you see that the way of weight loss with these non-nutritive substances are, they can promote the release of GLP-1 and GIP, because these receptors are also present in the L and the K cell of the intestine. So what was the outcome of those meta-analyses? They looked at certain parameters, such as whether measuring eating behavior habit, measure of adiposity, then measure of type 2 diabetes. Now, if you look at the randomized control and the prospective cohort, if you see that there was a less caloric intake in patients who were on short duration of study between 3 months to 3 years, but if you look at the incidence of obesity, those who were taking on a long term of artificial sweeteners and who were non-diabetic, there is a chance of 1.76% of gaining weight rather than losing weight. And also that there was a chance, a high likely chance of developing diabetes in future in the prospective cohort study. They also looked at the measure for CVD, they looked at measure for kidney disease and mortality outcome. Again, if you see, these parameters of systolic and diastolic did reduce in the randomized control study, but there was an increased incidence of ESRD or incidence of CKD in patients on prospective study, and there was an increased chance of mortality, about 1.19% in patients who were on a long term of artificial sweeteners. And when you look at the case cohort study, where basically they looked at the chances of developing in cancer, it was very low evidence, so there was not major chance of developing a cancer with artificial sweetener. So what does the WHO recommend is, non-sugar sweeteners should not be used as the only means for weight loss or reduction of non-communicable disease in a non-diabetic patient. So yes, they can use it, but that can't be the only way to lose weight. And then let's look at what a Cochrane review in a diabetic patient who takes non-nutritive substance. When they compared a non-nutritive substance with a comparator, as such as the table sugar, they found that when you use a non-nutritive sweetener, when they were compared with a placebo, the chance of having side effects was less in patients who were on non-nutritive substance compared to placebo. And again, if you look at the reduction in the A1C, no matter what you compare with non-nutritive sugar with sugar, or non-nutritive sweetener with placebo, or non-nutritive with low caloric sweetener, there was not much of change in the A1C in a diabetic patient. Again, weight loss, when you compare with the comparators, there was not much of weight loss, except when they compared non-nutritive sugar with water. Yes, there was comparison which was done with water as well. They found that there was a significant weight loss on patients who were on non-nutritive substances. So what does the American Diabetic Association give a statement? Is yes, it can, the use of non-nutritive sweeteners has the potential to reduce overall caloric and carbohydrate intake, provided that they don't take those calories from different substances or food substances. So you can substitute a sugar sweetened beverage with low caloric sweetened beverages, which might help to reduce the increase in the blood glucose spikes. Healthcare professions should always continue to recommend reduction in sugar intake and calories with or without non-nutritive sweeteners. Healthcare profession can regularly make sure that your patients don't take excess than what is being recommended of non-nutritive substances. And when you look at the American Heart Association, the statement they give is, when non-nutritive substances are used judiciously, it can facilitate reduction in added sugars and energy intake, and can also maintain a healthy weight and lower risk of cardiovascular diseases and type 2 diabetes. And again, a committee for adults who are habitually on high consumers of sugar sweetened beverages, low caloric sweeteners would be helpful to reduce the intake of sugar sweetened beverages. So this is my last talk is, yes, you eat less sugar because it definitely is a poison. Excess sugar is not good for your health. Thank you.
Thank you, sir, for that lucid presentation. So my question to you is for your comments on the effect of non-nutritive sweeteners on gut microbiome and the long-term risk of developing diabetes.
Now, obviously, a very good question, because it is shown that non-nutritive sweeteners does cause dysbiosis. Or what is dysbiosis is that there's an alteration in the gut microbiome. Gut microbiome is nothing but all the bacteria, parasite and fungi what is there as a natural in our gut. It causes dysbiosis, and there is a high chances when there is a dysbiosis, there is increased production of lipoprotein LPS, lipoprotein S, which can cause an inflammatory process. And again, that can lead to diabetes itself. So there is a short chain fatty acids which are produced also, which can be basically a food for the microbiome. Again, when you have dysbiosis, the ratio between a few microbiotas, such as Firmicutes and bacteroids, they change over. So that again leads to inflammation and can cause diabetes.
Yes, sir. Thank you, sir. Any questions from the audience?
Yes, madam, it can be used in acceptable daily intake allowances, what is advisable. So just because they are taking a natural sweetener doesn't mean that they can increase the calories in different food products. So just make sure that they take in an acceptable daily intake is what it can be recommended. Yeah. Yes, exactly. Yeah. It's all right, madam. Yes, yeah. Yes, yes, yeah. Because there have been a lot of issues initially causing that aspartame could cause brain tumors as well. Again, that has been negated by WHO with the studies. It doesn't show that there is increased chances in humans.
Is there anything you've read wherein among these sweeteners you would prefer one over the other?
Well, if you're going to ask me, the natural sweetener is stevia. Stevia is much better, much safer compared to the other artificial sweeteners which are available. That's a natural sweetener with no calories. No, madam. Probiotic is completely a different ball game. Obviously, no, you don't give it for dysbiosis caused by sweeteners. You don't give another one to rectify the dysbiosis caused by the sweetener, because that's a completely different ball game of probiotics. And even if probiotics have to be taken by a healthy individual, it is only, the recommendation is only about 28 days at a stretch you can take a probiotic, not more than that. Again, you don't want only the good bacteria in your body, because there should be a balance between the pathogens and the symbiotic bacteria which is required.
Okay. So thank you, sir. Thank you for the presentation.
Our next speaker is Dr. Dominic Benjamin. Dr. Dominic Benjamin is a consultant geriatrician, aging specialist, diabetologist for older adults. He's also the head of geriatrics at Bangalore Baptist Hospital, Bangalore. He has won a lot of awards and recognitions. And today he'll be talking about impact of herpes zoster on patients with diabetes mellitus and its prevention. Over to you, sir.
Thank you, Chairman, and thank you for the organizers for inviting me. I think we're going to switch gears, and we talked about whether sweetness has to be given or not given, but I wish we Indians are less sweet in our bloods and more sweet in our attitude, but that's a wish. Anyway, so we're going to talk about impact of herpes zoster on patients with diabetes mellitus and its prevention. If you look at the GBD publication in Lancet, diabetes is the 4th leading cause of disability, and diabetes is sweet cancer which licks and bites every part of your body. Okay, now it's topical to talk about vaccination. It's a shame that we have few people, but I think that's the way it is. I think one of the things that happened after Andrew Wakefield published his infamous article in Lancet about MMR and autism, there's been a strong movement of anti-vacciners, and that's got more pronounced during COVID, and there are people who were vouching for vaccine and people who were against vaccine. I'm going to make a case as to why in India we have to vaccinate. A bit of a data on health care spending. We know that India spends abysmally low, 1.3% of the GDP compared to 10% of the OECDs and 20% in US. So there's a health expenditure per person in India, and we know that per capita spending on health is lowest among the BRICS countries as well. Why did I put it up? I can't change the way India spends, but I can always use preventable things to prevent the infections. And we know very well that most of the older people have a double whammy of non-communicable disease and infectious disease. So if there's any chance that you can use a vaccine to prevent an infection, please do. Now, we know that diabetes is a brutal disease. It causes disability and morbidity and mortality. This study looks at the diabetes was the single most common cause of years lived with disability, YLD. It also predisposes one for CKD, and we know that it's one of the leading causes of death in patients worldwide. It also comes with a big tag of money that attached to it. It's quite a big price tag. It's quite expensive to treat healthcare burden in patient with diabetes. But look at this, as I mentioned to you, in 2021 we had 7.4 crores of Indians known diabetic. I'm sure that's the tip of the iceberg. And in 2045 it is 12.5. And as I mentioned earlier, I wish we could be less sweet in our bloods and more in our attitudes, but I think that's the way it is. Okay, 2.5% of global blindness is because of diabetes. So diabetes not only blinds you, it binds you to home, causing a disability, and it's a very pricey disease to have. And diabetes is a major risk factor for chronic kidney disease, which affects 1 in 8 in the global population. So it also predisposes to severe outcomes in many conditions like infectious diseases, vascular diseases, cancers, degenerative diseases, pulmonary diseases, and self-harm. I don't know whether this is of importance for you. The 3rd commonest cause of suicide in people above 60 in the US is herpes zoster pain. Okay, so I made a case to you saying that using a vaccination always makes sense. It makes economic sense in India because we spend abysmally low on our healthcare spending, and also diabetes is a brutal disease and it predisposes to infection. So if you can use any vaccine that can prevent infections, please do. So how does herpes zoster play out in patients with diabetes? And we see here, there's multiple studies which shows that incidence of herpes zoster in diabetic populations is higher compared to other non-diabetic patients, and risk of herpes zoster in those with diabetes versus control was quite high, relative risk was higher. So diabetes is an independent risk factor for post-herpetic neuralgia, increase the healthcare resource usage following herpes zoster episode, indicating that herpes zoster is most severe in patients with diabetes. It causes more morbidity, hospitalization, spending of money. Well, this is a study which is published in Rheumatology Journal. About 500,000 people were studied about. We know that diabetic patients have a high incidence of herpes zoster compared to healthy subjects in people between 51 to 60, 61 to 70, and above 71. What are the impact of herpes zoster? It is more common in diabetics, it is more often seen in diabetics, and it causes more post-herpetic neuralgia. What is the impact? What is the health impact? You know that 24% of well-controlled diabetics go off balance when they develop herpes zoster. And we know that there are high likelihood they get hospitalized, the length of stay is longer, they're more likely to be using more medications and other medication as well. And we know very well a lot of patients who are crorepathies become roadpathies, so you have a couple of admissions in the hospital. And thankfully we are so very good in sort of making them come down the socioeconomic ladder. But what is the risk of herpes zoster in different comorbid conditions? We know that herpes zoster is more common in patients with cardiovascular conditions, inflammatory bowel disease, obstructive airway disease as well. When you have different comorbidities added together, and it increases the risk. Look at this: diabetes plus cardiovascular disease 1.19, diabetes with heart failure 1.25, and COPD with heart failure 1.25. And this graph very clearly shows that when you have multiple comorbidities like type 2 diabetes and cardiac disease, your chance of getting herpes zoster goes up compared to patients who don't have it. What is the social quality of life effect on this? It affects one's walking ability, so he can't socialize, he becomes a loner. Relationship with others, he can't do any social gathering, he can't get back to normal work, his sick days are more than the working days, he's normally depressed and now feels gutted. General activities is normally sort of curtailed because of this. Enjoyment and quality of life is very poor. Sleep is also disturbed in patients with herpes zoster. What about health related qualities? Mobility comes down, he becomes more dependent, and he needs help for activities. Pain can be disabling. Anxiety and depression more common in patients who develop pain. And what is the impact of post-herpetic neuralgia in health-related diseases? We know that is mobility, self-care, usual activities, all takes a beating when you have a pain, acute pain in post-herpetic neuralgia. So what do? It's very common in diabetics. It makes them to spend more. It makes them more disabled. It makes them more sick and groggy and miserable. So can we do something about it? Of course we can. Shingrix has really transformed the whole landscape of adult vaccination, thanks to Amitabh Bachchan and also GSK. I mean, they sort of pitched it so well, and adult vaccination is in the forefront now. Now, Shingrix consists of herpes zoster. It's a recombinant vaccine. It has got glycoprotein E and adjuvant, which is sort of added to it. That sort of helps you. And we see here, it produces more CD4 cells, IgE specific, and B cells as well. And look at the response. It's quite a good response compared to with the vaccine without an adjuvant. Now, ZO50 and DO70 are the two studies which is done in people above 50 years, above 70 years, and they found the average people were about 16,000, and they followed them up for 3.5 years and up to 11 years, and they found more than 90% efficacy in giving 2 doses of vaccine for the lifetime. I wonder, are there any other vaccines that can give you that results? Now, this is what the breakup is. More than 50 is 97%, and even above 70, 97%. And we know that as we advance in age, your chance of getting herpes zoster gets worse. And they studied in ZO70 was in people above 70. And they found that even in patients above 80, there was 91% protection compared to without taking it. And what about efficacy on post-herpetic neuralgia? It's very good compared to not vaccinating them. Okay. So, what about patients with comorbidities with hypertension? It has got a significant benefit even if you're hypertensive, diabetic, coronary artery disease, asthma, respiratory disorders, or renal disease. Okay. Now, this is ZO50 and 70. We studied for 3.5 years, and there's a long-term follow-up up to 11 years, which has showed 87% efficacy over this time span. Okay. What are the adverse effects? The common adverse effect is pain, redness, and swelling. Of course, you can have fatigue, arm pain, which I noticed in a lot of my patients, and shivering. The younger you are, 50s and 60s, the more reaction compared to older people. Okay. Now, it is quite safe compared to placebo. The reactions are the same, nothing much. And it is indicated for prevention of herpes zoster, post-herpetic neuralgia in any individual above 50 years, especially if they have a chronic long-term disease and if they are diabetic as well. And it can be given, you're using one arm, make sure that you use the other arm, as we can use flu vaccine, pneumococcal vaccine, and Tdap vaccine as well. It's been recommended all across the world, and What's the summary that you need to carry home is there are more than 90% efficacy across age groups in patients above 50. There is a long-term protection that we have studied till now. It's a recombinant vaccine approved for use in adults above 50. It's quite well tolerated. Okay. Now, we know very well diabetes predisposes to infection because of its effects on the innate immunity and humoral immunity, and they're at a high risk, places them at a high risk for infectious disease in general, and definitely the herpes zoster and post-herpetic neuralgia. So vaccination is especially important, helping to protect against both direct and possible indirect effect. So these are the various recommendations. Okay, how do you vaccinate? You got to give the first dose on a 0, and then the next vaccine dose is between 2 to 6 months time. Okay, but in the studies it is more often 2 months, but you can give up to 6 months time. Okay, now just be careful if somebody is going to take rituximab. Make sure that you immunize them 4 weeks prior to the scheduled therapy, or wait for about 5 months till the immunity sort of got better and the immune effect is waived out. Or if somebody is on steroids, make sure that they are less than 20 milligrams to have a good response. Okay, so these are the guidelines. Okay, what happens if somebody has got a herpes zoster? Do you vaccinate them? Yes. Some studies shows give them after 4 months. Some says after 1 year. So, so it's quite a safe medication. Okay, why did I leave this the last slide? I'll give you a real life scenario. I had this gentleman from Coorg. He's always prim and proper. Unfortunately, he was going through a stress of his daughter's wedding, and he developed this lesion in his groin. And he thought something to ignore, and he didn't take much notice of it. And finally, he went to doctor because it's unbearable pain. And finally, it was treated. And after that, he's left with post-herpetic neuralgia. And he's not able to wear his pant because it is in L1 region. So this gentleman was prim and proper, bubbling and buoyant in life. He's now despair. There is existential despair. That is what it can do, ladies and gentlemen. And look at this. Yeah, herpes zoster pain can be more than the labor pain. I can't tell it. I know my wife told it's miserable, and a lot of people say this, but this is what it is. And look at post-herpetic neuralgia. It is horrible. It's absolutely horrible. And look at this. 88% of the patients at clinically significant pain, but 65% had severe pain, and 16% had unbearable, unimaginable pain. Pain is a tangible evidence of suffering. So if we can do something about it, we jolly well do. Summary. Numerous studies have shown that there's an increased risk of herpes zoster in diabetics compared to non-diabetics. And both the ZO50 and ZO70 trials have shown that it is very effective. And the various guidelines have accepted that. There's only one human disease that's been eradicated. It's a shame, isn't it? Hopefully by 2030 we would have eradicated 4 more. That's what Bill and Melinda feels, and I hope they come true. Thank you. And vaccination is for the older person, younger person, and make sure that you vaccinate your pets as well. Thank you. Any questions?
Any questions from the audience?
Sir, most of the times...
Oh, sorry, yeah.
So most of the times, it is when their partner is affected that they realize that yes, they have to be vaccinated. So suppose someone from the home has an acute herpes zoster. Can the household contacts get vaccinated at that point of time? Is it efficacious, or it is too late?
You can, of course. I mean, this is not, you can get vaccinated. Yes, of course you can. Yeah. But that's when it dawns on them what it is. Unfortunately. That's when they realize how horrible it is. And that's when they're more amenable to it. But it's too late, isn't it? Somebody has already had a problem, and post-herpetic neuralgia is absolutely devastating. And unfortunately, these are the ones who don't tolerate gabapentin or any of those pregabalins and things like that. So it becomes totally unlivable. So yeah. But you have a vaccine which gives more than 90% protection. I'm not sure about many other vaccines that can give this protection. And it's just 2 doses for a lifetime. So I would strongly appreciate if you could just keep this in your repertoire.
And if somebody misses the second dose, is it required to give the 2 doses again?
That's a good question. I never had this problem, but I suppose you just give another dose. Yeah.
this acyclovir and use of acyclovir and amitriptyline and tegretol combination, it prevents the post-herpetic neuralgia. And usually this disease is a self-limiting one. So is it necessary to vaccinate?
Oh my God! Okay, I think it is not a self-limiting one. I'm sorry. I can give you statistics from thing which saying that more than 30% of the patients experience debilitating. I use the word debilitating post-herpetic neuralgia. It is devastating, absolutely devastating. So I don't know where that you say it's not self-limiting, ladies and gentlemen. Sorry, gentlemen, it's not self-limiting. It's devastating. Now, giving the cocktail of amitriptyline, yes, it makes them dopey, and you know that amitriptyline predisposes to delirium, and this is more often seen in older adults, and they may have a anticholinergic effect and cause problem with bladder obstruction as well. So it is not the whole purpose of me coming here and giving a talk here to tell you it's absolutely devastating. It doesn't sort of contain itself at a particular time. I think a simple policy is that ounce of prevention is more than better than a pound of cure. So, yeah.
So Chief Minister of Karnataka lost power because of that.
Sorry, come again?
One Chief Minister of Karnataka lost power when he had
herpes ophthalmaticus. I'm not very in tune with politics, and so yeah, I think that's devastating. Herpes ophthalmaticus can be very devastating. And if you meet a person, as I mentioned to you one story of a person who's buoyant and bubbly and chirpy, becoming existentially despair, wondering why should I live, and it can be so devastating. Yeah.
So thank you, sir, for the engaging session. And next, I would like to call upon Dr. Aditya Hegde. So Dr. Aditya will be speaking upon new era in type 2 diabetes management, incretinize, individualize, Indianize with biosimilar liraglutide. That is what we are looking forward. And Dr. Aditya Hegde is one of the best endocrinologists in Bangalore and has 7 years of experience, and he has various awards, and his areas of interest is pediatric endocrinology, adrenal disorders, and newer developments in diabetes. Over to you.
Thank you. Thank you, Team Magna, for giving me this opportunity, and Anantraman, sir. So today I'll be speaking on the pandemic, if we may call so, of diabesity and how to treat that with a liraglutide biosimilar. So I think a few talks before did speak something about biosimilars. What are they? How do they compare with the originals? Can we use them? Do we have approvals? Everything. So I'll go ahead and start my talk. So, I think we have gone through a lot of slides where we actually saw the prevalence of diabetes and obesity. So diabetes is around 11.4%, and it's definitely going to increase. More interesting is pre-diabetes is already at 15.3%. And generalized obesity is around 28.6%, and abdominal obesity is 39.5%. Should I do something? Yeah, okay, fine. Then the most important thing is, if we take diabetes plus obesity, it's close to around anywhere between 60 to 90%. And these are all recent ICMR India studies. There is no exaggeration in this. So coming to this term called diabesity. So this was coined as early as in 1970s, but probably in the recent sort of years, we are seeing this explosive pandemic. So this is a serious metabolic consequence of obesity and type 2 diabetes, because we know that probably more than 80 to 90% of obese individuals are at high risk for developing diabetes. And why is it important? Because not only for the risk of diabetes, but also the risk of developing various other comorbidities, which include cardiovascular complications or other related risks. So, and we always should target both of them. Something which works both for diabetes and obesity eventually will be able to give a good result with respect to the future complications. And what are the comorbidities associated with diabetes? So we already know prevalence of MAFLD is higher in these patients. Increased risk of CKD anywhere between 50 to 66%. Prevalence of OSA, that was also spoken about, that is also way higher. And most importantly, prevalence of ASCVD, hypertension, dyslipidemia. So it's a continuum, and treating both probably will help us in reducing these, the burden of these complications. So the same thing, multiple common soil hypotheses like hypoxia, lipid imbalance, endothelial damage. So ultimately, the risk of CKD, ASCVD is going to increase with the prevalence of diabetes. So again, we are always backed up with sufficient guidelines. So what are the guideline recommendations for diabetes and obesity? So as I think Anantharaman sir also spoke, we have come way forward from a glucocentric approach to various sort of other approaches. The most common one what we have seen is, here we categorize them into three, that is type 2 diabetes with obesity. So among them, we look at agents which have a very high efficacy for weight loss. So the ones which fall in the very high category are semaglutide and tirzepatide. Here we are looking at somewhere between 20 to 25% of weight loss from the baseline. Then we have ones which high efficacy, that is dulaglutide, liraglutide, anywhere between 5 to 10% of weight loss from the baseline. And those which are intermediate, like simple GLP-1 receptor agonists, the one which are not included in the first two categories. And weight neutral, that is TP4 inhibitor and metformin. In patients with type 2 diabetes mellitus and MAFLD, so again, we have to consider the use of a GLP-1 receptor agonist, and I think in these patients, they score slightly above the SGLT2 inhibitors. And type 2 diabetics with ASCVD, so use a GLP-1 receptor agonist with a proven CV benefit in the trials, CVOT trials, or that is liraglutide and semaglutide, or SGLT2 inhibitor with a proven cardiovascular disease benefit. And one important change is, so as I told, we have moved from the glucose-centric algorithm. This is from the ACE. I think the guidelines are more stringent in ACE. So what they clearly say is, even if we individualize and even if the patient has achieved the target HbA1c, still we can consider switching on to the GLP-1 receptor agonist. And in fact, we can consider GLP-1 receptor agonist as a first-line treatment for a patient with type 2 diabetes with obesity. So probably even before metformin, if it is quite pragmatic. So very clearly, HbA1c, even if it is less than 6.5% for someone who is overweight or obesity, we can always prefer GLP-1 receptor agonist or SGLT2 inhibitor with a proven CV benefit. And even we can consider switching over a person with well-controlled HbA1c to a GLP-1 receptor agonist with a proven CV benefit. So coming to where does liraglutide play a role in the holistic management of type 2 diabetes? Are we going beyond glycemic control, and what are we looking at? That is, are we looking at any extra glycemic benefits of GLP-1 receptor agonist? So again, this is from the Indian NFHS data. So very clearly what they have shown is the combined prevalence of overweight or obese either in women or men. It has actually doubled from 12.6% to 24%, both either in men and women, which is quite striking. And as we know, with what they call a famous food famine to feast hypothesis. So as we have improved with respect to our, we have moved out of poverty and we have sufficient stores. So what they say is the pandemic of diabetes and obesity is only going to increase. So the states with the highest sort of per capita income, like Punjab and all those, they are the states which actually have are going through or grappling with this diabesity pandemic. So we have come out of one problem, but we are entering the next era. So coming to the studies, lot of busy slides. I'll try and give the gist of each slide. So this was the scaled diabetes randomized clinical trial. So one thing was liraglutide. I think all of us do know that the doses which were used for diabetes and weight loss were quite different. So 0.6, 1.2, 1.8 was which was used for diabetes, whereas the 3 mg one, which was called Saxenda, that was the one which was approved for obesity. So in this scale, diabetes RCT, they randomized patients to 2:1:1 of liraglutide 3 mg versus liraglutide 1.8 mg versus placebo on a baseline 500 kilocalorie deficit, dietary deficit, and baseline 150 minutes per week of physical activity. The endpoints what they were looking at were a relative change in weight, that is proportion of patients losing 5% of more or more than 10% of baseline weight, because we tell them that the endpoints we look at is at least a minimum of 5% of weight loss from the baseline. So what clearly they found out was liraglutide 3 mg, they had almost 6% weight loss compared to liraglutide 1.8 mg, which gave close to around 5% of weight loss, and compared to placebo, which was around 2% of weight loss, because we had a baseline MNT which was there. So very clearly, among patients with type 2 diabetes, 3 mg performed better than 1.8 mg versus a placebo. So again, this was another study which compared 2 or 3 parameters. So close to 200 patients, they were divided 1:1:1:1 with either a placebo with usual activity, exercise program plus liraglutide, that is 3 mg per day, liraglutide with usual activity and moderate to vigorous intensity exercise plus placebo, and similar endpoints, change in body weight and also change in body fat percentage with a DEXA. So again, very clearly across the 4 subgroups, the highest difference was seen in the combination group, that is the liraglutide plus severe intensity of exercise. And we can clearly see up to 9.5 kilograms of weight loss from the baseline, which is quite significant, because we know that even a 5% of weight loss does help the patients with control of diabetes, and many of the time we do say that there is a possibility of also remission in patients with just borderline diabetes. If they lose 5% of weight loss, they may as well go into remission. So this was one more interesting study, similar scale study, but this was done in obesity and pre-diabetes, because we know that we have 100 million diabetics, we have almost close to 150 million people with pre-diabetes. So again, this was around 3,000 patients who were included, and they were again subjected to liraglutide 3 mg per day versus a placebo. Similar endpoints, change in body weight and proportion of patients losing at least 5% and more than 10% of their initial body weight. Again, very similar results. So with respect to liraglutide, they lost, or the change in body weight was close to anywhere between 8 to 10%. And again, I'll reiterate that this was with 3 mg of liraglutide. So, and the patients who lost more than 5%, more than 10%, and more than 15% against a placebo, 5%, they were, it was close to 63% of patients, 10% close to 33% of patients, and more than 15% was 14.4% of patients when compared with a placebo. Again, the mean weight loss was anywhere around 5%, and maximum they saw was around 9 to 10% of weight loss. And this was low dose liraglutide in weight control among non-diabetics patient. So around 50 patients. This was a Taiwanese cohort. and they received a low dose liraglutide at 0.6 and 1.2 mg per day. This was not 3 mg. And again, what they saw was the change in the percent change in body weight was again close to 5 to 6% in either groups. So again, not only the 3 mg daily dose, even with respect to 0.6 and 1.2 mg per day dose, they did better. And again, liraglutide for obesity and people who are overweight, a very busy slide. So a lot of RCTs were included, and adults with obesity or overweight were chosen. So usually in Indian cohort, the BMI is taken to be above 23 or 23.5, not the usual BMI of more than 27 or 30. So across the spectrum and across the studies, liraglutide 3 mg, there was a mean reduction of around 5 to 10 kilogram of weight from the baseline. And again, as the prevalence of diabetes increases, we know that a lot of patients are ending up with non-alcoholic fatty liver disease. So I think now this is almost replacing alcoholic liver disease as one of the most common causes for progression to CLD or the need for liver transplant. So again, across the studies with diabetes or without diabetes, liraglutide versus placebo, liraglutide versus pioglitazone, which is known to have some benefits in NAFLD. So across the studies versus placebo or versus pioglitazone, again the graph is favoring towards liraglutide, and the mean reduction is anywhere between 5 to 10% of improvement in the markers of NAFLD or the other liver fat content measured by MRI, PDFF shift studies. And this is a meta-analysis of liraglutide in patients with NAFLD. Some were included diabetes, some included those who were non-diabetic also. So as I told, NAFLD was diagnosed with liver biopsy in some, MRI in some, MRI PDFF, that is the sort of chemical shift what they see. So across the studies, liraglutide 1.8 mg, liraglutide 3 mg on a baseline of metformin, what they clearly showed was the effect of liraglutide on liver fat did favor liraglutide. Though in some studies it did not reach the statistical significance, but definitely it did favor liraglutide. And we know how do GLP-1 receptor agonists help. So one most important thing is the gastric emptying, the portion size is reduced. It reduces glycogenolysis and gluconeogenesis. It does stimulate insulin release. And it works at a higher level to reduce appetite and also improve satiety. But what is the biggest problem? Access, because all of us do pay from our pocket. So where do biosimilars come in this? So we have this liraglutide biosimilar. So Glenmark is one which came up with this versus the reference biologics. And as we know, they always have to do a PK/PD study to show the bioequivalence. So across the various studies, they did prove the various area under curve, the T-half, and the other pharmaco-equivalent studies. What they showed was the results were quite similar. And also from the biosimilar phase 3 study, so liraglutide biosimilar versus the reference biologic. So the primary endpoints were the reduction in HbA1c, and the secondary endpoints, I'm sorry. Yeah. Just last few slides. So either with respect to the HbA1c reduction or with respect to the secondary endpoints like body weight, fasting plasma glucose, and postprandial glucose levels. So the results were quite similar, no significant differences. Safety data was quite similar, no severe adverse events which needed discontinuation. and the immunogenicity potential were quite similar. So definitely biosimilar was quite equivalent with respect to the original, and cost probably is almost 25 to 30% of what the original molecule was, and the DCGI has already granted the authorization. Yeah, and I think for the benefit of time, last few slides we'll try and skip. So one thing was, this was the evidence from the GRADE study. So what they did was, they took few endpoints. So they added glimepiride, glargine, sitagliptin and liraglutide to metformin, and the endpoints were one of the above, that is a glycemic deterioration, weight gain of more than 5%, and severe or recurrent hypoglycemia. So the risk of reaching the outcome was lowest with liraglutide and, as expected, highest with the glimepiride group. So to summarize, definitely it's not only diabetes, but diabesity is what we are more concerned. And SCALE trial has clearly demonstrated almost a 8 to 9% body weight reduction when compared with a placebo. Most guidelines have put GLP-1 receptor agonist and SGLT2 inhibitors quite high, especially those with proven CVOT trials. And biosimilar has demonstrated non-inferiority in phase 3 trials. And with the biosimilars, we have a good molecule with a lesser cost. Definitely with access and affordability being easier, we can think of adding or putting more of our patients on GLP-1 receptor agonists. Thank you, and I'd be open for more questions.
Thank you, sir, for the wonderful presentation. I have a question. So a person with a normal weight, okay, BMI of 22, with the ASCVD risk, so SGLT2 and GLP-1 will cause further weight loss. Which one you choose or you don't use? What is your take on that?
Yeah, definitely. One thing, Indians compared to Caucasians, I think that's a very famous YY paradox. BMI, they compared an Indian and a Caucasian. Both had a BMI of 23, but when they did a MRI and DEXA, both of them, when the fat analysis was done, the visceral obesity, and for the similar BMI, we were more obese and we had more insulin resistance when compared to our Western counterparts. So Indians, I think we are a separate sort of subset, Indians and Asians. So even for a similar BMI, I think we always have to keep GLP-1 and SGLT2 inhibitors even for a similar BMI, way above, especially given a background of ASCVD, no question. Someone even with a BMI of 22 with a background of ASCVD or CKD, definitely GLP-1 or SGLT2 inhibitors we'll have to consider.
In obese patients with CKD, what is the role of liraglutide when compared to SGLT2? Where would you place it?
Yeah, so very rightly said. We know that right now with the newer guidelines coming, we have molecules with SGLT2 inhibitors up to a EGFR of 20 probably can be used. We have some GLP-1 agonists where irrespective of the EGFR, they can be used, like the once weekly injections which are available. So liraglutide. So across the spectrum of CKD, we can use, except for those probably who are already on maintenance hemodialysis. So I think in these patients, probably safe to use GLP-1. And SGLT2 inhibitors with the latest guidelines, probably 20 is sort of a cutoff where until then probably we can use them judiciously.
Regarding the suicidal ideation with semaglutide, I think that's on the news of late.
Yeah.
So is it a class effect or it is just the molecule effect?
Probably molecule is what I feel. I don't think it is only limited to a class. And also retinopathy. Retinopathy, probably there were red flags, just like the insulin initially. It was related to probably the HbA1c reduction and all those. But still, yeah, someone with a background of established retinopathy, still, we have to be slightly careful.
Thank you. Thank you, sir.
Thank you.
Next speaker is Dr. Mohan Raj. He'd be speaking about basic surgical and medical management of diabetic maculopathy. Dr. Mohanraj is an ophthalmologist, and he has over 16 years of experience, and he has completed his MBBS from BMC and his MD from AIMS Delhi. He is also a consultant vitreoretinal surgeon at Dr. Agarwal Retina Foundation. Over to you, Dr. Mohanraj.
Good evening and welcome to the last talk of the session. I know you all are very eager to go back to home, and I will finish it as quickly as possible. And diabetic maculopathy is a microvascular complication of sustained hyperglycemia. So sustained hyperglycemia will lead to various pathological changes within the retina, which leads to an inflammatory like condition and accumulation of fluid and other changes which occur inside the retina. So incidence is more among non-insulin diabetic patients because they are more aged and their coping mechanisms are very limited. Whereas proliferative changes are very pronounced in these young insulin dependent diabetics. And diabetic maculopathy is seen in almost 10% of the patients with diabetic retinopathy. So the risk factors are, one is the duration of the diabetes. Longer the duration of the diabetes, more is the chances that you are having diabetic maculopathy. And level of hyperglycemia. The more is your HbA1c, more is the risk of you developing diabetic maculopathy. And the other systemic conditions like hypertension, hyperlipidemia, pregnancy, then chronic kidney disease, nephrotoxicity, all those things lead to more risk of developing diabetic maculopathy. So as soon as we identify a disease and try to manage that, the first tendency is to classify them. So earlier, the first classification was given by the ETDRS group, which classified it as clinically significant macular edema. It was called clinically significant because it was bound to progress and lead to loss of vision. So they divided it into 3 groups based on the location of the retinal thickening, hard exudates, and the size of the thickening. And subsequently, this was more complex and it was more confusing both for the ophthalmologist and the physicians who used to refer cases of diabetic retinopathy to the ophthalmologist. The International Council for Ophthalmologists came with a simpler classification depending on the location of the macular edema, as center involving macular edema, where the central subfield 1 centimeter or 1000 micron around the foveal involvement as central one involving macular edema, and outside this 1 millimeter zone as non-center involving macular edema. Though this was easier to classify and remember and refer and manage, it did not consider the changes which used to happen inside the retinal layers. So subsequently we came up with another classification known as TSED HFV guidelines, where intraretinal changes and vitreoretinal interface changes were also taken into account, and which were based on the OCT. OCT is nothing but optical coherence tomography, where we get a section, histological section like picture of the retinal layers and various pathological process, ongoing pathological process within the retinal layers at order of several 5 to 10 microns. So it's almost like looking at a histopathological slide. So based on this TSED guidelines, foveal thickness, interretinal cyst, then ellipsoid zone, photoreceptor integrity, external limiting membrane integrity, then hyperreflective foci, number of hyperreflective foci inside the retina, and disorganization of the inner retinal layers, and presence of subretinal fluid, and changes occurring in the vitreomacular interfaces. All these were considered, and subsequently it was classified as early diabetic maculopathy, intermediate diabetic maculopathy, severe diabetic maculopathy, and ultimately the end stage foveal atrophy. So this is currently in vogue, and it gives us a clear picture as to the prognosis of the condition and the duration of the condition and the severity of the illness. So once you classify and we consider the patient for management, first we investigate them by doing various studies, look at the macular perfusion, then the thickness and these OCT biomarkers, and the duration of the illness, how the patient is systemically controlled. And once you assess the patient, you have to tailor make the management of this condition. And first and foremost, we have to treat the cause. The cause for diabetic maculopathy is unstable systemic condition. One is raised blood sugars, raised serum lipids, then hypertension, and other metabolic parameters like homocysteine levels and sometimes in pregnant ladies also, and nephropathy. So medical therapy consists of, first and foremost, you control the blood sugars. We would advise the patient to maintain the blood sugar levels below 7 HbA1c of 7%, and blood pressure is also below 130/80 of 80 mm of mercury, and management of CKD, and management of lipid profile, and anemia. Basically, the main driving force of diabetic maculopathy and proliferative diabetic retinopathy is hypoxia. So anemia, because most of the diabetics have got CKD, and usually they end up with very severe anemia because of CKD, and that itself will worsen the disease. So this also needs to be corrected, which leads to better outcome and better response to therapy. So this is one paper from PGI Chandigarh where they have shown very good results and we have also clinically seen once the lipid profiles are controlled, the perivascular lipid exudation and exudative maculopathy responds very magically to treatment. And these patients respond very well to steroids and the newer anti-VEGF agents. And if you leave them like that, ultimately the natural history of the illness is the retina goes into thinning. Once the retina thins, it means the cells which support the retina, there are a lot of different cells which process the visual impulses and send it to the brain. They are lost and the quality of the vision reduces. Ultimately, the lifestyle of the patient takes a hit. And once you medically manage the patient, and next option is laser photocoagulation. This was the first therapy which came into the management of diabetic retinopathy as such, including maculopathy and proliferative diabetic retinopathy. It was serendipitous discovery that the ophthalmologist who saw patients who developed choroiditis and developed scarring of the retina did not develop the severity of diabetic retinopathy when compared to patients with normal retinas. So they thought, why don't we scar the retina by means of bright light or other means? So they started using cryopexy. They started using sunlight focused by means of magnifying lenses, and ultimately they came with krypton laser, argon laser, and now we have got double frequency Nd:YAG laser, and now we have got yellow laser, which is supposed to produce minimal collateral damage and equal outcome when compared to the older forms of laser. So patients who come early to us with very limited involvement of the illness and good perfusions of the macula and good visual acuity, they respond very well to the laser. Suppose if there is minor retinal thickening, you treat them first with any of the pharmacotherapeutic agents, and then you treat them with laser, and laser gives a very continuous, sustained response. And in a country like India, where financial burden is a big issue, the patients do well for a long time. Once you laser them and once they continue to control their blood sugars well, they do well without any recurrence of the illness for a long time. And subsequently, this is a picture where you can see patient has got cercinate exudation. This is basically, there will be a lot of microaneurysms which have lost their pericytes. Once there is loss of pericyte, they start leaking fluid. And all the intercellular and intracellular junctions are all compromised. They start leaking fluid. And this fluid is continuously pumped out by the Muller cells. But whatever the plasma components which are there, that is the protein and the lipids, they start accumulating in the form of a ring. So these cercinate exudates, ultimately they encroach onto the macula. You can see how they are spreading towards the macula. And ultimately they cause drop in vision. So what we do in laser is, there are two modes of treatment. One is you do a focal laser. You target those leaking microaneurysms which you identify either by clinically or by doing an angiography, and you burn them off. Once you burn these microaneurysms, the leak stops, and eventually whatever this lipid exudation and protein exudation that is there, that gets absorbed, and the patient does very well. Suppose these hard exudates extend onto the fovea and they get organized, the outcome drastically changes. The patient will go into moderate to severe vision loss. Then, as I've already told you, diabetic retinopathy is, though it's metabolic, there are all signs of inflammation. Like metabolic syndrome, this is also a kind of inflammatory process set inside the eye. There is tumor, that is swelling. There is rubor, there is engorgement of the vessels and bleeding. And there is functionalessa, there is loss of function, which Celsus had defined thousands of years ago. So we have two kinds of steroids. One is Kinocort, triamcinolone acetonide, and other is dexamethasone sustained release implant. Kinocort is a very cheap drug. It costs around 100 rupees and works equally well as the dexamethasone implant, which costs you around, I think, 25 to 30,000 rupees. Though the difference is too much, the only difference between the two drugs is the triamcinolone acetonide comes with a first order elimination, means it takes a long time to get eliminated. Whereas the dexamethasone implant has been designed in such a way that it follows a zero order kinetics, that every day a specific amount of drug is released. For example, if you give triamcinolone acetonide, the normal dose is 4 mg. So, but around 40 days it becomes 2 mg. Then the next 40 days it becomes 1 mg. So, sustained release. So, it takes a long time to get cleared. And suppose the patient develops any of the complications related to steroids like glaucoma or cataract, it is difficult to manage them. So, you will have to wait till the drug is really manage them medically till the drug is gets absorbed, or you have to surgically remove the kinocot. But with the dexamethasone implant being zero order kinetic, it's a 700 microgram implant, and daily around 5 micrograms of drug is released. But still in our clinical practice, we use both of them depending on whether the patient can afford or not. And still we can, we give low, now the studies have shown that even half dose kinocot produces similar effect as 4 milligram kinocot, and patients do well with both of the medications. And personally, I can show you one patient who developed a diabetic macular edema, which is center involving, with a lot of intraretinal biomarkers appearing. With one injection of dexamethasone implant, the same patient which I have shown the photograph, the swelling resolved very well, and the vision improved from 6/18 to 6/6 parts. So the patient did very well, and subsequently we did little focal laser, and the patient is doing well on subsequent follow-ups. Now, then subsequently these intraretinal growth factors like vascular endothelial growth factor, angiopoietin, and platelet-induced growth factor, all these factors also play an important role. And there are a lot of such factors which are now being studied closely. And this bevacizumab was a drug which was used in patients with tumor, basically colonal cancer, which inhibited angiogenesis. So they gave a try that let us see how it works inside the eye, because vascular endothelial growth factor is one of the chief driver of diabetic retinopathy. So the patients with diabetic macular edema and proliferative diabetic retinopathy responded excellently. So subsequently they refined the molecule and brought about another fragment called ranibizumab, and now we have got 3 or 4 anti-VEGFs in the armamentarium which blocks additional factors like angiopoietin and placental induced growth factor. There are various treatment protocols, and this is one of the patients treated with ranibizumab. This is a very good response, but the response need not be always like this. The response depends on one, duration of the illness, the extent of the damage inside the retina, and the systemic control of the patient, and the irreversible damage which has set inside the retina, because sometimes once the cell loss has happened and fibrosis sets in with glial proliferation, they don't respond well, and the vision also does not improve. So the key is early recognition and early treatment. The problem is, one is the financial burden. These drugs are very expensive. So we have to tell the patient that there is a certain time limit before which the treatment has to be initiated. And if the patients are not willing, we can go with other options like this steroid and laser photocoagulation. Then once all these things come out, then we have got all these drugs act inside the retina. There is another aspect to diabetic maculopathy, that is the vitreoretinal interface. So this is a very complex layer where the vitreous and the retina are attached to one another by means of various glycosaminoglycans and chondroitin sulfate. These products undergo a lot of changes because of glycation, and vitreous also undergoes a lot of oxidative changes and undergoes liquefaction and tries to separate from the retina. So once there is liquefaction, there is a tendency to separate. Once there is glycation, there is a tendency to attach. So the separation and attachment will lead to something known as traction. There can be focal traction, then formation of membranes. So this can be classified as vitromacular adhesions and vitromacular traction, then epiretinal membrane formation, then lamellar hole formation, and ultimately full thickness macular hole formation. Here you can see some hyperreflective intraretinal foci with vitromacular adhesions. The posterior hyaloid is trying to separate from the retina, and it is not able to separate because of the firm adhesion. And these patients, once they develop macular edema, they respond very poorly to any medical therapy because there is a physical mechanical traction which is acting on them. So we need to relieve the traction if at all they have to respond to any pharmacotherapy. So what we do is we directly not do any surgery. We give a trial of 1 or 2 injections. Suppose the response is not as per the expected lines, we advise the surgery and remove the membrane, and subsequently they do extremely well once the traction is removed. So if you don't treat them, some patients do progress into the next stage called vitreomacular traction. From adhesion, they go into something known as traction. Once the separation tendency increases, they pull the retina and cause separation of the neurosensory retina from the underlying layer. So if you leave like this, ultimately they progress into full thickness macular hole. So this is a definitive indication for surgery. It is one of the leading cause of vision loss in diabetic patients. So this is an epithelial membrane because there are micro breaks in the internal limiting membrane, and glial cells migrate onto the surface of the retina and cause again traction, the membrane, which causes tractional macular edema. These swellings also respond very poorly to any pharmacological therapy. These also need to be removed. And subsequently, some of them progress into partial thickness lamellar holes. You can see separation of inner and outer retina, and partial thickness hole, and continuous photoreceptor layer. These patients have good vision because the photoreceptor layer is intact, but suddenly they develop drop in vision because there is retinoschisis. So retinoschisis is split in the neurosensory retina. So all the circuits of the neurons are broken, and suddenly they develop vision loss, and they don't respond after surgery. The vision recovery is not there. Anatomically they do close, but the vision recovery is very poor. So we have to intervene in these patients very early. So ultimately, some patients, a part of patients go into full thickness macular hole. This is also a definitive indication for surgery. So some of our personal experience, this is a patient with epiretinal membrane. You can see a patient in the right slide, you can see there is an epiretinal membrane responding very poorly to injection. Subsequently, we removed the membrane and the patient returned to normal. From 624 vision, he returned to 69 vision. So this is how the surgery is done. So go inside the eye, clear all the vitreous. You stain the posterior membrane. This is a little faster mode. It is twice the normal speed. So carefully we peel off the membrane, and we have to peel off the template also. The underlying internal limiting membrane is the template on which the epiretinal membranes grow. So if you leave the internal limiting membrane, the membranes continue to tend to recur. So you have to remove both the membranes, and once you remove both the membranes, this is the earlier patient. So they respond very well to the surgery. So this is another case of lamellar macular hole. You can see multiple membranes. One is the posterior hyaloid, one is the epiretinal membrane, there is a lamellar macula. So these pathogenesis can coexist. Multiple pathologies can coexist in one macula only. So the treatment is same. You go inside the eye, carefully peel layer by layer, you peel the membrane, and the patient improved from 636 to 6/9. This is how you peel. So once you go inside the eye, layer by layer, you stain each layer. Each layer takes up a different stain. So first layer is the hyaloid layer. You stain it with tricot dye. So it stains the layer. So you separate the membrane from rest of the attachment and carefully peel. You can see nicely the membrane has been stained by triepsilone acetonide. So you have to trim from other attachments, because the area we are working is just a small 500 micron area. If you pull them, it will cause a iatrogenic macular hole. So carefully trim the layer. You can see the traction. Once you try to pull, just a focal attachment. The area of attachment is not more than 100 microns. So once you trim this membrane, then the subsequent layer you have to stain again with BBG dye, brilliant blue dye. So this attachment is a pathological attachment. Posterior hyaloid attachment to the ILM is a pathological attachment, but the attachment of ILM to the underlying retina is a physiological attachment. So it easily separates. So the risk of creating an iatrogenic hole is very minimal. So once you trim the vitreomacular traction, carefully peel the internal limiting membrane, which is a physiological layer. You can see how beautifully it separates from the fovea. Once it separates, you achieve the separation and the maculopathy resolves. So the other kind of diabetic maculopathy is thick-taut posterior hyaloid. Again, there is glycation of posterior hyaloid membrane, and it causes thickening of multiple layers. The previous one was a vitreomacular traction, but the layers were not thickened. But these are more thickened and more adherent because there is a fibrovascular proliferation. So as these patients are the ones with proliferative diabetic retinopathy. So when they are having proliferative diabetic retinopathy, there is upregulation of VEGF, vascular endothelial growth factor. So as soon as the vascular endothelial, as soon as the disease burns out, there is a fall in the levels of vascular endothelial growth factor, and TGF beta increases. So TGF beta is associated with fibrosis. So they go into malignant fibrosis. So once they go into malignant fibrosis, such a kind of picture is seen, and the management is very similar. You go inside, layer by layer, you stain and peel, and ultimately you get this kind of picture, and the patient improves in vision. And suppose some patients go even into more severe malignant this you can see, this is a kind of fibrosis. The patient has got a tractional macular hole. The previous one is a simple macular hole. Post laser, the patient has developed macular hole. This is also treated by removing the membrane, and the patient membrane goes away and the vision is restored. And subsequently these patients have tractional macular hole. These are the ones which go into permanent vision loss if you don't treat them early. So once you go inside, remove the membrane, fovea comes back to its shape and vision is restored. And these are the more malignant ones. You can see how you cannot make out the structures at all. You cannot see the disc, you cannot see the macula. Its entire thing is closed. It's called crunch syndrome. It's gone into a crunch, napkin ring like crunch. So this is also treated by means of laser. Go inside, remove the membranes carefully, and the patient resolves well. So to summarize, so diabetic maculopathy is a complex disorder involving the intraretinal layers, retinal surface, and the systemic condition of the patient. And hence you need a tailor-made approach to manage this condition, which you have to assess the patient and then plan the further course of action. Thank you, sir.
Thank you, Dr. Mohan. What is the cost of anti-VEGF drugs?
It depends on which brand. We have biosimilars, which cost around 20 to 25,000. Then we have ranibizumab, which is the parent molecule. It will cost you around 35,000. Then you have aflibercept, which will cost you 70,000. Then you have Pagenex, which will cost you 50,000. And Vabysmo is there, that is just recently come into the market. It will cost you 90,000 rupees. So it depends on the company. So most of them produce similar action, but some have got additional benefits, like Vabysmo blocks, apart from VEGF, it blocks angiopoietin also. And then aflibercept irreversibly blocks the VEGF and it blocks PGF also, platelet-induced growth factor. And ranibizumab is a long time trusted molecule without any serious adverse events. So it has been in vogue for almost 10 years and it is working still well. So sometimes patients develop tachyphylaxis over long-term treatment. They develop antibodies to these antibodies, monoclonal antibodies. So they stop responding, then we shift to other molecules. And if they are not responding to anything, we give them steroids, because steroids are pan-suppressants. They suppress everything, arachidonic acid, these growth factors, everything. And if they are not responding to steroid also, then we do laser.
Thank you, sir. That was really wonderful talk, and very nicely you elaborated the different types of maculopathy and the treatment options available. I thank you for your presentation, sir. So with this, I think we conclude this wonderful session and the entire days of activities, and I hand it over to the organizers.
Yeah.
Thank you.
Thank you, chairpersons and speakers. I request you to collect your, our tokens of appreciation, please. Then. So, we have come to the towards the end of the conference. So, I first would like to thank all the delegates, especially sir, who has stayed till the end and have participated actively throughout the conference, and the speakers and the chairpersons who have made time on their busy schedules on a Sunday in Bangalore traffic, and our Magna team who have made this possible, and along with that also the industry members who have supported us throughout the conference. Thank you all.